Right. Good morning, everyone. It's 31st January 2026. I'm greeting you from Hull, and I think we will start the third World Day of Regional Anesthesia and Pain Medicine. Uh, Thank you for choosing our event for your World Day celebration today. My name is Jacob Kazda. I'm going to be taking you through the program today. I'm one of the coordinators alongside with Dr. Balaji Pakianatasamy. I am a consultant anesthetist with interest in regional anesthesia in Hull University teaching hospitals. Uh, for those who are not familiar with UK geography, Hull is on the east coast in the northern England. It's a busy tertiary center covering adult and pediatric services. I am a consultant, so we have a large volume of and quite high involvement in regional anesthesia across multiple locations and multiple ways of application. Before I take you through the program, I'm gonna pass the word to Dr. Balaji to say a few for you.
Hello everyone, I'm Dr. Balaji Pakianataswamy. People call me Balaji, that's very easy to do. I'm very thrilled to see 130 delegates for our online program where the common theme is equity, access and relief in the regional anesthesia world and pain medicine. Thank you very much all the attendees for your time to come for our meeting. It's not a new thing for us. We have done this World Regional Anesthesia Day at the outset, at the beginning when it was started. We did it face to face, but this time we are doing it online, and with the success probably we might do it next time face to face. And it's a honor for us to host on this occasion, and many thanks to the ESHRA team and ESHRA President Eleni, as well as Nura Lucas, who is the project lead for WDRAPM World Day. And given an opportunity, I hope I and Jacob, we worked hard by getting local speakers as well as international speakers to make it more entertaining and more informative and helpful for the trainees, and also for some candidates who are taking YEDRA ESRA exam. I'm one of the examiner, and all this program has been pitched in such a way it will be helpful for you guys for part 1 or part 2. Welcome you all. I will leave it to Jacob to tell about the whole program. Just pay attention to what he tells, and there's a quiz at the end, which we encourage all the trainees to participate on it.
Right, thank you, Balaji. Right, I'm gonna show you a presentation of mine I prepared about the program. And I'm going to talk you through some of the points of the program and tell you how the program is structured, and tell you about a quiz as well, which has some exciting prizes. So I hope you can all see my presentation. Am I right?
Yep.
Very good. So the first half an hour we have dedicated to welcome messages and undressing. So grab a coffee, relax, and enjoy some of our precious guests, which will be joining us in a few minutes. At 9:30, we will start the scientific program, and we will open with we call the Evidence Club. We will cover some top papers in regional anesthesia and top papers in pain medicine. It's a very dense block, so be well caffeinated, because there's going to be a lot of information packed in these two presentations. After that, after each session follows a Q&A, which is joined for all the presentations in each session to keep it concise and to stick with the timings. So after Q&A for session 1, we will proceed with session 2, which is titled The Power of Free Innovation, Equity and Rescue, and we will have 3 clubs. We will talk about the innovations in the delivery in regional anesthesia, in the technology, and about AI decision tools. We will talk about the relief. We will describe our local process of management of patients with thoracic trauma. rib fractures and how we approach it here in Hull. And we will close with the Rescue Club, and Dr. Daga will tell us about some troubleshooting when the regional anesthesia is not working as well as we want, which unfortunately happens to all of us from time to time. After that, we will take a quick lunch break, and we will proceed with session 3, which is titled Beyond the Block, and we will discuss some maybe more niche topics in regional anesthesia. So I'll have a quick topic about regional anesthesia beyond the operating theaters, which is a modern topic, and it's constantly expanding. It's a very dynamic field. Dr. Sanem will tell us about some transitional pain services, which is again very fashionable wave in pain medicine. We will cover obstetrics and pediatrics as well. So very exciting topics there. In regards of the mentioned quiz, the quiz will be actually launched 3 times during the day. So it's going to be at 1 o'clock, 2 o'clock, and 3 o'clock of British time. You can get through the quiz through this QR code. I'm going to put up the presentation during the coffee breaks and the lunch breaks as well, so you can scan the QR code later. It's going to take you to 25 MCQs, which will test your knowledge across the whole spectrum of regional anesthesia, and the top 3 highest scoring participants can win the free access to the Ezra Congress in Lisbon in September 2026.
Nous ne pourrons pas être avec vous aujourd'hui,
a very nice prize.
Mais nous serons très heureux de prendre connaissance des conclusions de vos échanges.
And of course,
Et à ce
we will ask you for your feedback for this event. As Dr. Balaji has mentioned, this year we have opted for an online platform, but I think in the future we might go back to the face-to-face. So if you have any comments or if you would like to share some pro tips about how we can deliver more experience and more talks to you about regional anesthesia from our center, then we would definitely welcome your feedback. Again, like I said, I'm going to put up these presentations during the break, so you can scan the QR codes later and get yourself to the quiz and get yourself to the feedback forms.
L'image d'échographie. Et puis, je vous montrerai aussi à un moment, quand je demanderai une image d'anatomie, pour bien comprendre 2-3 éléments hyper importants pour pouvoir scanner facilement comment s'appelle la région interscalinique. Donc la région interscalinique, elle va intéresser quoi? Elle va intéresser toute la grosse traumatologie du membre supérieur, quand on a des gros traumatismes, on ne peut pas mobiliser le bras du patient. Eh bien, c'est plus facile de faire de l'interscalinique, tous les blocs qui sont au-dessus de la clavicule, que de faire Ezra le bras pour faire des blocs axillaires. Et puis c'est surtout, première indication, c'est l'épaule. Donc on a vraiment l'épaule, après toute la grosse traumatologie du membre supérieur. Donc là, je vais prendre cette sonde linéaire, juste pour l'orientation et pour commencer sur l'orientation, j'ai ma petite épine qui correspond à mon logo, et donc je vais mettre tout ce qui est la partie médiale du jeune homme, ce sera sur la partie gauche de l'écran, d'accord? Et puis après, toute la partie latérale du jeune homme, ce sera sur la partie droite de l'écran. Donc on va commencer. Un élément que moi je trouve très important, on va attendre ensuite encore ce que je trouve très important pour faire l'ensemble des procédures que l'on a, c'est d'avoir des repères anatomiques. Je vais vous montrer là sur la diapo, on va passer sur la petite diapositive si c'est possible. J'attends de l'avoir arrivé. Elle est au pro, donc on la voit. Vous allez sur cette petite image d'anatomie un vaisseau, qui est un gros vaisseau, et sur le côté, normalement, vous allez retrouver, je me déplace, vous allez retrouver, pour la voir, vous allez retrouver comment ça s'appelle, l'ensemble des structures, nerveuses. Donc c'est hyper important, vous voyez, on voit très bien la première côte, donc c'est hyper important de se prendre la première côte et les vaisseaux repères. Et à partir de là, vous allez pouvoir tout décliner et tout balayer de la partie très distale de votre région interscalinique jusqu'à la partie très proximale. On va pouvoir repasser sur l'appareil d'échographie en transition pour pouvoir bien comprendre. Donc là, on repasse sur l'écho et on va retrouver ces éléments dont on parlait juste là. Donc on a
Jack, it might be
cette petite flèche.
I think it may be a pleasure to introduce Dr. Ram. I think he might be there in the group, and he is the pioneer in regional anesthesia from Hull. Dr. Ram, if you want, you can put the camera on. And he was instrumental in getting the first face-to-face Regional
Donc là, on
Anaesthesia
a
Day in
vaisseau,
Hull for
plexus
Yashra,
latéral, et quand on est ici avec
and
la
he
sonde
was
qu'on
one
fait
of the
avec la
organizers
luxation, on met
who brought it to
la sonde
block it
très vers
live
les pieds. Et quand on
Regional
a la
Anaesthesia
sonde très vers les
program in
pieds, on va
Hull from
tomber directement sur la
2007.
première côte.
Dr. Ram?
Of course, I'm very pleased if Dr. Ram is here. I'm not sure he's expecting to be called up to the stage, so I'm not sure he'll be willing to join us. But if you hear Dr. Ram, we would love to hear some.
Yeah, I think if you take your
from you.
presentation out, I think I don't know, you might
Sure.
be able to show his face up, and he might pop in to say hello to everyone.
Quand on fait des blocs.
Dr. Ram, I don't know whether he's listening or.
He might not be ready to appear.
But at the end, we can introduce him and felicitate him. Yeah.
I've noticed Dr. Nuala Lucas has joined us now. Good morning. Do you hear us, Dr. Lucas?
Hi.
Nuala, yeah.
How are you? How's everyone?
Oh,
Yeah,
all
very
fine,
well.
Nuala.
Thank you.
Yeah.
Good.
Thank
So
you very
Dr.
much, Nuala, for giving an opportunity to present the world.
Oh, there's Balaji. Hi,
Regional-
Balaji.
Yeah, World Day in Regional Anaesthesia and Pain Medicine at Hull. Yeah, please introduce yourself. That would be good. You're
Fantastic.
the chair and the lead for that one. Yeah.
Okay. Hi, everyone. My name's Nuala Lucas. I'm an anaesthetist in the UK. I mostly do obstetrics, which I hope everyone would agree is part of the regional anaesthesia family. And this year, I've been involved in organising World Day of Regional Anaesthesia and Pain Medicine. What can I say to all my friends and colleagues in Hull? Well, look, it's a pleasure and a privilege to be with you all, even briefly today. And I'm sure if I could see all your faces, there'd be some familiar faces. So hello to you, particularly those who I know. World Day, I think, reminds us that we're part of something much bigger. You know, while we're here together today, teams across the world are also meeting with the same aim, sharing skills, improving access to good pain relief, and making care safer for our patients. Different systems, different pressures, but a shared purpose. And, you know, I've always say we always have much more in common with each other globally than we might first imagine. I took a look at the programme today and it really looks exciting and very innovative. I think we all know that this isn't simply about blocks in theatre. It's about regional techniques in emergency care, intensive care, perioperative pathways, and of course, POCUS, and examining how we can really fit and absolutely embed regional anaesthesia into modern perioperative practice, the whole picture. I saw only glanced at it, so apologies if I'm misquoting, but I saw a very nice systematic review in anaesthesia when I was browsing the journals in an abstract way. And it's one of Karim El-Boghdadli's latest systematic reviews, but the suggestion that I got from the headline is that regional anaesthesia seems to be the major factor affecting perioperative outcomes when you're looking at analgesic uses across the board. So yeah, perhaps a systematic review to look at, but certainly at first glance, very supportive of how important regional anaesthesia is. So what else can I say? Let's be curious. Let's be generous with ideas, as you've been generous with your time today. And I think, you get to a certain point in your career where it's difficult to, learn or assimilate loads of new knowledge. But I think if you leave today with one new skill, one new thought, or one new connection, the day will have been worthwhile. So huge thanks to the organisers for putting this on, particularly on a Saturday. Thank you to you for being here, and have an absolutely wonderful World Day of Regional Anaesthesia and Pain Medicine.
Thank you, Dr. Lucas. We appreciate it. As a chair of the whole event, you must be very busy, so we are very, very pleased that you were able to join us for today.
Well, look, have a really wonderful day. I hope it's not raining with you. It's absolutely pouring with me. But yeah, look, have a good day.
It's actually sunshine in Yorkshire.
Okay, sunshine in Yorkshire. Okay, Yorkshire's pulled out the stops for World Day. Okay, have fun, everyone. See you all soon.
But the problem is we are going to miss the sunshine, though, because we are going to be inside this one.
Oh, I'm sorry. Yeah. I'm so sorry.
So look, it's okay.
It's for the greater good. It's the greater cause.
Equity, access, and relief.
Absolutely. Yeah, you're on it. Yeah. Okay. Take care, everyone, and see you soon.
Thank you again. And I would immediately follow if we have Dr. Eleni Moka to join us.
Do you want me to text her? I can see whether I don't know what.
I've seen Elsa connected, so I'm hoping that they would be ready. And she just disappeared from the conference. Maybe there's some connection issues on their side.
Yeah, she has come now.
Oh, very good. Yeah.
Yeah, I think
now better.
Hello, Eleni. Good morning.
Good morning, Eleni.
Oh, good morning. Can you hear me? Can you listen to me?
Of course, we can hear you. We can see you now.
Ah, perfect.
Well,
fantastic.
Welcome, Eleni. Just a small introduction. Yeah, Eleni is Yashra president, and it's a honor, Eleni, to host the World Day of Regional Anaesthesia and Pain Medicine in Hull via virtual one online. Please give your wonderful words about this meeting.
Thank you, Balaji. Thank you, the team in Hull, for joining us in this huge, massive activity, mammoth activity, I would say. Today, we gather in almost 200 cities, coming from more than 50% of the countries across our planet. And we have more than 800 experts in Europe and across all continents, teaching, educating, spreading the news, spreading our theme, which is equity, access, and relief. Equity, access, and relief in regional anesthesia, in perioperative care, in safe practice, and in chronic pain medicine, because all these elements are fundamental for an holistic care of our patients. And this is where we should focus. We have the tools in our hands. We have the knowledge in our hands. What we probably miss, because we miss something, is the advocacy. And we have a lot of society supporting what we do, what you do, your streamings, your transmissions, your lectures, your workshops, and so on. The most important is that we have the passion and the energy to make our vision a true reality, because we don't want barriers, we don't want boundaries, geographical, cultural, structural, whatever these are, because we want equality in care for our patients. Congratulations from my heart. not only as the president of ESRA, as Eleni, your colleague, who will continue to offer in the fields of regional anesthesia and pain therapy. Thanks a lot to all of you. Thanks a lot to the sister societies, to the organizations that have endorsed the activity, and to the World Health Organization that has understood the importance of our initiative, and they have supported us with very, very strong messages. Good success from my heart, and enjoy the day.
Thank you, Eleni. We are thrilled to say that almost 130 delegates are registered for Hull online virtual one, which is even face-to-face, we got only 30 or 40 when we started at the beginning, which shows the appetite from the delegates for the regional anesthesia, particularly the theme which you have chosen, the equity, access and relief, which I'm hoping we are going to do the justice with the program, what we have endeavored today. Thank you very much, Eleni.
Thanks a lot. Thank you. Enjoy
Thank you very
your
much.
day.
And see you in Lisbon.
See you in Estra first in March and then in Lisbon.
Okay.
I think I committed to Lisbon
For
already,
another wonderful activity. Thanks a lot.
Thank you. Thank you again
Have a
for
great
joining us.
day. Bye-bye. Good success to all.
Bye-bye. I think at this stage, it deserves to thank the whole Ezra and the sister societies as well for organizing this, again, massive global event where we can meet each other and network. As both Eleni and Nuala said, we are here as a group of convinced regionalists who appreciate the impacts and the benefits for our patients. But as anesthesia is being sometimes quite a lone specialty, it is sometimes a little bit tricky when you're standing alone in the theater and you have to fight all the barriers, including the surgeons sometimes, to be allowed to deliver what you are strongly convinced is the best care to your patients in the form of regional anesthesia and pain interventions, of course. So it's nice to have the opportunities to support each other, to share the experience, and to network and maybe spark some new ideas and bring the whole subspecialty forward. So as I said, our scientific program starts in about 7 minutes. So you have a chance to grab a quick coffee, get yourself refreshed, because the first couple of sessions are going to be really dense. So stay sharp and stay focused. And I'll see you in about 7 minutes back.
Hi, Eleni, can you hear us?
But if you have a small, inefficient recovery room, very soon it becomes overwhelmed and blocked with the of
Le petit pectoral.
And we have
and appreciating them.
C'est votre
Years ago, that we need to
Right, we are, excuse me, we are ready to start session 1. So our first session, the Evidence Club, will start with the top papers in regional anesthesia from 2024-2025. I'd like to invite Dr. Harry Murgatroyd from York and Scarborough Teaching Hospitals. Harry is very well known in our region. Everyone who has trained, especially in East Yorkshire or the whole Yorkshire, knows Harry is a very keen regionalist. Harry, the place is yours.
Yeah, thank you very much, Jacob and Balaji, for inviting me to talk at this, the World Day. Let me just wrestle with the technology a second. Right, okay.
Yeah, we can see
Very
your
good.
presentation.
Okay, so I'm going to talk about my top regional anaesthesia papers from 2024 and 2025. But I would say that there is also, if you go to the website for the World Day, there is a number of pre-recorded lectures as well. And there's a good one on this exact topic from Steve Coppens. And he talks about his favorite papers from the last few years. But he interestingly, he says this is all very personal because there's obviously a lot of papers, and the papers that appeal to different people based on your own background, you know, what you're interested in at the time, or problems that you've come across, or something that just sort of tickles your fancy. So the lists are very personal. And if you watch his, I mean, it's only about 7 or 8 minutes long, but he goes through a few of his favorite papers. And as you can see on the slide here, he talks about this paper that was presented at RA UK in 2024 about epidural analgesia during labour and severe maternal morbidity, because that's quite a profound paper if you want to have a look at that. But like I say, I work in a district general hospital. I'm a generalist with an interest in regional, and I'm interested in running our service safely, effectively. I'm open to new procedures, but they sort of have to be pragmatic, you know, things I can actually do with the resources that we have. And I don't want to compromise on things like safety and training, ideally. So these are papers that I've come across in my practice or searched out to answer specific questions that have come up. But I guess first, more generally, if there were a couple of papers I'd suggest, well, a couple of editions actually that I'd suggest are worth seeking out. There is a whole special edition in the BJA from May 2024, timed to coincide with that RA UK conference in London, edited by Alan McFarlane, the chair of RA UK. Some really interesting articles in this edition. There's an editorial about pressure of injection and nerve damage, questioning the whole relationship there. There's a research priorities paper, which was a Delphi survey of regionalists to decide their future directions for research. And at the bottom there, let me just choose a pointer. Is the pointer there? Let's see. I don't know. Yeah, anyway, at the bottom there, there's a paper on using prophylactic dexamethasone for rebound pain in regional anaesthesia. So a good few interesting articles there. Additionally, from February of last year, there's a special edition of RAPM, which is all about chronic post-operative pain. And a whole load of interesting articles in there. I guess it just, yeah, like I say, it sort of just interested me at the time. There's articles about the biology of chronic pain, amputation pain, the role of regional anaesthesia in preventing post-op pain, long-term post-op pain. It touches on other medications as well, non-regional, things like ketamine and magnesium. And there's a couple of articles there about transitional pain services, which aren't a big thing in the UK. I can see in our program actually that there's a talk later on about transitional pain services. So I think it's something that's going to probably come to us, because bridging that gap between the outpatient and the inpatient, the acute pain and the chronic pain, there's a lot of potential there. So that's another good special edition that I'd say would be worth checking out. Now, this is, I'm actually slightly cheating because this is actually just published this month, but I think it's worth talking about. Like I say, I'm looking for articles that I would use in my own practice. Now, one of the issues we have, as I'm sure everyone else does, is that the surgeons don't necessarily want you to do a block because they say it ties up the list, slows everything down, blah, blah, blah. So anything I can use as ammunition to say, well, actually, this is best practice and we should be doing blocks is great. So this is an update of the prospect guideline about hallux valgus repair. The last update was in 2020. And this is a good stick to beat the surgeons with, because again, it highlights that the first line for post-op analgesia is the ankle block, preferred over popliteal, I guess because of foot drop. And although it says that infiltration is good as an alternative, first line is the ankle block. So yes, a stick to beat the surgeons with. The other things that are covered in this paper are IV dexamethasone, which I think was probably in the previous edition, and we often use it anyway, don't we, for post-op nausea and vomiting. Also, this article is another nail in the coffin for liposomal bupivacaine, as again, on review, they say that it doesn't actually make a great deal of difference. And that's fine, because I mean, I don't think we're going to get that anytime soon. So no skin off my nose. This is an article from last year about the PENG block, or the pericapsular nerve group block. It was first described in 2018, but one of the original authors here, Professor Peng, looked back at the evidence from the last 5 years. So this is all of the studies that were stimulated by his initial publication. And it's a narrative review, and I do like a review that tells a story rather than blinding you with too much in the way of numbers. About half of it is about anatomy and cadaver studies, which I wouldn't necessarily follow individual cadaver studies. To have a really good comprehensive review is great, and I'd recommend, if you're interested, to have a look at this review. About half of the other half of the study is about the clinical studies that have happened since the original publication, and also about new horizons, like where we might be going with PENG blocks in the future. So just to briefly touch upon the cadaver studies, this is a picture from the article comparing 10 mils versus 20 mils in a PENG block. And you can see with 10 mils, it's very localized along that ridge of the iliac bone there, just at the top of the anterior capsule of the hip joint. But if you go up to 20 mils, the spread is quite considerable, both cephalad and caudad, and medial and lateral. And this may explain that despite the original description of the PENG block showing that it's a muscle sparing, basically there's no femoral nerve block, so it's one that might be surgeon compatible. Subsequent studies have shown that there is a rate of femoral nerve block, or at least quadriceps weakness after PENG blocks. And this medial spread might explain that. It also might explain this caudad spread, may well explain why we've found that it works quite well for intratrochanteric fractures, whereas you'd think that if you were just anesthetizing the capsule, you wouldn't necessarily cover the intratrochanteric region. So the next slide. Oh yes, they showed this as the mechanism potentially for getting femoral nerve block and quadriceps weakness after a PENG, and you can see that there's potential local anesthetic spreading through the muscles or through the intramuscular septi, or back up the needle and then causing a fascial block. But I think the most interesting thing they talked about wasn't anything to do with this. They said that there's some studies that showed that local anesthetic infiltration leads to quad weakness, as does the surgery or trauma. So it's not even necessarily that the PENG block has caused femoral nerve weakness. It's just that having some sort of procedure done causes the patient to be reluctant to recruit as many muscle fibers as they would do in their sort of post-op setting. So it's not necessarily the PENG block, is what they're saying, that's causing this quadriceps weakness. Moving on to the clinical studies, certainly in my practice, I use the PENG block quite a lot for hip fractures. They reviewed the evidence behind the utility in the pre-op setting for positioning for spinal anesthesia and for post-op analgesia. And we know in the first two settings that the PENG block is better than placebo, probably comparable with the fascial block. And then in the post-op analgesia setting is probably better than the fascia-iliaca block. Now, total hip arthroplasties, I've never done a PENG block for a hip arthroplasty, so I was quite interested in their review of the evidence so far. They quoted a study that compared the PENG block to extensive local anaesthetic infiltration. The people doing that study were hoping to show that the local anaesthetic infiltration had a lower rate of quadriceps weakness. What it actually showed was that the PENG block was inferior in terms of analgesia. So local anaesthetic infiltration is better for pain relief. And that's probably understandable because the local anaesthetic infiltration is a PENG block, but it also covers the posterior capsule as well. So kind of makes sense. But really interestingly, they found that the local anaesthetic infiltration actually caused more quadriceps weakness than the PENG block. So the PENG block was better femoral nerve sparing than the local anaesthetic infiltration. So it's a bit of sort of a slightly muddy waters there. But I guess overall, you'd say that probably the local anaesthetic infiltration is equivalent-ish. It's a bit difficult to say. Now, I don't use PENG blocks in total hip arthroplasties, but there's been some studies looking at adding a PENG block to local anaesthetic infiltration. And I had never even knew this was a thing because, like I said, I thought the local anaesthetic infiltration kind of was a bit of a PENG block, sort of. But there have been studies, but they showed a statistical but minor and short-term clinical benefit, which, to be honest, in this article, they kind of talked it up quite a lot, but I'm not sure it's going to change my practice, if I'm being honest. The final indication is for hip arthroscopy. We've actually stopped doing them in York, so I don't have a great deal of personal experience with this. But my understanding of the evidence was that PENGs were quite good for hip arthroscopies because a lot of the pain is from distension of the capsule. But in this review, they say that that's not really the case because a lot of the post-op pain is actually due to extravasation out of the capsule and also due to those sort of extreme leg positions they get the patient into while they're doing the while they're actually doing the surgery. So it may well be that both are true, that if you don't get extravasation, maybe the PENG is useful. And if you do get extravasation, then it actually isn't stuff that the PENG covers. So it just isn't that effective. One thing that wasn't touched upon at all in that PENG review was adjuncts. Now, I'm going to talk about two papers from 2025, both from the same team, about using perineural dexamethasone. This first study was aiming to look at the duration of block and opiate sparing. And it was a 60-patient randomized controlled trial comparing two groups of total hip replacements. One group having 20 mils of ropivacaine in a PENG, and the other the same, but with 4 milligrams of dexamethasone in the block. Both groups having a plain opiate-free spinal and no local anaesthetic infiltration. So really relying on the PENG. And these are the results of that study. You see the PENG block on this left-hand plot, the PENG block time to first opiate rescue, which was their primary outcome, is 9 hours. And with the dexamethasone addition, it's 16 hours. And on the right-hand side, the 48-hour opiate use in morphine equivalents with the PENG block is 2.1. So really low anyway. I mean, that's super low. But the addition of the dexamethasone brought it down to 0.9 on average. So even lower. What's also interesting on this right-hand graph is that there's so many patients where they had no opiate use in the post-op period at all. That's 27% in the PENG group and 60% in the dexamethasone group had no opiates in the post-op period. And just to remind you, that's a opiate-free spinal with no local anaesthetic infiltration. They showed that there's no difference in quadriceps strength between the two groups. Of course, there's no control group here. There's no local anaesthetic infiltration or no local group. Now, the other study by this same group was looking at whether you can use dexamethasone to reduce the volume of the PENG block that you're giving. And I guess this might be a pandering to the surgeons and in their hope that we don't cause any quadriceps weakness. So again, it's a 60 patient randomized controlled trial comparing 20 mils PENG versus a 10 mil PENG, but with the addition of dexamethasone. I wonder if there's actually a bit of crossover between the groups, because between these two studies, because the protocols are very similar. So these are the outcomes that they had, pretty similar to the previous study, actually. So the time to opiate rescue is 9 versus 15 hours. 48-hour opiate consumption was a bit more. The PEN group 5 milligrams on average, and the DEX group 2.3, and opiate-free recovery 30% in the PEN group and 60% in the PEN and dexamethasone. Again, no intrathecal opiate and no local anaesthetic infiltration. And the weakness is, as I kind of touched on, there's no control group and there's no systemic dexamethasone group. And a lot of us would be using systemic dexamethasone just as routine. But in these sort of pilotish, smallish studies, they've not included a systemic dexamethasone group. But it kind of points the way that dexamethasone may be one of the blocks that dexamethasone is useful as an adjunct for. There are also a number of protocols that were published. I've actually pulled this off the clinical trials website, but it was published as a trial going forwards. This is the PENG block versus intrathecal morphine in total hip arthroplasties. So maybe this is the way that the PENG block might find its way in total hip arthroplasties, in that we might be able to use it to avoid other analgesic modalities that have other problems, like the retention that you get with intrathecal opiates. Now, changing tack completely, this study was published in RAPM in 2025 about post-op follow-up of patients once they're discharged by either automated text messaging or a telephone call. Now, I was interested in this and sought it out because it's potentially applicable in our clinical practice at York. We're in the process of moving to new digital platforms, both in pre-assessment and virtual ward for patients discharged, day case patients. And also we're getting a whole new medical records system. I mean, it's going to be chaos. But anyway, it might be a good time to try and introduce something like this into all of our systems. And this is all in the time of NAP8. I presume most people are UK attendees. So NAP8 is coming to us fairly soon. I've just filled out my the initial survey, and it seems pretty plain that one of the suggestions is going to be that we should be more proactive with our patient follow-up. Our patient follow-up at the moment in York, and I'm sure this is probably the case in a lot of places, is that the patient is given a patient information leaflet with a contact number, which they immediately lose. And the first time we hear anything about post-op neurological problems is when they go to the surgical outpatients, and then the surgeon gets in contact. So I was interested in this study, despite it being about continuous regional anaesthesia. So this is about patients they're sending home with a catheter in. I know some places do this. I think Hull does it, for example, don't you? But we don't send anyone home with continuous regional anaesthesia, certainly not at present. But because this is so much more complicated in terms of follow-up than a single shot, it, for me, sort of shows proof of concept. If it works for something more complicated than our single shots, then it should work for us. So the study itself, they had a phone call group versus an app group, 91 patients, and they were followed up daily. What happened in the app group is that the patients were sent a WhatsApp message 3 times a day with a link to the app. When they follow the link, they answer this online questionnaire, which then goes to the acute pain team, highlighting anything that's been flagged. And the phone call group, they're phoned up by a resident each of these days, and the same survey is gone through. On the 3rd day, both groups were called to confirm that they'd removed the catheter. The team that did this study were particularly interested in showing that it was usable, and they used a standard assessment of usability for the app, and they wanted to show that patient satisfaction was comparable between the groups. And they did show that. It was shown by this standardized method. It was shown to be usable and comparable patient satisfaction between the 2 groups, with a fantastic compliance with a 70 to 80% return rate. And that's 60% of patients completing all 3 days as well. So that's actually really pretty good. But the standout thing for me was that the reconsultation rates differed quite markedly between the groups. And what I mean by that is that's patients going to A&E or patients phoning up to the pain service for advice. And the phone call group was quite low, 6.7%, but the app group was 28.3%. So they looked into why this was the case, and they found that the vast majority of these calls were initiated by the patient, telephoned in with a non-urgent query or minor events, and most of them within the first 24 hours. A lot of them seeming to concentrate on sort of symptom interpretation. And I guess that makes sense when you think about it, because when the patient is called, then it's a 2-way conversation, and these little niggles can be answered. Whereas if they're filling out an app on their own, with the patient's knowledge of medicine and medical things not being as good as our own, it will actually probably generate more questions for them and actually sort of almost prompt them to call in just to double check or to address any queries that they have. So maybe that's not surprising. But overall, they found that there was no difference in complication rates, hospital visits, or admissions. So great, it's sort of proof of concept, really. The weaknesses of the paper, there's no estimate of time or cost of either arm, but I guess we'd have to say that the phone call group must be more expensive because it's got a resident set aside to phone these patients every day for 3 days afterwards, and I don't know how they do that over the weekend. And I guess by its nature, it's very app specific, because if your app is designed badly, then the patient satisfaction rate is not going to be as good. However, like I say, it's proof of concept that such a thing is acceptable to patients and seems to have no difference in terms of outcomes. So just moving on to the last, I'm actually running out of time. Oh dear. Anyway, just moving on to my last thing to talk about. This is from the Canadian Journal of Anaesthesia in 2025 about local anaesthetic dosing for fascial plane blocks. Now, we've not actually had any problems with this in York, but we have to recognise that there's a larger number of fascial plane blocks than there used to be, and also we're using them a lot more. In the last few years, we've got a rib fracture service now, and a neck of femur fascial block service, sometimes with catheters, and the surgeons are citing rectus sheath catheters and tap blocks. And these are large volume blocks of potentially a large dose of local anaesthetic, often given to our frailest patients, if you think about the fascial iliaca block. So this review, again, it's a narrative review, tells a nice story. It's got a good basic science overview, so if there's any trainees watching, it's a good review of the basic sciences of local anaesthetic action, pharmacology, pharmacokinetics, and talks a bit about the mechanism of action of fascial plane blocks. It's also got a good review about LAST, actually, if you need to top up your knowledge about that. So saying it's a narrative review, it does have some systematic elements to it. They did detail their search criteria, and they kept it really pragmatic, which I really like. So they talked about everything in terms of actual body weight rather than going to lean body weight, and that's because most of the studies and most practitioners day to day don't use lean body weight, they use actual body weight. And they limited their search to the drugs we actually use, so ropivacaine, bupivacaine, and levobupivacaine. And they converted, from all of the papers they looked at, they converted all of their percentages and volumes just down to milligrams, so they could all be compared. So these are quite busy diagrams, but I'll take you through them. On the left here, we have the abdominal wall blocks and the fascia iliaca block, and on the right, we have the thoracic wall blocks. And the x-axis is the local anesthetic dose in milligrams per kilogram. And on the y-axis, you have the fraction, which is the maximum plasma concentration of local anesthetic divided by the known toxic plasma concentration. So when it's 1, the plasma concentration equals the toxic concentration. So the interesting things to take away from here are that this is the TAP block, and you can see it's much steeper than the quadratus lumborum and rectus sheath blocks, so that if you give higher doses with the TAP block, you're going to get a higher plasma concentration, even at doses of, say, 2 milligrams per kilogram of bupivacaine, the recommended dose. And I guess with the fascia iliaca block, we have to remember it's your frailer patients that we're giving it to, and sometimes combined with surgical local anesthesia as well. So something to watch out for if you're a person who gives these higher doses. Sorry, that's the fascia iliaca line there. Another thing I was interested in was the timing of this peak concentration. Are we getting to the point where we're not seeing the peak concentration? So that all of these blocks on the left-hand side, their peak concentration is 30 to 45 minutes-ish. So that's, if you think about it, you've done a fascia iliaca block in the anaesthetic room for surgery, is when they're doing the 30 minutes or so will be when they're doing the cementing. If you've done it on the ward, that's when you're leaving. And if you've done it in theatre, that's when you've sent them out of PACU. So we actually should probably hold on to our patients a little bit longer. On the right-hand side with the thoracic wall blocks, far fewer studies, very safely below the line though the local anaesthetic is absorbed much quicker, like 5 to 10 minutes. But I find that reassuring, because when I do a block for a rib fracture, I will usually keep them in recovery about half an hour, by which point they're in a safe place. Now, I don't normally add adjuncts to peripheral nerve blocks. They're usually they have been associated with nerve damage, and not necessarily any advantage. So I don't normally do it. But actually, fascial plane blocks are different. No target nerve per se, and there's a higher absorption from that high vascular sort of surface that you're injecting into. So this study showed that that any dose point adding low adrenaline reduces your peak plasma concentration. So the main take-homes are that they give a few updated actual body weight dosing recommendations. Remind us that if you're using a high volume, you have to lower the concentration, and that probably we always use too high a concentration and too high a dose anyway. We can probably get away with a lot less. The reported toxicities, most common blocks are the erector spinae and TAP blocks, but this is the tip of the iceberg, because there's actually quite a lot of other blocks where the plasma level is too high, but we don't get a clinical syndrome. And what was missing? Well, the PENG block, unfortunately, because it's just too new. No one's done any of the studies on the pharmacokinetics of a PENG block. So I hope this has been useful. In the spirit of the Plan A blocks, I've tried to present papers that have been about the blocks that we actually use. And I've talked about the papers that have actually been of use to me in the last couple of years, addressing problems and questions that we've had in my practice as a consultant at the District General Hospital. So thank you very much. I will hang around for the Q&A. Jacob.
Thank you very much, Harry. That was an excellent presentation. It sparked a lot of thoughts in my head, and I already have a lot of ideas about questions, but I'm going to leave them for the appropriate section. before we move on to the next presentation, in the Q&A section of the webinar, I'm going to be popping up some questions for the wider audience. So please have a look and give us your opinions. Now we're moving on to the top papers in pain medicine from 2024-2025, and I have a panel for this. So there's going to be Dr. Nimi Soundarajan. She's very well known in Hull and in Yorkshire and around the whole UK for her excellent work for pediatric anesthesia, and she has a special interest in pain as well. And she has invited other two colleagues, Dr. Tanmoy Malik and Dr. Dinesh Soundarajan as well. So the floor is yours, Nimi.
Thanks, Jacob. I'll just share my screen and then we'll choose this. So, sorry. Does this now? Can you see? Can you see, Jacob?
I can see, yes, but it's not in the presenter mode.
Is that now?
Yeah, it is, yeah.
Yeah, okay. So good morning, everyone. I'm Nimi, consultant anesthetist at Hull and a member of the acute pain service. So DK and Tan and I, we present our choice of papers in pain medicine over the last year. So the first paper that appealed to me is a paper from the Netherlands that describes the implementation of an intrathecal morphine protocol and assesses its impact on the quality of recovery using an obstetric quality of recovery questionnaire. Now, this questionnaire is called the OBS-QOR 10 Dutch scale because it enables scoring from 0 to 10 for 10 parameters, and so the maximum score is 100 points. Moving on, just trying to move. Okay. So in our trust, we've been using intrathecal diamorphine for cesarean sections for over 2 decades. However, we are forced now to respond to a shortage of diamorphine by substituting it with preservative-free morphine. And therefore, the objective of this paper resonated with me. The objective is to assess the effects of implementing intrathecal morphine for cesarean delivery on the post-operative quality of recovery. So this is a single-center observational cohort study for which ethics approval was waived. So in this before-after observational study, there were 2 groups, the pre-intrathecal morphine group and the intrathecal morphine group, which is after the implementation of the protocol. So the patient data was extracted from the electronic health records, and all patients completed an OBS-QOR questionnaire 24 hours after the cesarean section. So in both groups, the patients received a spinal anesthetic with hyperbaric bupivacaine. The intrathecal adjuvant was what differed. In the pre-ITM group, it was left to the discretion of the anesthetist, and there was a variation in the choice and dose of the adjuvant. So adjuvants used were either fentanyl, sufentanil, or clonidine. In the ITM group, the protocol was standardized, and the adjuvant used was 100 micrograms of preservative-free morphine. The only difference in the standard of care provided for the 2 groups was the post-op modality for managing rescue pain. In the pre-ITM group, it was either IV-PCA or epidural infusion, whereas in the intrathecal morphine group, ITM group, it was oral morphine. Monitoring standards were the same in both the groups. For low-risk patients, the sedation score and the respiratory rate was monitored 2-hourly, whereas in high-risk patients, they had continuous pulse oximetry. Naloxone was readily available for both groups. The primary outcome was the OBS-QOR score 24 hours after cesarean delivery. However, they also studied secondary outcomes that included subscores and side effects. So the statistical analysis showed that at least 41 participants were required per group. And the number of patients in both groups were comparable, as you can see, and neither group had instances of respiratory depression. The ITM group had better OB score scores, but only by 6.3 points. In addition, the patients in the ITM group had reduced pain scores and required less opioids. However, they reported a higher incidence of nausea and itching. So the strength of this study is that it shows how implementing a standardized protocol with intrathecal morphine performs in an actual healthcare setting. However, this study was not randomized, and the ITM group included more scheduled or elective cesarean sections. So for anesthetists considering the transition to intrathecal morphine like we are, this paper provides valuable information about the standardized dosing, quality of recovery, and standards of care. So this QR code will take you to this open access paper. Moving on, the next paper that I chose is related to opioid stewardship. I'm always looking to balance optimal post-op pain relief with reducing the risk of persistent, with the risk of PPOU. And I'm curious about the risk factors that can be controlled by clinicians. So the objective of this paper is what resonated with me, and that is to find the risk factors for PPOU amongst perioperative processes and patient-reported outcomes that are pain-related. So PPOU is, to expand it, persistent or prolonged post-operative opioid use, and this is defined as at least one opioid prescription within 90 days post-discharge, and another one between 91 days and 180 days. So this is also a prospective cohort study, and this analyzed the data which was obtained from nearly 1,900 surgical patients in 31 German hospitals. Regression analysis was used to check the association of various factors with PPOU. So the study had ethics approval, written consent was obtained from all patients who participated, and they filled out a QIPS outcome questionnaire on the first postoperative day. So the variables that were analyzed included patient characteristics and perioperative processes, and you can see what they were on this slide. The variables analyzed also included the pain-related patient-reported outcomes on the first postoperative day. And this included maximal pain intensity, the desire to receive more pain treatment, and also nausea and the pain composite score. So the study found that the patients who used opioids pre-admission had pre-existing chronic pain and depression. They were predisposed to PPOU, whereas a history of anxiety was not predictive of PPOU. So the study, they also found that the opioids given perioperatively, especially on the ward, was associated with a 4% increased risk of PPOU, whereas the duration of surgery and anesthesia type were not predictive of PPOU. So for me, what does this mean? This study had, so I said about this, and then this study has some limitations. So, and these are that variables like the use of cocaine, benzodiazepines, and alcohol were not studied. The effects of surgical nerve injury were not investigated either. However, this paper, the main strength is that it includes perioperative processes and patient-related outcomes into the PPOU prediction models. So the main takeaway for me is that if we provide good intraoperative pain relief and good pain relief in the PACU or the recovery period, that means a lower opioid requirement on the wards and a reduced risk of PPOU. So that was the reason for my choice of this paper. I will now hand over to my colleague, DK, to present the next 3 papers.
Thanks, Rimi. Excellent presentation as usual. Hello, everyone. So my name is Dinesh Kumar Soundarajan. I'm one of the senior clinical fellow from Hull. Thank you so much for this opportunity. And I've got 3 papers and I've got 10 minutes to present it. So let's go for it. So the first journal that I've chose is a review article, basically, which shows the influence of different perioperative analgesic regimens on the tumor biology and the outcome after an oncology surgery. Next slide, please. So this narrative review explores how various pain management strategies that we use, like using opioids, NSAIDs, and local anesthetics, whether do they have any effect on the cancer progression and the recurrence following the oncosurgeries. So the perioperative period is considered as a window of opportunity. I'll tell you the reason later. So the anesthetic choices that we take might influence the long-term outcome from the oncology surgery. So by now you would have guessed the reason for calling perioperative period as a window of opportunity is because of the stress response that's generated during the surgery. The surgery, obviously, it increases the inflammatory cytokines. The pro-inflammatory cytokines like TNF-alpha and interleukins are released during surgery. That basically creates the pro-tumor microenvironment, and also the suppressed immunity. The NK cells and the cell-mediated immunity are suppressed during the surgery, which helps the tumor cells escape the immune system and migrate further. And last but not the least, the pain. Obviously, the pain increases the inflammation and increases the stress hormone release, like catecholamines and cortisol, that again stimulate the malignant cell survival. So now we will look into each analgesic regimen that we routinely use, and we'll see whether does it have any effect on the long-term outcome from the oncology surgery as such. The first one is opioids. The opioids is considered as a double-edged sword. The risk being by depressing the NK cell activity and by promoting angiogenesis as such, carries a risk of not so good result about the outcome from the oncology surgery. Whereas the benefit is by suppressing the pain, like we have seen in the previous slide, they help with the tumor progression as such. However, till date, the randomized control study that has been done have not shown any significant correlation between using opioid or opiate sparing technique affecting the long-term prognosis of the cancer. Next slide, please. The next one is NSAIDs. We may all know the NSAIDs by reducing the inflammation, and we have seen the inflammation as such can promote the tumor prognosis. So NSAIDs, by acting on the COX-2 receptors, they should inhibit the tumor cell aggressiveness. So far, there are various retrospective studies which have shown better survival in breast and ovarian cancers if we use NSAIDs in the perioperatively. However, the prospective trials gives some mixed results, and they are quite underpowered to say that is for definite. The next is the local anesthetic. Local anesthetic seems to be very promising, at least in the preclinical stage. The local anesthetic, though it predominantly acts by sodium channel blocking, they also block the calcium channels. By doing so, they affect the cytoskeleton. By doing so, they also inhibit the tumor cell migration, and also they block the signaling pathways. And the local anesthetic can also induce the apoptosis in the tumor cells, and also they sensitize the tumor cells to the chemotherapy. And they also stimulate the dendritic cell by all these 3 preclinical factors, though we suggest that the local anesthetic can potentially improve the prognosis. So can we go to the previous slide, Snimi? Yeah. So by doing the immunity as such, like I mentioned, it stimulates the dendritic cells. Yeah, next slide, please. Yeah. So the biomarkers, by integrating the biomarkers, the tumor biomarkers into the clinical practice as a part of our routinely collected data will help to identify in future whether which patient will benefit from specific anesthetic interventions. And obviously it is a multidisciplinary approach. We need both oncologists and anesthetists in order to develop large trials in future to know more about this. And last but not the least, by studying the phenotype of the tumor and patient as such, then we could tailor the anesthetic regimen according to the metabolic profile of the patient and the tumor. So the challenges from labs to bedside. We have talked about the various anesthetic or analgesic regimen, but though they have proven some effect in the preclinical stage, it's not been demonstrated in the bedside. This clinical gap exists because the randomized control trials failed to demonstrate any significant impact. So the reason is quite obvious. The difference in the pharmacokinetics between the lab-grown rodents doesn't actually correlate with humans, and the artificial conditions of the animal model versus the real-life tumor biology also has been suggested as a reason for it's not demonstrating the real life. And the large RCTs that has been done on regional anesthetic have not shown any significant reduction in the relapse rate as well. So by conclusion, so far we don't have any specific evidence as such that the specific analgesic strategy is going to affect the cancer patients, though the analgesic choice has to be individualized according to the patient. However, we are moving towards a phase where the anesthetist will play a key role in the patient's oncological journey. So, the next one is a randomized control study. Next slide, please. Where they're going to compare the effect of opioid-free care pathway versus the opioid-based standard care that we use for the laparoscopic bariatric surgery. So they specifically use the laparoscopic bariatric surgeries where they undergo sleeve gastrectomy for this surgery. We know the postoperative nausea, vomiting, and respiratory depression associated with opioids, especially in a high BMI patient, will be a really reason to consider using the opioid-free care pathway for them. So this study is quoted that till date there is no other study has implemented an opioid-free intervention that encompasses both the intraoperative and postoperative phases. So they claim this to be the first of its kind. So the objective of this study was to compare the post-op pain and the quality of recovery between two groups. The one who had an opioid-free pathway, the other one is a conventional anesthetic, including the opioids. It is a multi-center study and it's a non-blinded. I'll let you know the reason later. A randomized control study done in Sweden. And the patients who's been posted for laparoscopic gastric bypass and the sleeve gastrectomy has been included in the study. Next slide, please. The intervention group, which is the opioid-free group, they've used dexmedetomidine and esketamine as an intraoperative analgesic option as an infusion, and lidocaine as well was given. As such, the induction was same for both the groups. Both had a propofol and induction with rocuronium, and anesthetic was maintained with desflurane. So the analgesic regimen used in the intervention group was dexmedetomidine infusion and esketamine, like I mentioned. And in the control group, they've used the usual opioid care. They've used remifentanil infusion and oxycodone as such. So the key change was in the postoperative period. Previous slide, please. In the postoperative period in the intervention group, where they used high-frequency, high-intensity TENS as the first-line treatment of pain if the pain score is more than or equal to 3. Thank you. Next slide. Thank you. So the outcomes that were assessed, or the primary outcomes was, as already mentioned, is the change in the patient-reported pain intensity from PACU arrival till they get discharged, which is usually around 72 hours. The second outcomes were the post-op pain intensity at 24 hours, 72 hours, and 3 months, and the total in-hospital opioid consumptions, and the post-operative quality of recovery scale measured across 6 domains: physiological, nociceptive, emotional, cognitive, ADL, and patient perspective. Next slide, please. So what the results obtained are mainly the pain relief were comparable between the two groups. The main difference was only like 0.04, which confirms the non-inferiority of the opioid-free pathway. And they also found the drastic reduction in the opioid consumption in the intervention group, which is approximately 40 to 45 milligram of less in the opioid-free group, less morphine equivalent than the control groups. And the efficacy of TENS, those who used TENS, nearly 64% of them did not require any opioid at all in the PACU. Next slide, please. So about the quality of recovery, the total recovery has been similar at 3 months between both the groups. The nociceptive recovery seems to be better in the intervention group, but surprisingly, the control group, where the opioid was used, they found to be more satisfied with the anesthetic care at 24 to 72 hours. I'll tell you the reason in the next slides. So, what we infer from this study, the opioid-free anesthetic combined with TENS is a successful opioid-sparing concept for bariatric surgery. So what they say is they can consider this as a plan B if you need during the surgery. But the problem is the non-routine, I mentioned about the satisfaction gap. The intervention group felt less satisfied than the control group. That could be because of the non-routine nature of the treatment, and the anesthetic were not very used to doing the anesthetic with esketamine infusion and dexmed instead of the remifentanil. And also the memories of induction discomfort have been quoted as the possible reasons. So there is a strong need for opioid sparing strategies in high BMI patient, we know, especially because of the obstructive sleep apnea. Next slide, please. So this is my last one. It's about rebound pain. I'm sure this journal gonna gaze some eyebrows. We know the regional anesthesia as such is popular in the ambulatory surgery or daycare surgery, which allows fast and quick recovery from the theater to home directly. The problem of rebound pain, which is the severe pain that comes after the block wears off, is often unnoticed and I would say often neglected side effect of the nerve blocks. So this journal speaks about that. So they define the rebound pain is the quantifiable difference in the pain score from when the block is active to the severe pain encountered when the block wears off. So it often occurs when the patient is at home, outside of the controlled health setting. So regarding the characteristics of this pain, it's usually a high intensity pain. They quote like 7 out of 10 pain scores, and the pain has been described as burning or excruciating. They typically last for 2 hours, and they usually occurs at the first night at the end of the surgery, and patient will be at home by then. And the interesting point is this rebound pain is not responding well to the intravenous opioids. So in 2016, there was a study which showed nearly 25% of the day case patient who had the wrist surgery reported or sought medical advice because of the pain. Out of them, 40% of them received peripheral nerve blocks when compared to the 10% who had a general anesthetic. The data is scarce for sure, but this narrative review mentioned that this needs to be investigated further because this increases the medical consultation and also increases the healthcare cost, and it also questions the quality of care that we deliver in the daycare settings. Next slide, please. So what could be the reason for this rebound pain? The mechanical surgical factors like unopposed nociceptive inputs are uncovered when the blocks wears off, or the potential mechanical or chemical insult during the nerve block as such. And the local anesthetic like bupivacaine, they have some pro-inflammatory properties, thereby increasing the gene expression and increases the pain once the anesthetic effect dissipates. These are the postulated reason for the rebound pain. So these factors that's been analyzed, or it's quite common or a high incidence found in the younger age group between 20 to 60 years, and those who have a high baseline pain before the surgery, they tend to come with rebound pain in quite severe range as such. And the female gender is found to be more common as well. And this rebound pain is appears to be on the higher side, especially after the shoulder surgery when compared to the knee or ankle surgeries. The prevention and management, the pharmacological, there have been few studies being done on the animals, in the rodents, where they found the peripheral dexamethasone may help prevent people can induce rebound hyperalgesia, but it's not been translated into the human practice yet. And the most important thing is the patient education. The patient must take oral analgesic on a regular schedule before the peripheral nerve block wears off. So that is the key. Ultimately, at the end of this, after reading this end of the journal, that was my take-home message as such, that patient education is the key, and we should encourage them to take the oral analgesics on a regular schedule, and certainly before the peripheral nerve block wears off, to avoid having the rebound pain. And we should also inform the patient to compare this rebound pain to the preoperative levels rather than starting from the zero pain state when the block was at peak. Next slide, please. The good news is currently there is no demonstrated link between this rebound pain and the chronic post-surgical pain or long-term functional recovery. And human behavior recovery also appears to be unaffected in the longer term. Next slide. So this rebound pain is clinically relevant, unwanted side effect, but still we need large prospective studies in order to dig deeper into it, and then to assess and then evaluate further. So ultimately it all comes to a perioperative medicine, and the clinician must bridge the gap between the early peripheral nerve blocks and the late phase postoperative distress if at all the patient goes through. Thank you so much, and that ends my journal discussion. Thank you.
Thanks, TK. This is Stan, one of the senior clinical fellows. I'm going to present two papers. I'm a bit out of time. I'll try to stick in time. And this is one of the articles of European Journal, which drew my attention. Perioperative management for women with opioid dependence. A disclaimer that this article deals with a pregnant patient on methadone or buprenorphine as a opioid who has got opioid use disorder and on treatment for that. We know that the number of the patients who are on opioid, who has got opioid use disorder, who are on treatment are increasing, even in pregnancy. And there is no defined standard of care how to manage the pain. And there is evidence to say there is a hyperalgesia and intolerance, even if the opioid use disorder has been treated or they are receiving treatment for that. So this is something very important. What they have described is a single institutional practice and how they manage these patients. Most of the patients they are on buprenorphine patch. However, in our setup, we get more of patients who use methadone. So what they have suggested is continue methadone or buprenorphine, whatever you are on, whatever the patient is on. Use multimodal analgesia. These patients would need expectation management from the very early phase, which needs into the antenatal care. So it needs multidisciplinary planning involving the obstetric, neonatal, addiction medicine, pain and anesthetics department. So essentially, it has to be established early. And while assessing the patients and administering analgesia, it is just not the pain score. We have to focus on functional pain goals as well, like ability to mobilize, feed and care for the neonate, sleep, and mood. Next slide, please. So going into the nitty-gritties a little bit, when we are managing labor pain, what they have suggested is institute neuraxial, epidural early, rather than when the pain sets off. Use epidural opioids in these patients, plus or minus clonidine epidurally, depending upon the patient characteristics. And if, in spite of these things, the pain relief is not adequate, we can go upon a higher concentration of local anesthetic. In patients who do not have, we cannot put an epidural, they have suggested ketamine infusion where epidural is not done. However, given our setup where we have remifentanil and fentanyl PCS coming up, I think that is a suitable option. Again, I'll have to reiterate, they have to continue the methadone or buprenorphine, whichever they are on in this period. For the perioperative period, they have recognized that when the patients are going for a C-section, they have got an increased propensity of pain. So for elective or semi-elective setting, they would change the buprenorphine patch to a fentanyl patch, which is a pure opioid agonist, to have a good pain relief. Do CSE for all of them, not just spinal, because they want to continue the epidural pain management in the postoperative period. This patient's postoperatively would be assessed by the obstetric anesthetic team daily, and they would, with this assessment, they will decide whether the epidural can come off or not. And the fentanyl patch will be there, managing the pain throughout as a baseline. If the patients are going for an emergency GS section or any other reason, fentanyl patch as soon as it's possible, clonidine patch as well. That is what they practice in the department, on that institute. Regional blocks of any kind, like TAP and quadratus lumborum. Having said that, we have the QUALIC study which has come in, and we are reinforcing the fact that quadratus lumborum has got a superior analgesic modality than a TAP for C-sections. Also use breakthrough opioids. They have a very nice protocol over there. Is the patients are admitted for 72 hours. These kind of patients, they have the fentanyl patch for 72 hours. During admission, they are prescribed one more patch after they're discharged, and then they are switched over to their regular maintenance medications for post-op pain relief. And during their admission, they liaise with the opioid use, OUD treatment providers, so that these patients can have a follow-up after discharge, and they can go into their maintenance therapy, and the pain can be managed, which is pretty good. Next slide, please. So goes without saying, this is a flow chart. It's worth having a look and then tailor it to the local practices. Next slide, please. So the take-home message is, obviously, we need a standardized local guideline. We have local guidelines for patients on opioid, but we don't have pain management in patients on opioid, but we don't have any for the pregnant patients. This needs a good multidisciplinary liaison and good governance framework to manage that. And we have to remember that there is a risk of relapse, which needs to be balanced with adequate analgesia. Next one, please. So this is my final presentation. This is something which I found interesting. I think Dr. Sanem would be talking about the transitional pain service, and the chronic pain after postoperative pain has been a discussion on the recent days. So this is a meta-analysis which assesses the perioperative psychological interventions for the reduction of post-surgical pain intensity, depression, anxiety, and pain catastrophization. Next slide, please. So I've just gone through why does it matter, and I think it would come up at certain point of time if we have the transitional pain service setting in. Next slide, please. The primary objective of this primary aim of the study was, what is the effect of intervention on the perioperative pain intensity, management of on the pain intensity. And while doing that, they have included some secondary aims, which is, what are the type of interventions provided? When was it provided? Who provided it? How was it provided? Was it online or in person? What was the duration? Whether it was provided randomly or targeted at-risk population? What was the pre-op pain, and whether there is any, what is the gender involvement into the paper? Next slide, please. Screening that, they had 2,300 papers, which by exclusion criteria is narrowed down to 27 RCTs, and eventually for having the data available, they meta-analyzed 17. The interventions that were offered was cognitive behavioral therapy, mindfulness-based interventions, and acceptance and commitment therapy, ACT, which usually MBI and ACT are provided in conjunction, not alone. What they have found out that the pain intensity reduced, moderate effect. Now, they subdivided the group into subacute pain and chronic pain, which was defined by less than 3 months and more than 3 months. Pain going beyond 3 months. They have found out the effect on the subacute pain was more than the chronic pain. The anxiety was reduced, but there was no clear benefit for depression or pain catastrophization. Next slide, please. Amongst all the interventions provided, CBT was most effective when it was delivered by a psychologist rather than a non-psychologist colleagues. The outcome does not depend on when it was delivered, how it was delivered, or for how long it was delivered, and whether it was targeted or non-targeted. The evidence was of moderate quality, but authors are recommending to consider integrating this into the perioperative pathway, which is impressive. Next one, please. So by saying that, I'm going to conclude this, and I think that is all we have to present from our side. Thank you so much.
Right, thank you very much. It was an excellent battery of information. I had a lot of ideas while I was listening to the presentation, but I would like to ask the audience if they have any questions first. For either Harry or Tan or Nimi or DK. And if there's no questions at the moment, while you're having a think, I'm gonna just remind you that in the Q&A I've posted some questions about the use of prophylactic dexamethasone. I'm wondering how many of you are using dexamethasone routinely for their blocks, whether it's IV or perinaturally. And my next question I've written down for Harry was about the perineural use of dexamethasone in pain block, but he kind of answered it that the study only compared the perineural use versus no dexamethasone. There was no IV dexamethasone. Am I right?
Yeah, that's right. I mean, this has come up before in previous studies looking at, say, brachial plexus blocks. There was, I think, the first study that looked at adding dexamethasone to an interscalene block, sort of triggered this whole thing that they showed that there was an advantage putting dexamethasone in the block. And then when it was published in the letters columns, people were like, well, why aren't you comparing it against giving it IV? So then they added on that third arm, repeated the study, and showed that it was very, very similar. So this, these two studies I presented, they acknowledge its weakness, but I think they were sort of it almost seemed a bit scoping, you know, they're sort of testing the water a little bit. They were kind of a bit small. Yeah, so, you know, they didn't have a control arm either. So really you wanted a sort of a four-arm study to look at the effect of IV dexamethasone and everything, you know, all pain blocks versus nothing. So yeah, it's a recognized weakness. I mean, talking about dexamethasone for rebound pain and for pain blocks, it's interesting. You know, in the UK we're quite dexamethasone happy. IV, you know, I would say nearly all of my patients get dexamethasone for the post-op nausea and vomiting point of view. But when I worked in Canada a while ago, they just don't use dexamethasone. When I asked someone why, they said it's because of the incidence of avascular femoral head necrosis. And I thought, oh, is that a risk with dexamethasone? And it is, but it's an extremely small risk. So yeah, I think these studies that are being published looking at dexamethasone are often from other places where dexamethasone IV isn't as much of a thing as it is here. So in answer to your question you put in the Q&A, do you routinely use prophylactic dexamethasone for rebound pain production? I do, because I use it in nearly every anesthetic I give. So yeah, yes.
Thank you. I fully agree. I use dexamethasone a lot. I normally use IV about 9.9 respectively with my blocks for the maximum prolongation. But I think we know from the studies that the effect is equivalent with the ceiling around 10 milligrams for IV use and 4 milligrams perinurally. Thank you. Balaji, you raised a hand.
Yeah, I think what we use prophylactically for nausea and vomiting is 6.6. But if we need to up the dose, probably we need to use 2 ampules. The only caveat is in diabetes, we need to be a little bit cautious. And I use even for epidurals and spinals for hip and knee arthroplasty. It does make the trick. You can even bring down the short-acting spinal anesthetic and give a dexamethasone. It helps a lot. That's what I just wanted to share.
No, I agree totally. I've upped my dose. I haven't quite gone as high as 2 ampules yet. I'm at 1.5 ampules. But you do have the additional caution, of course, is psychiatric issues. So I've heard someone mention, although I don't know what the evidence base is here, that they wouldn't give as much dexamethasone to someone who's on 2 antidepressants, or if they're on an antipsychotic, which I guess is a very pragmatic way of trying to avoid roid rage, perioperative roid rage.
Yeah, so what I used to do is not to give IV high doses dexamethasone to my afternoon patients in order not to disturb the sleep cycle, and prefer the perineural dexamethasone in the afternoon. But to be honest, I have to admit that I reverted from that to IV for everyone. Yeah. It's probably because we don't follow up our patients very well, so I don't really get to see them at night. I have to admit that. Babette, you raised your hand. Do you have any question or comment?
Yeah, thank you for the talks. My name is Babette. I'm a consultant at University Hospital in Antwerp at the moment. But I had a question about the dexamethasone as well. I wonder whether the studies were giving any direction into timing of the dexamethasone. Is the giving the dexamethasone at induction when you're going to do a block or when you have done a block? Is that good enough, or should we be repeating the dose to make it closer to when we expect the block to wear off? Did the study say anything about that?
Is this with regards to rebound pain?
Yes. Yes.
I'm not sure I know. Who was it? Tan? Was that the paper that you looked at?
I have this topic has been discussed at the last ESRA meeting. I think there were some studies presented when they were giving additional dexamethasone in 24 hours after the initial operation. But I'm not entirely sure from the top of my head what the outcome was, but I think there were minimal benefits from that, as far as I remember.
I think at the induction, it plays a vital role, Babette. That is what the evidence shows. So before you do the block, you give the dexamethasone, it works very well. Apart from if you give it later, and we can follow it up after 12 hours with another dose, and it does make even further trick with pain relief, prolonging the duration of pain relief.
Yeah, that's what we do. We usually give a block dexamethasone a dose at induction. I was just wondering whether we should be repeating it in a later stage as well too.
It's a really good question. I'll have a look into that, because that's it's a good idea. Of course, the caution there slightly is that giving IV dexamethasone to an awake patient can be a bit stimulating.
It exists orally though as well.
Oh yeah, you can give it IV. You just have to dilute it and give it slowly. Yeah, I don't know. It's a really good question.
Dr. Sanem.
Good morning. It's a very nice talks this morning. My probably is more of a comment about using dexamethasone epidurally and spinal. I think Balaji was mentioning about it. I think when we are using epidurally and intrathecally or spinal, we just have to be mindful the common dexamethasone which is available comes with preservatives. So you just have to be mindful.
I think you misunderstood. when I mentioned it is intravenous only, it's nothing to do with spinal or epidural. What I meant to say is, even if I give spinal anesthetic, I tend to give dexamethasone and it prolongs the duration of spinal anesthetic. That's what I was trying to say.
Okay. All right.
It has a synergetic action. It's not that I'm giving intrathecally or epidurally. That is not the one.
All right.
We give it intravenously. Even if I do a block, I give it intravenously. I don't give it perineurally because I'm very twitchy because I don't know whether it is preservative free or not.
Yeah, that's right. Okay.
Yeah.
That's the only thing we just have to be mindful of. If you are doing that perineurally also, probably it is worth using preservative free. It's chronic pain, we use all the time dexamethasone. So there's nothing wrong, but just be mindful of using appropriate medication. Thank you.
Right. Any other comments about dexamethasone? It is a hot topic which comes up almost at every conference. Tan, go ahead.
Yeah, I think Dr. Mugatroyd did mention that the dexamethasone perineural versus intravenous was a meta-analysis which showed interscaling, which was tailored to interscaling brachial plexus block. Now, I could remember Babbitt did ask this question, whether we do it before and after. I don't think there is much work apart from use of dexamethasone IV in any other blocks. And one second is it's a meta-analysis focused on upper limb, specifically shoulder surgeries, which means they don't cut the muscles. They go through the plane in between. But when we compare that with surgeries on other sides where muscles are cut, more peripheral nerves are cut, which doesn't amount to be doesn't amount to have numbness or anything like that. But the more structures are cut, the more the pain and again converting into the transitional pain, chronic pain, and all those risk factors are there. I don't know whether there is enough evidence to link to whether we can give IV or perineural and which one is superior, what are the timings. I don't think we have enough evidence to reciprocate it overall. However, we have a meta-analysis which says it is similar, so we can actually try and see, and then probably there's a future direction for doing the studies and doing some meta-analysis on this.
Yeah, no, I agree. I've actually got on my other screen, I've got the meta-analysis up, and you're right. It is a lot of it is shoulder surgery or radius surgery. There's only one on a couple on the lower limb. So it probably does vary between the different surgeries that we do, the benefit of dexamethasone. But it does, like I say, I find a lot of this quite academic anyway, because I'm going to use dexamethasone IV anyway for these patients. If there was a study that showed that there's a big advantage about putting it into the block, like potentially with those Peng studies I showed, then maybe I'd start changing my practice. We had a patient recently, well, maybe last year, who had a acetabular metastasis, and we put dexamethasone in a Peng block for that patient, and the block lasted 3 days. So I guess in certain circumstances, if you want a really long-lasting block, you could, if you put it in the block itself, maybe in those circumstances, it could be a bit more along the chronic pain prolongation, reduce the inflammation as well. So yeah, I'd wait for a bit more evidence before I start adding too much stuff to the blocks.
Right. I had one more question to the wider audience. Harry hinted on the communication of the doses of local anesthetic. I was wondering how people communicate their doses of local anesthetic to the surgeons. This is particularly important after the recent Spire Lee Hospital incident, which was very unfortunate, and the patient passed away following severe case of local anesthetic systemic toxicity. So Do you guys prefer, when the surgeons ask for the allowance of local anesthetic, how much can they administer? Do you give them the doses in milligrams, or do you tell them milliliters of a specific concentration, or do you tell them milligrams per kilo? What is your preferred way?
So what we usually do is, in orthopedics, where this is usually the problem, and I usually find with total knee replacements, because we've done an adductor canal block and other stuff, and then they want to do some infiltration as well. Try and keep it simple for the surgeons, because we all know our surgeons. But they usually use the same concentration of local anesthetic, so that keeps it simple. So I usually work it out the volume that they can have, and I usually talk to the scrub nurse rather than the surgeon. And because we've had some near misses, we have like a chart on the wall. So it'll have the patient's weight, and then it will give the number of mils that the surgeon can give for that weight, and then there'll be another figure for reducing that by the amount that we usually use for an adductor canal block, for example. So, keep things sort of quick reference, easy to access, and make things as easy as possible for the surgeon and the scrub team. But yes, we've actually, I think the most recent rechange of our checking in, at the start of each surgery, it actually specifically includes this, probably because of that case that you were talking about.
Yep, that's right. That's right. We do that as well during our checks. I just found out that some of the surgeons almost use the milliliters and milligrams interchangeably in their speech, which introduces more confusion. And when we introduce another team member, because obviously this is prepared by the scrub nurse, then there's even more potential for miscommunications and errors.
Yeah. I mean, it should really be our responsibility to make sure that they're doing things right. I did a grand round in York a few years ago about local anaesthetic toxicity, presenting a couple of cases, and at the end of it, a cardiologist said, I give 40 mils of 2% lignocaine to put pacemakers in. Are you saying that's too much? I was like, yes, that's way too much. So I think we're quite used to this sort of thing and doing the calculations and being a bit careful about it. I think out there, the surgeons and the medics just don't have an appreciation for it at all. Mixing local anesthetics as well. We had a case where the surgeon had put a lot of lignocaine in and then put a lot of bupivacaine in as well, because they're different agents, so it's okay. But of course, it's not okay.
Yeah. Right. Let's move on to the other questions in the chat. Someone is asking whether we have noticed, or someone has noticed, the effect of dexamethasone on postoperative sleep disturbance. So from my experience, that's only anecdotal. Like I said, we are not very good following up our patients after they leave the recovery, and even more so after they leave the hospital. So I don't get to see my patients at night. But anecdotally, I've heard of that, yes, with high doses. Anyone has an experience with sleep disturbance following high doses of steroids? No, in that case,
Tan, is that what you were going to say?
Tan, yeah.
Yeah, it is, again, this is a specific group population that I'm going to speak about, patients with cancer pain and palliation. So when I used to do that, I avoided doing dexamethasone later on the day. It does have a psychostimulant effect. It increases hunger and make the patient feel good, especially when they are thriving with the cancer pain and suffering. And we used to prescribe it early in the morning rather than late, because it usually hampers the sleep. Now, having said that, I have never followed any patients postoperatively, and I don't know whether it can be this can be transferable to the postoperative surgical patient population. But this is just a comment to add on.
Yeah, I agree. Actually, it reminded me when I do my neuro-oncology list, all of the patients, when I see them in the morning, they always complain that they didn't get a good night's sleep since they have been started on steroids. That's right. But you rightly pointed out, whether it translates to our regional practice is a slightly different question. We have some more questions about whether there's any evidence of the amount of intrathecal bupivacaine making a difference to the efficacy of intrathecal morphine. That's, I think, a question for Nimi.
Sorry, I have answered that. Was that the one in the chat? Yeah.
Yes.
Jacob. So the thing is, both the groups received bupivacaine as part of the spinal anesthetic. The only variation was in the adjunct that was added. So that's why I've said that. So I think what they said though was in both groups, the amount was left to the discretion of the anesthesiologist. So that volume of bupivacaine and all the adjuncts in the pre-ITM group was left to the discretion of the anesthesiologist. In the ITM group, the only thing that was standardized was actually the intrathecal morphine.
Right. So that effect which Mustafa was asking about is basically wasn't studied in your paper. Right. There's a question from Dr. Reina to Tan about how much clonidine would you suggest in opioid-dependent patients for epidural analgesia, and if there's any advantage of fentanyl over clonidine in this category of patients.
Yeah. Hello, Dr. Reina. So the papers suggested that these patients should have early epidural local anesthetic and the fentanyl for all these patients. They didn't actually mention the dose, but again, transferring my experience of using clonidine for the nerve blocks, it usually is 1 mics per kg of ideal body weight. I have seen when we use that amount of drug in the epidural, it can cause a significant amount of drop in blood pressure. So probably I will keep it around 40-50 mics of clonidine in the whole bag and start. Again, this was just a single institution-based article. I have not gone through the details of whether there is enough evidence to comment on that. But having said that, I will have a look and get back to you.
Thank you. And Andrew also followed up with another question, whether there's any advantage in the pain relief using 150 mics morphine over 100. So I believe that's for you, Tan, as well. It looks like Tan has frozen.
Sorry, I just missed the question. Sorry.
This is a question from Dr. Reina again, whether there's any advantage of using 150 mics over 100 mics of intrathecal morphine in regard.
So was that question to me, Jacob? Just because of the intrathecal morphine paper? Yeah. So
maybe yes.
The paper that I read, which was about the implementation in this Dutch hospital, only standardized the dose to 100 micrograms of intrathecal morphine. They did not use 150. It was a standardized dose. 1 mil was what was the preparation that pharmacy gave them, and that's what they used. 1 mil, 100 mics per mil.
Okay. I think Dr. Reiner might be asking the whole audience whether people have any experience.
I think what they've also
100 and 150.
What they've also said is as we increase the dose of the intrathecal opioid, the side effects like pruritus increases. So I think that's the thing that we should bear in mind.
Sure. And in your experience, does the analgesic effect increase proportionally as well, or have you hit the ceiling with 100 and you're just increasing the side effects? I think that's the question maybe Dr. Reiner's hinting on.
Yeah. That was not answered by that particular paper, but it's a great question and something that we should look at.
I think I've heard of a paper that does address that. I can't remember the reference though, but there is definitely a ceiling on the intrathecal dose of opiates. Because for some of our bigger laparoscopic abdominal stuff, people who were using in New York, they were using really, really high doses of dexamethasone, and then someone dug up this paper that showed that there's no advantage of going over 200 mics, I think it was. So everybody's reduced it down. We've not seen any real change in anything. So there probably is a ceiling effect, isn't there? I can't remember the reference, so I'm sorry.
Yeah, I personally agree, but then the whole debate is just going to shift to where exactly does the ceiling lie.
Yeah.
And I think we will probably be seeing countless studies just shifting with 15 mics here, 15 mics there. Right, 11 o'clock exactly. If anyone has any more questions, this is the time. Otherwise, we will proceed with a quick coffee break to refresh yourself. I would like to thank everyone who presented in the session one. It was excellent. There was a lot of amazing studies. I would also like to ask you if you can put the links to the studies you have presented in the chat so people can refer to them and get a more detailed insight. And thank you. And we will proceed with session 2 at 11:30, and we'll be talking about innovation, and we'll be talking about catheter service for refractory patients and some troubleshooting in failing regional anesthesia.
Okay.
See you in half an hour. Hi, can everyone hear me? I had some technical issues. It looked like the whole MS Teams just collapsed for a couple of minutes. I can hear you, Balaji. You muted.
We can hear you, Jacob. Yeah, sorry, I was about to log in, but
Yeah, I had a bit of a scare because the whole Teams collapsed for a few minutes.
Okay.
However, we are ready, and we are ready to move on to session 2, the power of free innovation, equity, and rescue. And I'm going to be asking a question to Alan Race. What is new in the world of regional anesthesia and pain medicine? Alan is one of the consultants in anesthesia and intensive care in Hull. He's also the acute pain lead in our trust, and he had extensive involvement in many projects. One of them is the project for our management of rib fractures, which we will have a second talk about. But currently, Alan is going to tell us about the innovation in the field. Alan, are you ready?
I can't see Alan there. I don't know. Oh.
Right, and we can't hear your talking. We can only see your pictures.
Alan, we can't hear you.
I'm having a few technical issues because I'm in this coffee shop, so it keeps freezing. So let me I'll do it now. It's just so noisy. I don't want to. So I'll reshare. Okay, should work now.
We can't actually hear any background noise from you. So
can you not hear me at all?
We can hear you well. We can't hear any noise. It's a good sound
are you sure?
from you.
Anyway, I pre-recorded it, so I'll just play it and then I'll do questions at the end. It is very noisy for me, so I'm finding it difficult to hear you guys. That's a problem.
Right, sure.
So I'll just I'm moving house today, and obviously everything's in chaos. So but I'll see. Good morning, everyone. Can you hear it now? Thanks for having me. I'm Alan Race, consultant in anaesthesia and intensive care at Hull, and I'm the acute pain lead. And today I want to talk to you about 3 evidence-based approaches to reducing our dependence on opioids. Let's start by why this actually matters. This is the opioid crisis in England and Wales over the last 30 years. It's deaths per million. You can see it's not getting any better. And we've known about this problem for decades, and yet here we still are climbing. The numbers, they're really stark. So 11.5 million opioid prescriptions per year in England alone, right? That's and we've got over 2,000 deaths annually in England and Wales. And here's a number that should make us all quite uncomfortable. It's been 27 years since we've approved a genuinely new analgesic class. That's 27 years, right? That's a whole generation. And we need alternatives, and we need them now. So what were you doing in 1998? I was doing my PhD in theoretical physics. But 1998 was when COX-2 inhibitors were approved. And as I said, that's the last genuine novel mechanism. So here's what stagnation looks like visually. Morphine isolated in 1803, aspirin in 1897, fentanyl 1960, and the drug that we all use and abuse perhaps on ICU is remifentanil 1991. And then, of course, COX-2 inhibitors. And then there's absolutely nothing. Yeah, there's been a few refinements, like, the generation of pregabalin, but these are really tweaks to already known biology, improvements. They're not fundamentally new. So we've been iterating on this same biology for 27 years, and all along the death rate still climb. So today I'm going to talk to you about 3 innovations that maybe could change this picture. So suzetrigine, it's a genuinely new mechanism targeting peripheral sodium channels. Second is AI-assisted ultrasound for regional blocks. Now, we all know AI exists and it's around, but it really is becoming a practical tool. and it's CE marked, so you could be using it next week. And then third, Xyreleaf, an extended release local anaesthetic that lasts 72 hours with a single injection. So let's take one at a time, shall we? Suzetrigine, it was classed as the drug hunter's molecule of the year. It's an oral sodium V 1.8 selective inhibitor. That's voltage-gated sodium channels expressed predominantly on peripheral nerves and nociception signals. It's FDA approved for acute pain in America, and it was discovered by a company called Vertex. And here's what makes it interesting. It wasn't discovered the traditional way. And this is how they found it. They started with human genetics, not chemistry. Clinicians noticed that some patients felt no pain. Not reduced pain, no pain. Geneticists found loss of function mutations in the gene encoding NAV 1.8 in these patients. So scientists targeted specific channels. This is reverse genetics. You start with a human phenotype, identify the gene, then design the drug. It's the opposite of traditional screening approaches where you test thousands of compounds, hoping to find something that works. The result? The first fundamentally new analgesic mechanism in 27 years, FDA approved on January 30th, 2025. It's awaiting MHRA and NICE approval in the UK. Let's talk numbers. These are the phase 3 data published in Anesthesiology. 2 randomized controlled trials, 2,191 patients in total. Abdominoplasty and bunionectomy, chosen because they're reliably painful and you can measure outcomes clearly. Abdominoplasty trial, pain reduction of 48 points on a 0 to 300 scale, 95% confidence interval, 34 to 63. P-values were significant. Bunionectomy trial, pain reduction of 37 points, confidence interval of 24 to 49, also significant. Both trials were superiority trials tested against a placebo. Both were statistically and clinically significant, and there's real-world follow-up too. 256 patients, 83% satisfaction rate, published in the Journal of Pain Research. So that's the evidence. Right, so that's the first one, Suzetrigine. So let's move to number 2, AI-assisted regional blocks. Right, we all know that experts don't always agree on what they are seeing when they're doing ultrasound. No, so this is from a BJA article in 2024, and it's a study by Bonus and colleagues. 19 expert assessors reviewed identical ultrasound images. Same images, same patients, different interpretations. So it generated a statistic called a kappa statistic. And what this does is it essentially looks at the way 2 observers classify categorical outcomes. And it's a measure of seeing whether it's beyond chance. So for instance, a perfect agreement is equal to 1. Agreement equivalent to chance is 0, and -1 is perfect disagreement. So interscaling blocks came out with a kappa of 0.89, so that's good. Supraclavicular kappa of 0.77, so that's moderate to good. Adductor canal kappa of 0.64, so again moderate at best. So experts frequently disagree on nerve identification, right? So if experts can't agree or have some disagreement on what's nerve, what's artery, what's structures, then how can somebody like me, who is non-expert, who maybe does regional a couple of times on a list, in a kind of 6-month block, what chance have I got? So what's AI? AI image recognition mimics how our brains process vision. So just as neurons in your visual cortex detect edges and patterns to recognize objects, convolutional neural networks learn hierarchical features from medical images. So that's just it's just a fancy layered logistic regression. Okay. So the process is straightforward, really. Convolutional layers extract features like edges and textures, pooling layers, compressing this information, and then the network classifies what it sees. So, for instance, in this case, hemorrhage, tumor, or infarction, or that would be nerves, arteries, or muscle. So the key difference, traditional analysis uses fixed rules. AI learns patterns from thousands of examples fed in, often detecting subtle findings we miss. So for us, this means real-time support. So identifying difficult airways from imaging, for instance, that's been done, detecting pneumothoraces on chest x-rays, and in this setting, looking at nerves and identifying what you should be needling. So the question isn't whether this works, it does, but it's how do we integrate it into practice? So this is ScanNav. So you can see here, it's detecting the adductor canal region and looking at features. So it gives muscle is green, nerve is yellow, and artery is red, and nerve is blue. And you can see it's portable. It's something that you can use. It doesn't require some humongous supercomputer. So ScanNav, as I've said, it's an AI system that overlays real-time color and on your ultrasound images, giving you what you giving green for nerves, as again red for vessels and yellow for pleura, for example. So performance data: 720 ultrasound videos with external validation, published in the BJA in 2023. So true positive rates 87 to 94%, false positive rates 4 to 8%. So that's comparable with expert level performance. And here's the key point: is now actually FDA and CE marked, and we can use it in the UK. So yeah, this is something that we don't require NICE approval. You might see this like on units around the country. So impact, leveling the playing field. So non-experts without AI, obviously variable performance, higher inter-rate disagreement and longer identification times. However, with non-experts like me, with AI, it should approach expert level, consistent identification and improve confidence. Now, it doesn't replace training. It's just to augment training. So we would never say that this is going to replace like the expert regionalist, but it just makes kind of good, okay practitioners better, like me. And that's I would class myself as a sort of prosumer of regional. So that's number 2. And now we're going to go on to the third one and the final one, which is Zyme relief. Okay. So it's an extended release local anesthetic, and it also contains meloxicam. So this is a situation where you might use it in a painful knee arthroplasty. Rather than just infiltrating local anesthetic, you infiltrate Zyme relief, and it should give longer pain relief. So it's bupivacaine plus meloxicam. It's a polymer matrix, single injection into a surgical site, and 72 hours it has sustained release. It combines a local anesthetic with a non-steroidal in one formulation. So FDA approved in May 2021. It's not UK licensed yet, but it's probably coming. And there are 7 RCTs pulled in a 2020 meta-analysis. And this is what I want to talk about next. So the 7 RCTs were pulled, and these are the outcomes. So pain reduction minus 1.8 points on a 0 to 10 scale, so about 2. Confidence interval minus 2.2 to minus 1.42, and it was significant. So opioid-free odds ratio, that was 3.25 with a confidence of 2.3 to 4.58. So that's 3 times higher rate of opioid-free patients compared to standard local infiltration. Morphine equivalent reduction, minus 10.6 milligram equivalents. Confidence interval 13 to about minus 13 to minus 8.1. So the effect size is not enormous, but it's consistent and it's meaningful. So here's the most recent head-to-head comparison published in July 2025 in the Journal of Bone and Joint Medicine, Mayo Clinic. 101 knee arthroscopies, Zyme relief versus standard periarticular infiltration. That's a cocktail most of you are using ropivacaine plus ketorolac and adrenaline, mixed at a time by the surgeon or anaesthetist. The area under the curve pain score was around 331 with Zyme relief versus 373 with standard cocktails. So P was non-inferior. Same efficacy, but Zyme relief is standardized pre-mix and lasts 72 hours. So here's a thought experiment. If all 3 of these are in the UK tomorrow and they were licensed, what could we do? So obviously we could pre-op do an AI guided regional block using ScanNav, so someone like I could do it without making an absolute mess of it. Consistent nerve identification, even by non-experts like me. So have a go, heroes. And intraoperatively Zyme relief injected into the surgical site. So that should give 72 hours of bupivacaine and meloxicam release from the single injection. And then post-operatively, suzetrigine, start with about 100 milligrams step down to 50 milligrams twice a day. And this blocks the sodium V1.8 channel with no opioid mechanism. So that's genuine multimodal analgesia with a realistic chance of avoiding opioids entirely. Not guaranteed, nothing's a guarantee, but there's a reasonable chance. So now let me bring you back to earth. So suzetrigine is not licensed in the UK. It's awaiting MHRA review and then NICE appraisal. So it could be months, could be years. Zyme relief, same story, not UK licensed, awaiting MHRA and NICE. AI ultrasound, that is available on Monday. It's CE marked and ready for use. So you could request a demo tomorrow. NICE approval obviously depends on cost effectiveness modeling. So this could be years or it could be never, and that's the reality. So I had a look at some of the costings. So for instance, currently for suzetrigine, it's $232 for a 7-day course. Now, when you consider that prescribing something like a codeine-based drug is probably around about $10 for a 7-day course, that's a pretty steep price, isn't it? And again, standard bupivacaine, about $5 to $15, whereas Zyme relief is about $270. So again, will NICE approve these things? Now, ultrasound per block, I did a rough calculation of about an additional $55. So, these things are they're expensive, but times have to change because we know that fundamentally that opioids cause lots and lots and lots of issues, not just immediately, but also long-term problems. So what you can do Monday, use AI ultrasound. It's available. Request a demo, see if it works in your hands, right? You can just, I guess, track the pipeline, just follow MHRA and NICE decisions on sumotrigine. and Xyreleave. These will come eventually, and I guess be ready to understand them and move when they do arrive. So, and then 3, design opioid sparing protocols. It's really important. I know we're all much more aware of opioids stewardship, but you know, if you can do a regional technique, optimize multimodal regimes, maybe using some S-ketamine for pain relief, prepared for changes, and then make sure that you review evidence regularly, and then decide for yourself. So let's end where I started. 11.5 million opioid prescriptions per year in England, 2,000 deaths annually in England and Wales. And we've got these 3 innovations, perhaps, that may help us to chip away at these alarming figures. So there's Suzetrigine, AI ultrasound, Xyreleave. You know, none of them are perfect. You know, they're not miracles, but they are definitely options that are coming. So the evidence is there, and whether you act is up to you. So yeah. So these are the key references.
Thank you, Alan. That was an excellent presentation, as always. Before we move on, I just wanted to say that we do actually have the AI-assisted devices in Hull, and we use them regularly, mainly for the training purposes. And I put up a question in the Q&A so people can share their experience from using these devices, whether they use them in their clinical practice or training. Please answer the question and share your insights so we can then potentially discuss it in the Q&A section. The next presentation is the Relief Club, and we wanted to excuse me, introduce the service we have in Hull for refractory management, and you know, share our insight from the years of the service. Alan Race is one of the authors, or the main author of this service, so hopefully he will be available to answer some of the questions. The talk is pre-recorded again because Dr. Tumu is one of the Caesar Fellows in Hull, is currently sitting on the plane, but I will play his pre-recorded talk, and then together between myself and Alan, hopefully we'll be able to answer the questions. If you just give me a moment, I'm going to put up his presentation now.
Hi, Jacob. We are not able to hear.
Oh, you can't hear the presentation?
No, we were not able to hear. Yeah.
Right. Let me try to.
We can see the presentation, but we can't hear.
Okay. Let me try again.
Probably when you share, you may have to unmute it. I don't know.
It was unmute. Did you hear it at the beginning?
No, we didn't hear at all.
Yeah, so that's not the muting then.
I think when you share before that, you go there, there'll be a box where you have to unclick the audio or something because it'll say audio muted or something. If you go into the video one, yeah.
I'm not sure that's the case.
Alan might be able to bring it on because he got the same thing.
I had the same problem. So you need to just play it from the beginning, but unmute it. Because if you mute yourself and you're playing it, then it won't sound.
Okay, let's try it again. Can you hear it now?
No.
Then it's not the case because I can hear that. And right, let me maybe disconnect my headphones and see what it is going to be. What about now?
No, Jacob. I think in the thing, when you go for sharing that one, you have to go for the video. When you're trying to get the video there should be something on the end to say audio, yes or not. Not this one. Not this one. At the back end, I think. That is always a problem. If you have a video, we need to make sure that the video is linked.
Yes,
in your setting,
yes,
you need to find it out.
Okay.
Let me see what I can tell you. How I don't know how to do it.
Yeah, I don't seem to be able to.
If you see, you have opened the video, you go to the share. When you go to the share one, when you share that one, click the share.
Yeah.
Yeah. And does it come with sync to the video? There's something that you're mentioning, sync to the video there at the bottom. So okay. Okay, you're trying to do that one. Yeah, your status is set to not to disturb. Watch in the browser. Let us see what is happening with the video.
Yeah, let's see here.
Go to the sound. No.
Do you hear it now?
No. So unless that audio, because in your settings somewhere your audio has been muted. I don't know. I can't access your thing there. That audio has to be unmuted there.
Yeah, I'm in the audio settings now and I can't really.
If you go to the audio setting, when it says that if you're going to put a video, it will say that it's muted. I don't know. You need to scroll and see some point. High fidelity mode. If you no, that is not the one.
Jacob, sometime if you go into the Microsoft PowerPoint presentation.
Yeah, I only have it as a Teams.
Yeah, no. And then there is a custom slideshow. And in the custom slideshow, there's an advanced, yeah, so go on the slideshow and there's a custom slideshow. No,
yeah, but
I
I don't have this presentation as a.
It's a video format he has. That's where the challenge is.
That's fine. Okay.
So he is uploading the video now because he is the master one. The video one that has been muted somewhere. And not here. No files are there. It is.
And it's very unfortunate. I apologize to everyone for this technical issues. I was almost
what
thinking
we can
that
do is we can get Veena to do it. We will try to find out. Can you send that one to me? Let me see whether I can look into it, Jacob. That video.
Yes, I will send it to you if
we can get Veena
let's
to
hold the
do that
sessions and
one
if we can get Dr. Daga to present the rescue club now, and then we will circle back to the rib fractures. That would be great.
So good afternoon, everyone. It's literally just 5 minutes. Can you all hear me and can you all see me? If someone just shout out.
Yes, we can hear you, we can see you, and take your time. We can always use up some of the questions time.
Perfect. Thank you. So thanks very much. It's so nice to hear loads of update, especially all the recent paper, innovation. So yeah, thanks very much to all previous presenters and welcome to the Rescue Club. So my name is Veena, and what we will be discussing in next 20 minutes, more about what we do when regional anesthesia doesn't go according to the plan. What I have tried for this presentation, I look for all the latest evidence, especially in last 2 years in 2024 and 2025 literature, and especially some concerning emerging data on local anesthetic systemic toxicity, which has been very recently published. So as we all know, the regional anesthesia has become increasingly sophisticated with ultrasound guidance, but we still face block failures, complication, and we definitely need some robust for rescue analgesia or rescue strategy. So today's goal is to just provide you some systematic evidence-based approach that you can implement immediately in your practice. So I try to cover mainly those 5 key areas. So we try to first understand what does it mean when we say failed block or inadequate block. Following that, some systemic troubleshooting for failed block, how we can recognize and managing the last, which is local anesthetic systemic toxicity. And we will be discussing the current ESRA guideline. Again, looking for some more evidence-based multimodal approaches. And finally, some opioid sparing strategies. At the end, we'll go through some case studies as well, because that will be helpful for some of you, because some of you might be just started doing the regional anesthesia. And I also understand most of you are very, very experienced and have done amazing amount of regional block. But whichever situation you are, we always need a clear rescue plan is essential. So let's start. So we all know failure is fundamentally about clinical effectiveness. It mainly looking for, does the block meet the agreed surgical and analgesic goals for this individual patient? We are not looking for whether it blocking the textbook dermatomal map, which is colored in different various color. Complete failure usually implies that the local anesthetic is not in the right plane at all. It may be intramuscular, maybe subcutaneous. Or when we say about partial failure, it may suggest that some drugs is in correct tissue plane, but either volume, spread, or concentration is inadequate. Another form of failure, what we always talk about, is initially very, very effective block, but which regress very soon, either before the operation finished or patient having unacceptable pain either in the theater or in the PICU or when they go into the ward. This distinction matter because they all carry different risks and they all drive different rescue strategies. So basically, it's first we try to establish whether it's ineffective, complete failure, inadequate failure, or partial. And let's look for some data. Now, this data might not correlate with your own practice, but this has been published very recently in 2025. And what it suggests that block failure rate range from 3 to 15%, depending on the technique and also how we define the failures. It doesn't look very significant. So, for example, some of you would do blocks every day, might be doing 100 blocks per month. You may encounter between 3 and 15 failures. It's all depend what kind of rescue strategy you use. Now, this number may change after having our AI-induced ultrasound from Monday. So this is the figure I'm talking from the last year. And basically, that's maybe if you say 100 per year, or if you're doing 100 per month, it may be like 1 to 2 per day or 1 to 2 per week, depending how busy your regional practitioner you are. And mainly common causes when we talk about the block failure or what has been prescribed is human anatomy doesn't read like textbook. Not everyone is the same. Everyone is unique, and you may have realized or may have already observed that anatomy variable. Inadequate local anesthetic spread can occur despite good technique, often due to because of facial separation or some compartmentalization. Technical factors may include like needle placement, or sometimes patient factors such as high BMI, any previous surgery, and it can complicate the matters. Now, looking at the last incidence, which is local anesthetic systemic toxicity, incidence in this key finding is quoted about 0.27 per 1,000 peripheral nerve block. And this is all based on the large registry data from Neil and colleagues. So that would be, I would say, 1 in 4,000 blocks. So it's not that big number. It's very rare. Having said that, this is potentially catastrophic. So it's very, very essential that we recognize it and we have excellent management plan. Anyone who is performing regional anesthesia, it is very important. The most striking recent findings coming from this publication, which has been published in January 2025 on British Journal of Anesthesia. So they analyze the all adverse events reporting system over 55 years, which was from 1968 to 2023. And what they found was very unexpected. It was like that from long-acting local anesthetic like bupivacaine, it has been decreased significantly after publication of some practical advisory in 2010 and 2017. However, lignocaine-related last death remains essentially unchanged throughout that period. So why is this happening? We still don't know fully yet. It might be because there's an increased use of lignocaine, particularly for when all the surgeons, they infiltrate lignocaine more than any other medication, any other local anesthetic. Or it might be because we all think that lignocaine is safer. So whatever the reason, this 2025 data make us more vigilant about lignocaine dosing and monitoring mode. So don't assume that safety just based on the agent. It based on lots of other factors as well. So when surgeon or patient, they say block isn't working, I think it's very important that time to have a pause and have some structured information, because having the systemic approach, it will prevent panic and it ensures safety as well. So let's walk through step by step. So first step should be immediate assessment. In that case, don't just ask whether block working. It has to be more specific. And that specific, what sensory distribution do you have? Is it patchy or is it complete failure in certain areas? What about motor function? Because those information will tell you what you need to do to rescue, or does it need the targeted supplementation? If we already have some ultrasound images, review them again, whether to just reconfirm if you could see the whole circumferential spread around the nerve. Other thing also to look into how long it has been done. Remember, the time variable is different among different blocks. So if you have done adductor canal block, it might take 15 minutes. Or if you do interscalene or any other facial plane block, sometimes it does take 30 minutes for complete block. So very important to have structured immediate assessment. Secondly, we're looking for anatomical review. As we all know, human anatomy is gloriously variable. So the nerve position can differ significantly compared to what says in the textbook. So for example, femoral nerve might be more higher or more deeper, or sciatic nerve, maybe bifurcation, more higher level. Or sometimes there's some septation into the facial plane block, which can limit the spread, which is very common, especially for the facial plane blocks like TAP block, serratus plane block. So it's always important or useful to quick rescan, reveal the tissue guide, and then change your strategy plan. Then third step will be thinking for supplemental option. So if there's a catheter, it's easy. Just consider might be careful top-up dose. Again, very crucial. Remember, what's your maximum dose? How much dose has been given? Because for bolus, if patient has only bolus, then it will be complementary. And for like other blocks, for example, if you're thinking about lower limb block, if you have adductor canal block and still partial failure, then we can think about supplementing by femoral nerve block or supplementing through the IPEC if there's only the posterior coverage. For upper limb, it might be if you had done the interscalene block or then the axillary block, patient might be more beneficial to have targeted peripheral nerve block. So key is mainly having a plan rather than reactive improvisation. Don't forget, safety always comes first. Patient who already had failed block, and if you have given another 2 supplemental block, it means this patient will be high risk for the systemic toxicity. Always make sure, check your cumulative dose meticulously. Useful, I think, as Henry said, you all write down the weight on the board and then see how much drugs you have given and how much drug surgeon has given. So have this cumulative dose meticulously and do the proper calculation. Always important to have monitoring, especially ECG and pulse oximetry. And I'm sure in your local policies, there is a intralipid lipid rescue always available. I think another thing not to forget about documentation, because if it is something toxicity, might not go ahead in the way you wanted, and there's a high chances it may end up in medical legal. So make sure you keep yourself safe from the medical legal point of view, and again, quality improvement. Regarding ultrasound guided benefit, so there is a study has done by Barrington in 2018. What they reviewed, confirm all the ultrasound reduces vascular injury, large pneumothorax, and phrenic nerve block compared to nerve stimulation. So they compared the both using nerve stimulation and the ultrasound guidance. However, using ultrasound, it doesn't eliminate nerve injury. And all the success still depends whether you are well-trained practitioner and have very sound anatomical knowledge, especially sonoanatomical knowledge. Ultrasound, remember, ultrasound is powerful, but it's not a magic wand. The loads of risk and benefit giving the rescue block. We all know that rescue block, or you say repeat nerve blocks, it definitely reduces meaningful opioid requirement. And also there are lots of restored benefits of regional anesthesia. For example, including improved pain relief in the postoperative period, quicker mobilization, and ready discharge as well to go home. At the same time, they are not benign. So if we keep giving incremental dosing, it quietly puts the patient over toxic threshold, especially if this patient has continuous catheter and keep having the repeated bolus. Also, when you look at the needling, you might be able to see the needle partially, not completely. And you never know that needle could be inside the nerve structure, even though with the ultrasound, there are reported injury of nerve injury with the ultrasound. Because there's also sometimes danger of masking compartment syndrome or ischemic pain, especially after trauma. So that's why giving the rescue block, risk and benefit, and on the conversation should be done with the surgeon, with the patient where possible. Clear documentation and have very low threshold to choose systemic analgesia if you already have given adequate amount or little bit more amount of local anesthetic to the patient. So it has to be shared decision. It can't be having the narrow focus that only regional anesthesia or rescue block will be beneficial. But when you keep thinking, giving more and more top up, think about having the second thought, discussing with the patient, discussing with the surgeon, and document. Now, last is recognition is absolutely critical. So if there is a local anesthetic systemic toxicity, as I said before, it happens very rarely. It's not that common. But when it happens, it has a high impact or complication, which must be at the forefront of your mind and always contemplating rescue blocks and top up. So risk will be higher if we have given the larger dose of to the patient, or if we have given long-acting agent, or the injection has been done in the highly vascular tissue, or in the susceptible population, like if patient is elderly, pregnant, any medical comorbidity, especially with reduced hepatic or cardiac reservation. Presentation about, I got this data from this 2024 guideline where Celebi and colleague, they have published in the clinical and experimental emergency medicine. So let's start with the CNS manifestation. As we all know, it's classically appear first. And the reason for that, because brain is more sensitive to local anesthetic than heart. And early signs, you might have seen tinnitus, which is like ringing in the ear. Patient may complain of change in the taste or some circumoral numbness or tingling, or sometimes agitation or confusion. These are just the warning signs. So if your patient reports any of this, your action should be stop. Stop immediately. Because if we don't stop, that CNS may go to the more progressive stage, which may end up with altered mental status, dysarthria, patient might not be able to speak properly, visual disturbances, muscle twitching, or tremors. This is more escalating towards seizure, and if it goes to the severe CNS manifestation include tonic-clonic seizure and loss of consciousness. That seizure can be brief, can be prolonged. Now, looking into the different system, which is the cardiovascular manifestation, it can occur same time, or it can be occur before or after CNS. So always very, very vigilant, because the early signs, it can be excitatory. So for example, hypertension, tachycardia, straightway because of the CNS stimulation. But sometimes when it goes more progressive, you may see the cardiovascular depression, which may include hypotension, bradycardia, or any kind of arrhythmia. If it becomes severe, patient may end up into the VT or VF, asystole, or complete collapse. As we all know, bupivacaine is particularly more cardiotoxic, and patient may end up having sudden cardiac arrest. Now, if you're looking at the more clinical pulse, so nearly 50% of last cases, they present atypically. So don't wait for textbook presentation or don't wait for any of the symptoms which we just discussed. Anything abnormal, think about last first. Secondly, about only 20% of the patient they presented with isolated cardiovascular depression without any CNS symptoms. And this is particularly very common in patient with bupivacaine and patient under general anesthesia. Because if patient having GA, it means we are already masking all the CNS effect. And up to about 20% of cases, it arises from simple tissue infiltration, not just because of the nerve block. As we already know the recent case of the hip surgery where it happened because of the local infiltration. So don't let your guard down just thinking, is a wound infiltration, nothing related to me. Bottom line, if there is any slash happen, it requires persistent and open-minded vigilance. Best thing, what it say, best standard says that you have to monitor the patient every 30 minutes post-injection, at least up to 30 minutes, very often, make sure there is no signs, and after 30 minutes, chances would be less. Any subtle neurological complaint or unexpected cardiac dysfunction, even like tachycardia, hypertension, it should prompt immediate cessation of local anesthetic administration first, and then maybe thinking about increase the number of observation. Let's quickly go through the management algorithm because this has been updated from 2018 by ESRA Practice Advisory Group. So let's go through step by step. Immediate action. First thing, as we all know, stop injecting. It seems very obvious, but it needs to be said because sometimes getting very narrow focus, we continue. So if you find out, other team member found out, please speak out loudly, stop. There's the word. Stop doing it, what you do. Call for help immediately. You definitely need extra hands, not only managing the patient, but doing the other stuff as well. We follow the ABC guidelines, definitely maintain airway, give 100% oxygen, big valve mask needed, avoid excessive hyperventilation because it may worsen the outcome. I'm sure you all do the cannula before the block, but if not, you will need the big wide bore cannula for the lipid rescue. If there's CNS manifestation, like you see the seizure, suppress them with benzodiazepine, like can be given midazolam or lorazepam, or can be given small doses of propofol, but use propofol only when benzodiazepines are not available. And try to avoid using propofol because if we give large doses, it may be the cause of cardiac instability. Lipid rescue therapy is the definitive treatment. We all know there's a 20% intralipid equivalent. Remember the dose, 1.5 ml per kg over 1 minute. So if you have a patient about 70 kilogram, it will be 100 ml per minute. Continue the infusion until hemodynamic stability is restored. If it's not restored, you can still repeat the bolus. And maximum cumulative dose you could give is the 12 ml per kg over first 30 minutes, which will be about 840 ml for 70 kilogram patient. Now, if the cardiac arrest occurs, make sure we follow the ALS guideline. So continuous CPR. You may need to modify something, like may need some vasopressin entirely if it doesn't work. If you have to give the adrenaline, make sure you reduce the adrenaline dose. It has to be less than 1 mics per kilogram. Frequently about, we say 10 to 20 mic bolus rather than standard 1 milligram bolus. And if you're planning to give any antiarrhythmic, try to avoid local anesthetic. It's very understandable, but easily get forgotten. So yeah, don't use local anesthetic as your antiarrhythmic. So no lignocaine, as it may worsen the toxicity. At the critical point, prolonged resuscitation may be required. Remember, the last induced cardiac arrest, it can take up to 60 minutes or maybe longer to reverse. So don't give up early. Not like after 20 minutes we stop, because it may take longer. Things to remember: continue high quality CPR and lipid therapy. If your hospital have ECMO access, might be considered for it, because if there's a refractory cardiac arrest, there are case report has been published where ECMO was helpful. Finally, very, very important to know where the lipid rescue is located in your hospital. And it has to be immediately available wherever regional anesthesia block or any regional block is performed. And make sure your team know where it is. It has been checked, stock regularly, and it hasn't expired. So let's talk briefly how this intralipid works. So if we look on the anesthesia review by McFarlane in 2021, and there's another review on 2024. So original theory was it worked as a lipid sink hypothesis. It means that lipid emulsion particles, they simply bind the free local anesthetic in the plasma, creating a lipid phase that sequestrates the drug. And now we understood more sophisticated than that. So current thinking is more lipid settle hypothesis. So how it worked? So lipid emulsion particles have strongly negatively charged phospholipid cell, and local anesthetic, they are positively charged lipophilic. They are fat-loving. So the local anesthetic molecule, they bind to these lipid particles, and then they take away these particles from high flow, high sensitive organs like heart and brain to the skeletal muscles or liver, where they restore and metabolize. It's not just binding, it's about actively redistribution of the drugs from the critical organs. And clinical evidence is compelling. There's multiple case report has been published where dramatic reversal of last with lipid therapy. Practically, if we say 20% intralipid concentration we are looking for, and it has to be at the room temperature, use it immediately. Now, when your regional block fails or you need to escalate to systemic analgesia, think stepwise and multimodal. An approach should be based on the ERAS principle and evidence-based multimodal analgesia guideline. So step 1, try to use the non-opioid. We all know paracetamol, NSAID, and ketorolac. Your step 2, thinking about using the another adjunctive. So 2 adjunctive, then 1. So might be ketamine as a sub-anesthetic doses. I'm not sure how many of you do, but the another one is NMD receptor antagonist. Step 3 is more judicious opioid use, not too much, very small dose. And step 4, again, is your rescue option when analgesia alone is not sufficient. So you may thinking about having the alternative regional technique block. It depends, is it partial failure or complete failure? Then looking for the multimodal analgesia. And there is evidence that this isn't just theoretical, but it's robustly supported by all the research. So if you look on the American Pain Society, what they define that multimodal analgesia is the use of multiple analgesic medication and technique where you target different parts of the nervous system. So there are lots of benefit, like it reduces the opioid dose, improve pain control, and their key component or key medication, which we already discussed. So why does opioid sparing strategy is so much? As we all know that opioid crisis, if it's needed, you have to focus on the immediate clinical issue. We all know opioid, when you're given too much, it can cause respiratory depression. And they also cause nausea and vomiting, at least about 30% of the patient. There are lots of other side effects, as we are aware, sedation, urinary retention, itching, constipation. So in the context of failed regional block, we try not to use the opioid just because we are trying to get this opioid sparing effect. However, if the non-opioid medication, it doesn't work, then think about using the small dose of opioid as a rescue. Let's go through a few case studies. I won't take much, so very briefly. Think about you have the patient who is 72-year-old, ASA 3, block for TKR, you've done the adductor canal block, working beautifully throughout the operation, didn't need anything, and now patient is complaining of pain in the PECU. As we discussed, I believe you'll be doing assessment first, make sure how much drugs has been given. Option here, if you're thinking about more rescue block, we can add femoral nerve block. If pain is more towards the posterior compartment, may think about IPEC. So if we say this patient had the femoral nerve block, pain improved, patient mobilized, no issue. Another case report, which is like 25-year-old ASA2 for ORIF distal radius. You may come across with this, may have like in your clinical practice, you may have come across with this situation before. This patient had axillary block with 20 ml of 0.5% lipivaquine, levobupivacaine, and now operation has started about 45 minutes, complaining of tourniquet pain. The option, again, first make sure all the blocks have done properly. If not, you can think about giving some additional musculocutaneous intercostobrachial now. I have been in this position before, and after 2 hours, when blocks effects start wearing off, first thing patient was feeling the tourniquet pain. Given the musculocutaneous block, which was accessible because you can give through axilla, and patient was fine afterwards. Another case, there's a patient for the post-laparotomy in the emergency surgery for bowel obstruction. Was fine throughout the theater. Patient had paracetamol, given 10 mg of oxycodone, and now complaining of midline pain in the PECU. Option can be think about the rectus sheath block, because there's more about midline pain and rectus sheath block, which help for the midline pain. So those are the case studies, just giving some example. What are the different ways we can use, or we can do the rescue analgesia? Remember, prevention is always better than rescue. So let's talk about how we can optimize our block. Technical excellence is always start with optimizing your ultrasound visualization. Take your time. There's no rush to get the best possible image. You may need to sometimes adjust the depth, gain, and focus. While doing the block, ensure that local anesthetic has spread properly. More better if you use the appropriate volume and give enough time. Sometimes we just keep checking the block after 5 minutes, after 2 minutes, and they say the block is not working. So make sure you give enough time to it work. Important to remember your safety maximization as well. Always calculate the maximum local anesthetic dose. Inject where is needed. And if you're not sure, just inject incrementally, just 1 ml at a time, and keep looking at the spread. Close monitoring, not only during the block, but after the block as well, and make sure you have the intralipid nearby. Patient safety is not only where you can just see the block and give the block, it's more about comprehensive approach. So if other thing, selection is very important. So if patient, any reason you're not optimized or not suitable for particular block, try to think about the different approach. So key message what I want to give here with the few things to remember. First, block failure occur in 3 to 15% of cases. It is rare, but if it happens, you have to have some troubleshooting and rescue plan. Last is rare, but very potentially fatal. So maintain the vigilancy. Multimodal analgesia, try to use it as an option because it helps to reduce the opioid consumption. Remember the latest data that lignocaine toxicity is the emerging concern. When we think about safety, every patient should have different, they are unique. So think about the maximum dose, how we can provide the maximize or safe anesthesia. Finally, adverse block experience are rich learning opportunity. Once you do it, once it's happened or anything it happened, make sure have the proper debrief with the surgical team, nursing team, and the operating theater department. Document, you may need to do datics, so document properly. And might be useful for these cases to present in the M&M meeting, audit meeting, because he's always learning, and have some departmental guideline, especially as we're talking about rescue club or rescue block. Thank you very much. And I'm here happy to have some question if needed.
Thank you. In the meantime, I believe I have sorted out the technical issues, so please accept my apologies again. Obviously, at every meeting, there's this one person who has learned absolutely nothing about video conferencing since COVID, and today that's me. So I'm going to circle back to the rib fracture presentation. I know we're overrunning a bit, but the presentation is actually fairly short. Hopefully, you'll be able to hear it now.
Good afternoon, everyone. Hope you're enjoying the presentation so far. And this is
Can everyone hear?
Dr. Dinesh, one of the Caesar Fellows in Anesthetics at Hull Royal Infirmary. And I'll be talking about rib fracture pain management at Hull University Teaching Hospitals. And I would like to thank Dr. Alan Race and Claire Eastwood, one of the acute pain lead nurses, for bringing this project this far and doing a lot of contribution for the rib fracture pain management at Hull University Teaching Hospitals. So we have done 3 rib fracture management projects so far. The initial one, I think it started in 2019, where following identification of suboptimal rib fracture analgesia, the aim was to improve outcomes by standardizing rib fracture care pathways. And after that, once we've established a rib fracture care pathway, we focused on evaluating block governance and documentation following the early success of this rib fracture passport. And this helped us understand gaps and implementations of SOP to ensure safe and consistent SAP and erectospinal block management. And with project 3, we did a rib fracture timing audit, where we tried to look into the timeline or timestamps when the patient entered the ED to the point he had his block done. So we tried to see the timeline of this travel, and then we tried to see if we are able to reach the standards that we set as targets. So the initial project started with Hull Royal seeing 160 to 180 patients any year, coming with multiple complex rib fractures, and they ended up with mortality and morbidity as these are silver trauma patients, and the estimated mortality was around 10 to 13%. So to begin with, they used to calculate a score based on the patient's age, number of fractures, where they were whether they were bilateral or unilateral. But there was absence of structural guidance for escalation, limited clinical value. So the pain score or the calculated score had limited clinical decision-making ability, as even simple rib fracture can have profound consequences for already frail patients. So this is the rib fracture score which was used initially, and it required to follow this fracture score calculation, and then you would get an advice on how to do the acute pain management in these patients. So what we have done is we've introduced the rib fracture passport, which helped us identify those at risk, stratify them, adopt a prognostic approach, prescribe optimal analgesia, and identify key process and outcome measures and check points to detect deterioration and promote quality care. So as you can see, we could classify based on the risk factors they had into low risk, immediate risk, and high risk. Based on the color they ended up in, that would tell us whether the patient required a discussion to have a SAP block or ESP block as early as possible. So three colors mentioned that the patient would fall into one of the categories, and then that would tell how to escalate this patient and what needs to be done. So the rib fracture passport is an all-in-one document. It helped us to stratification, as I've said, low, intermediate, high, whether the patient required serratus anterior pain block or erectospinal block insertion, documentation, prescription of the analgesia given through the catheter, daily monitoring, troubleshooting, identification of deteriorating patients, promotion of prompts for SAP or ESP block checks. Physio section was included in this just to make sure that we don't miss anything, and then that would give us the key to monitoring patients if at all they worsen, helping us to see the response to physio in terms of effective cuff, level of mobility, restricted as this could be restricted by pain, requiring oxygen, many other factors. And it also spoke about how to remove the catheters, rescue analgesia, IV PCA prescriptions, guidance, monitoring, everything would come under the Refracture Passport. And pain assessment, I think we've used Prince Henry Hospital Pain Score, and based on this score, we were able to categorize the severity of the pain and the effect of analgesia on deep breathing and puffing and other factors were taken into account. A score of more than 1 will automatically move a patient into higher risk category. And we measured the results pre and post introduction of Refracture Passports and associated process. Yeah, I think there was a significant difference in improvement in patient outcomes. And that led us to project 2, where initial success, and then we had to do the second QIP to improve the safety and efficacy of SAP blocks and ESP blocks in management of pain. So the problem was this time that we used to put side these catheters, but some of the times the catheter was clamped from the theater, and the next day, and the pumps had no alarm due to elastomeric pumps, because they were elastomeric pumps, and this was one of the limitation, poor documentation, sometimes catheters falling out, not properly documented. So there was a lot of issues in terms of governance and how we kind of delivered this care to the patient. So we tried to look into these bits. Service evaluation, as I mentioned, baseline data gathering, gap analysis was done, plan, do, study, act cycle was conducted. The sample of around 30 for both survey and documentation audits was done. We tried to involve many clinicians involved in as many as clinicians as possible involved in patient care to see how they understand and how the Refracture Passport works. The goal is to ensure, as I've said, the project aims for to make sure that the refracture blocks are managed safely, avoiding toxicity and failure. This means inserting clinicians and the staff caring for patients with SAP or ESP blocks must have a clear understanding of their responsibilities and safe process of managing them. So one of the interesting things which we found was most of the clinicians we surveyed were consultants or specialty registrars, both in ICU anesthetics and emergency department. 20% of them had no understanding of or did not know about the Refracture Passports. So then we thought that we would come up with some posters which we and educating the clinicians on how important the Refracture Passport is and how to safely provide this care to the patients. And then comes project 3, which was quite a recent one where we did refracture timing audit. So we just looked into the timelines of when the patient came into the ED, when he was referred, when the block was done, whether these numbers were matching the standards which we have set so far, which we had in mind before we started. So as I've said, ED, trauma, pathway performance, diagnosis, referral, SAP blocks, and delivery. So we tried to compare some of the standards with the compliances or the way we do things. We tried to compare them with few standards. So whether the refracture was diagnosed within 24 hours, whether a referral was made within 24 hours, SAP block was done within 12 hours. Yeah, I think we managed to achieve that as far as for 84.3%. But in high risk patients where the SAP block needs to be done within 6 hours, I think we kind of have a bit of a deficit in that, with 54.9% being complaint. So sometimes they are missing this. Theater transfers are happening within 24 hours, and then we found that we need to remind our clinicians again that we need to make sure that we follow the refracture passport. And the reason for a referral to have a SAB block or ESB block is not failure of analgesia, but it is more to be decided. It has to be decided by the category in which they fall, such as moderate, intermediate, or low, intermediate, or high risk. So if the patient is someone with high risk, as per the refracture passport, it is better to escalate them and let the clinicians know, or the clinicians will let the pain team know that the patient needs some sort of analgesia rather than waiting for the analgesia to fail, and then they would refer for a SAB block. So that also helped us understand that pain team should be made aware of all the patients who are getting these blocks, and they would review these patients regularly, and then that would improve the safety and efficacy in optimizing patient care. And I think we have already discussed about the audit standards and how far we have shown compliance with that. And these were some of the posters that were made from the project 2, and then we have added a few more posters to it, reminding the clinicians to make sure that they refer on time and understand how a refracture passport functions, so that when in doubt, think about SAB block, and good pain control prevents further worsening of the patient, and that would reduce the mortality and morbidity, hospital stay, length of hospital stay, and everything. So the overall outcomes are definitely better. And if you have any other questions, I think Dr. Jacob would be happy to take those questions.
Right. So thank you, Alan, Veena, and Dinesh, and Claire. We are a little bit behind, but we will do a short Q&A, and then we're going to have a break for lunch. Like I said, Dinesh is not present, but between me and Alan, I'm sure we'll be able to answer all the questions about rib fractures. Are there any questions here?
I think there's already a couple of questions in the question chat. So one question, thanks, Mustafa. The question was, would you advise reconsider using 2% lignocaine for axillary block? So I know what I said, that axillary block, lignocaine have high local anesthetic toxicity. Having said that, it depends what's the surgery. So in my own practice, I do use lignocaine for axillary block, but little amount. I don't give all 40 ml. So might be 20 ml max, 2% lignocaine with adrenaline. Because if my patient is for dupuytren's or just small, ring finger, nail repair, something like that, I just use lignocaine. Don't want to keep the arm down for a few hours. Only thing I wanted to say, if you are giving it, more vigilant, make sure more monitoring very often, and at least first 30 minutes, just to make sure it didn't go intravascularly. But yeah, in my own practice, I do give it as well. And I'm not saying you can't use it, just be more vigilant. Again, Mustafa and Komal, they both talk about the hip case. I know this has been mentioned in the morning as well in other talk. And I'm not sure how many of you are aware, but I remember, is it late 2024? There was a case published from Safe Anesthesia Alliance and Group, from Association of Anesthetists and Royal College as well, all talking about this case. So if I remember correctly, and Jacob and everyone else, please correct me if I'm wrong. So there was a case of 47-year-old who came for total hip replacement surgery in private hospital. I think it was Spire, not in Yorkshire, so don't worry. It was in somewhere, Cambridge or somewhere. Spire Hospital had a surgery. And what happened during the surgery? Surgeon give local anesthetic as infiltration, which we all allow them to do it. But there was some miscalculation in the dose. So instead of saying 40 ml, so they say 40 ml ropivacaine, but it's supposed to be 20 ml ropivacaine with saline, has to be diluted. And the nurse didn't dilute, gave all 40 ml, and it was low. I can't remember exact dose, but something happened like that. So basically, there was excessive dose of local anesthetic given, and which was ropivacaine. And that ended up having the patient toxicity. Patient didn't survive. She had refractory hypoxia, and then brain damage for 3 months, and end result wasn't good. So she didn't survive, and it went into the coroner, and then lots of guideline came up, and the latest guideline is, as an anesthetist, we are responsible to make sure local anesthetic dose has been calculated and given the right amount to the patient. Doesn't matter you doing it or surgeon doing it. Is the everyone responsibility? But in terms of dose and calculation of local anesthetic, I think we had to take lead. Please correct me if I'm wrong in any of them.
Yeah, thank you, Veena. I'm going to follow with other questions. I had a question for Alan about the AI-assisted devices. There is actually some evidence which I wanted to put, I'm going to post in the chat about the AI-assistive devices enhancing patients' access to ultrasound-guided regional anesthesia. And that's probably because of the effect that Alan has described, that the occasional practitioner might feel more confident to perform regional techniques with the assistance of the AI. I was wondering what is Alan's personal experience, how he would use, if he described himself as a occasional practitioner, how he would use the AI-assisted devices, and to what degree would he believe what it tells him, because there is a certain limitation in the ability as well. So would you use it just to sort of make sure that what you're doing is right, or would you use it on a technique which you have never done before and just be completely guided by the AI?
Hey, thank you. I think it's a good question. I think for me, it's a tutorial aspect to it. So that if I'm given the occasional list where there might be a block that I need to do, and I can kind of look on YouTube and which this is all really bad, but this is the practicality I think of people who are the occasional blockist. But I think get in early and use the actual system as a way, because there are tutorials on how to find things and how to do and what you should be doing. And I think having that confidence of something that is giving you some feedback, I think that for me would be the clincher for it and why it's worth the investment. Because I think we're all a bit scared, especially I'm a 50-year-old anaesthetist now, and I don't want to look like a fool in front of some person who's really good, and they look at my needling and go, "Oh my God, that's really tragic." I mean, I'm not that bad. I don't think I am. Anyway, and sometimes I'll even just be asked to go off a list because I know that there's going to be upper arm blocks, and because I just don't have the confidence to do it, and that's the truth. I think we all need to have these things integrated throughout our training. I think we all need to be blockists. I think looking at my I showed you the graph of opioid consumption and it being the mainstay. We just all need to be able to do this, I think, as standard, so I think it's coming. I think it's good. I think the evidence for it is pretty strong for people like me. I think people like you, Jacob, I know you're an excellent blockist. But you're the person who leads the way and informs the AI, and then people like me can then use it slightly more confidently, I think. So I think it's that. I think it's the tutorial aspect and the just feeling a bit more confident on the list. Yeah. Does that answer your question?
Yes, it does. I just have to put a little bit of a disclaimer here because Alan was actually my teacher in some of the regional techniques I'm doing. So he's significantly underplaying his abilities here.
I think we all have to be honest. If I don't, sometimes I even put in an arterial line in. I'm an ICU consultant, and I'll do, and I'm like, oh gosh, I feel a bit nervous about it. I think we just need to be honest about these things, not be afraid to ask someone next door. Can you give me a hand for this? Because I'm, and that's the art of leadership. It's not about kind of blagging your way through. It's just being open and honest and saying, look, I've got a whatever block to do, could you come and give me a hand? But I do think this will give confidence to trainees. I think they'll go away and mess around with it and in their own time start to think, oh, I could actually do that. And so yeah, I think it's I would definitely use it.
No, I definitely agree. I think they are amazing tools for reassurance and for the blocks which we all have blocks which we are doing less frequently than the others. So yeah, I think for training purposes and a bit of a reassurance, and as the evidence shows, it does enhance the patient's access to regional, and that's what we want ultimately. Thank you.
Yes, awesome.
And Alan, thanks very much for your comment in the chat. I agree, all the patients are not same. And as you said, the last was involved in facial iliaca block. It's not only the local anesthetic dose. There are lots of other factors as well, as we discussed. It can be intravascular, can be in different planes. So yeah.
I think again now with modern AI, because I'm a statistician now, and these things we'll start phenotyping these patients and start looking through, like, because we've got more data and looking at things like clustering and is there a family, because they're such rare events, so it's very difficult for us actually to pick up on this sort of stuff. But with AI, where you've got kind of sparse data, I think well, machine learning, this is the future, and I think we'll have more phenotyping.
Yeah, and I think beyond phenotyping, I think we might be able to do some more advanced pharmacokinetic modeling as well to tailor to the patient's specific conditions. How is the pharmacodynamics and pharmacokinetics of the patient influenced by his current condition in regards of the local anesthetics and the maximum dosing. Very good. There's one more question for Alan in the Q&A. Dr. Bahadia is asking regarding the ZYNRELIEF. What might it offer over our standard multimodal analgesia practice using regional techniques and systemic insights?
So I was putting it more, these, because there's such sparse kind of developments in a lot of these things. But we've got liposomal bupivacaine and things like that. It was more just the kind of standard things that we do within our practice. Say if I'm doing a hip or I'm doing a knee, or how would it add any advantage? Would it? I think it's marginal. I think so the area under the curve study, which integrates pain relief over the first 24 hours, pretty much suggests that if anything, there's just equivalence. So it's an expensive drug. Does it really afford any kind of specific or improvement? Probably not. But it's just, I think we all need to be mindful that we have this opioid, and this is why we're here, isn't it? Essentially, this is why everybody's gathered here, because we're all mindful of the fact that opioids kill people. They do. Chest infections, bladder infections, all of this evidence is coming up, and I think, we need to be using other things. So does it have any improvement over just standard, like, who knows? And the other thing, so one more thing that I wanted to mention actually is these new drugs, and we're talking about local anesthetic toxicity. How do we know how they interact? So we've also got to be mindful of not being too excited about novel things, because I don't know whether these new sodium channel blockers interact with local anesthetic. So I mentioned this kind of idealized pathway, but it could be that they actually cause damage by having lots and lots of things hitting, kind of firing sodium channels, and we need sodium channels. That's how we exist, or a lot. So I think we've got to be really mindful of new and novel. But do I think it will? I think the cost is prohibitive, and I think that would be why I would say no. I would put a big cross on that one. But we do need to stop using opioids, and if this new sodium channel blocker does afford benefit, then I think we do need to be considering it. And a lot of the studies I did a pros and cons. So withdrawal doesn't happen even when you terminate it acutely. The main side effect was constipation. So mild constipation. So I think these things are coming, and I think we need to embrace them. Did that answer your question? I don't know.
Yeah, I think it did answer the question. Thank you. I had one more question for Veena, actually. I'm just putting up the QR code for the quiz, because the first round of quiz is starting now, if any trainees want to attend. But for Veena, do you run any multidisciplinary simulation trainings for management of LAST in your hospital?
So in terms of training, there is no formal training, but is the part of the course which we run, and every teaching, what we do for the ST1, ST2, and stage 2, there's a part of the teaching.
Right, but you don't run them multidisciplinary, like involving, the ward teams which are looking after your patients or recovery?
I don't get involved directly, but it might be happening, which I'm not aware. I'm sorry, Leeds is like, we have 5 different sites and 200
Sure,
consultants.
absolutely.
So
Yeah, I appreciate
it's
it.
tricky.
And I have one more question for Alan, and this one is about setting up this big project for rib fracture management. I've been approached by a couple of colleagues from outside of Yorkshire recently, and they wanted to look into something like this, and they were looking into the challenges. I was wondering whether you can tell us what was the biggest challenge to implementing some big change like this?
So wow, I mean, the backstory is that we essentially were peer reviewed and we failed. We were sending these poor patients to the ward on probably just paracetamol because everybody was worried about polypharmacy, and it was like, we don't want to give too much analgesia because it might cause harm, but actually then patients screaming in agony. So we were peer reviewed. I came in, I analysed it, and then it was a lot of hard work. Really, it was. I'm a believer that we as consultants should roll our sleeves up and be doing it ourselves, not kind of writing some terms of reference and saying this, we want this and we want that. That you have to, people have to smell and taste success. So I would come in and SAP blocks versus ESP. I chose SAP blocks because they're simple. You can train nurse practitioners to do them. They're relatively straightforward and safe. I know we're worried about local anaesthetic toxicity in these patients, but also rib fracture pain is a significant killer. 15% mortality in these elderly folks. So, I wanted to standardize the whole thing. I got theatres involved because I knew that you would get a better service, a bit like central lines. If you do something in theatres, there'll be all the sort of subsequent steps from failure will then be analysed and then, help got. So there's an escalation, like literally embedded within the whole thing. And, PACU nurses will not stop badgering you until, they know something is working. So SAP blocks, because positioning is easy. Often these patients might have other broken limbs or whatever, so you don't want to be like positioning somebody in awkward positions that's going to make them yelp and it's going to be awful. And they do work. If you look at the other early studies, the early work that we did, we use the Prince Henry Hospital pain score. It's a standardized score. It's a dynamic score. If you use visual like scores or you do number scores, but like it's the inter-rater kind of variance is so wide because some people will say, can you move and does it hurt? Or some patients will just they'll just say, are you in pain now? No, I'm not in pain. So there's that variability. So we wanted a dynamic score, but we also wanted in it like the ability to escalate should things not be working. Now, I think it's really interesting. I think the fact that we've got 83% within 12 hours, I think is pretty good, right? So that was what the finding was. Now, picking these poor patients up is hard because they're often elderly, fall from height, they've got an AF or whatever, they've broken a rib, they go to a ward, they don't really get seen, and then we eventually find out that they've got rib fractures, and then there's this delay in recognizing it, and then we get them to theatre. So I guess my quality improvement is about us as consultants rolling our sleeves up and getting dirty and convincing people that things work. And that's what I did. I had a curmudgeonly anaesthetist who was well known, really kind of like, well, why am I doing this? And then I showed him that it works, and then that was it. It was bought in. So that's it. I think you need to taste and smell success, and that's how you work it.
Yeah. So
sorry,
don't be afraid to be the pioneer. I'm very
passionate about this because I it was my baby and I really worked hard. And what's beautiful about this is that true kind of quality improvement is like I've handed it over to you guys. I don't get involved anymore. You guys are like pushing it, and that is when you know that something really is working. When people still want to maintain that standard and there's not that horrible drift down the line. So I think well done to Hull, because we've done a fantastic service, and everyone's brought in physios, nurses on the trauma ward. They all ask for these blocks if they see a patient who's got rib fracture. So I think we've done a really good job here, and no wonder that other hospitals in the region are really interested. Anyway, I'll shut up.
Thank you, Alan. So this is exactly why we have you here, for this excellent passion for the project and for the goal. So I think the bottom line here is it's a very powerful message. Don't be afraid to be a pioneer. If you're convinced about the benefit of your idea, start it yourself and build it up against all the odds. And you can see
you're doing something now, aren't you? So you're doing a similar thing. So you're convincing, and that's one of your talks later on, is like to do lower limb blocks and set up a really stringent kind of escalatable service if something's not working in these patients with ischemic limb pain. Anyway, I am going to genuinely shut up.
Yeah, I think this is an excellent bridge for the after the lunch talk. Actually, there's one more question for Veena, and then we're gonna leave you for lunch. Veena, someone called AS is asking that sometimes it's a bit difficult.
Jacob, I won't take long. So two things. First, you talk about the last training in our trust. So yeah, one of our regional fellow, he has already documented. One of my colleague consultant doing it. I'm sorry, I wasn't aware, but it's happening,
Awesome.
which is good news. Yes, your question is about what would you do? Like failure rate, I agree, because the facial plane block, they are not as clear as the nerve block, because in nerve block, you can see the nerve, you get the nerve, and you are like 99% sure it will work until unless there's some anatomical variation. Plain box is always tricky. Again, I would say depends. Two factors: how much you are comfortable doing that block, and the other thing you already said, if surgeon does it by properly. Because some of the block, I definitely believe on myself doing it, because when you do plain block, for example, PENG block or IPEG block, you know you have given in that particular plane, and that the distribution of the block will be covering the area, the surgical area. When surgeon gave it, is mainly the wound infiltration. So the pain relief would be different if surgeon gave it or you gave it. Again, if you're not confident, I'll let surgeon to do it. If some block I'm not confident, but the block which I'm confident, I do it myself because I know it will cover majority area. Like for breast surgery, we know SAB block and PEX block, if you combine, do it properly, it works better than the local infiltration. Post-op opioid requirement is less. Same in the hip. If you do the PENG block, it's better compared to local wound infiltration, what surgeon does. So yeah, it's all, there are multiple factors. I won't say one is better than other. It all depends how much you're confident and how much you trust your surgeon.
I think this was an excellent summary, because these debates are never ending at every regional conference. But I think you summed it up really, really well. Thank you very much. Once again, thank you to all the presenters from the session 2. There's going to be a lunch break. We're going to be starting again at 1:45. Sorry about the slight overrun and some technical issues. And after the lunch, we will look into the blocks beyond. The session is called Beyond the Block, and we will have a look into different patients' journeys outside of operating theater. We will explore the new transitional services, the transitional pain services, and we will look into patients' journeys in obstetrics and pediatrics. So several really, really nice talks ahead of us after the lunch break. Thank you. I'll see you at 1:45.
Thanks, Balaji and Jacob, for having me, and thanks everyone. See you after lunch break.
Welcome back, everyone. It's 1:45, and we are ready for our next session, hopefully. I have put on the QR code for the Ezra quiz, just because another round of quiz will be starting at 2 p.m. So if you're interested in taking your chances at winning this free access to Ezra Lisbon conference in September 2026, don't hesitate and sign in either at 2 p.m. or 3 p.m. Right, now I'm going to stop sharing this. And I'm going to move on to the next point, which is going to be the session 3 Beyond the Block. And we're going to be exploring different patients' journeys throughout the hospital admission with regional anesthesia. I'm going to share my presentation with you because I'm going to be presenting the next project. There we go. Right, very good. I hope you can all see my presentation here now. Cool.
Yes.
Thank you. Thank you. So the next project I'm about to present is about regional anesthesia beyond operating theaters, because I think this is a direction where a lot of the regional anesthesia will be heading when we are expanding the applications and trying to bring the benefits of regional anesthesia to more patients, which is obviously often exceeding our theater capacities at this very demanding times we are finding ourselves as an NHS or any other healthcare system. I'm going to be talking specifically about regional anesthesia and chronic limb-threatening ischemia. Now, I would like to pay my respects to our vascular surgeons, because as you will see in a short while, it's a very surgical-driven project. And I have to thank our vascular surgical team for being very goal-oriented and enabling us to bring this project forward. At the beginning, I just have to declare conflict of interest, and I have none, so we can move forward. A little bit of a background about chronic limb-threatening ischemia. It's the most severe form of peripheral arterial disease. Approximately 30, the incidence is approximately 36 in 100,000 inhabitants, and about roughly 10% of patients with peripheral arterial disease will eventually develop a chronic limb-threatening ischemia. So the disease burden is quite high, and particularly in deprived populations like the one where I work, we do see a fair amount of these patients coming through. They usually present, or at the point where we see them as anesthetists, they present with debilitating, severe ischemic pain, which is usually at rest. Now, the background of the pain is a combination of multiple principles. There's an ischemic pain, obviously, as the mechanism suggests, but there's always an element of neuropathic pain. There's an inflammatory pain. There's pain coming from the leg wounds, and there's a certain degree of central sensitization as well. So because the mechanism is so complex, I think it's no surprise that the management is usually quite challenging. And it consists of a combination of simple analgesics, as you would guess, but often these patients require opioids, and I mean high doses of opioids. Often they end up on BCA, for which obviously they need ward admission, sometimes purely for the analgesia. And there's a certain role for neuropathic agents as well. Leaving the pharmacological interventions aside, there's space for non-pharmacological interventions, as attention to the leg wounds and the leg ulcers, There's positioning therapy and physical therapies. And as a final step, the revascularization, so the surgical input. Now, if you have a look closely on the patient's journey when the patient presents with this condition. So as I said, the patient presents with very severe ischemic pain at rest, which is debilitating and limiting all daily activities. So the patient very frequently escalates very quickly to strong opioids, often PCA, which we know from the literature that is fairly ineffective for ischemic pain. There's a high risk of side effects, particularly in the side of comorbid, usually elderly patients who are vasculopaths, which affects multiple other systems like kidneys and the liver as well. And the high doses of opioids and PCA usually requires a certain level of supervision, so the patients require admission to ward areas with adequately trained staff. For inpatients, they undergo a series of investigations to plan for the final management, which usually consists of angiograms. Now, from our internal data in the hospital, the interventional radiologists tell us that 25 to 30% of these patients fail angiogram under local anesthesia. That's probably because the contrast injected causes a bit of a vasospasm, and in already compromised perfusion in the leg, this exacerbates the pain, and the patients can't tolerate it. That means that the procedure has to usually be cancelled. There's a bit of a delay in the diagnostics, and they have to be rescheduled for a session under general anesthetic, which is obviously limited. And it uses up more resources and exposes patients to risks coming from the general anesthetic. Following the diagnostics, the patients undergo their definitive operative management. I'm not going to go into the details of that, as you know, I'm not a surgeon, and eventually end up with this shiny new leg and leg survival, or the other on the other side of the spectrum, like amputation. Now, we've been looking into this process, and we've been trying to think of ways how we can improve the patient's journey and experience. And the intervention we came up with was the continuous popliteal sciatic nerve block. Right. So let's have a look on this journey I've just described with introduction of the block. So the patient still presents with a severe debilitating ischemic pain. At this stage, we would insert the popliteal catheter with continuous local anesthetic infusion. Now, from our experience, if the block is sited well, this can have an enormous impact on the patient's pain trajectory, and that's usually marked already in the theater, or when you wheel the patient to recovery, the pain scores come down dramatically. That means we can reduce the amount of opioids that the patient is taking. The patient can have effective pain relief with minimal side effects, can potentially ambulate, and I think there's a potential for sending these patients home and bringing them in for the investigations as an outpatient only as well. So you can already see a very positive effect here from the patient's perspective, but from the health economics as well. Now, the angiogram, we are hoping to see that these patients with functioning blocks will be able to tolerate the angiograms, and like that we will avoid the need for general anesthetic, which will shorten the time to final diagnostics for the patients, and obviously avoid the side effects and the risks associated with having general anesthesia in this high-risk population. And eventually, we are hypothesizing that the infusion of local anesthetic might even improve the leg survival through the vasodilatory effect of the local anesthetics normally have. Now, I know that this is just a hypothesis. There's obviously a lot of visual thinking in that, and we don't have much data for this, but it's certainly a plausible theory which I'm just throwing out there. And I'm not making these effects up. There is some elementary evidence in the literature already published. So there's a couple of studies which show that the regional anesthesia for ischemic pain is very efficient, and it reduces the opioid consumption. There is even some literature published on the efficiency of analgesia in interventional radiology suite for investigations in ischemic limb. Now, I appreciate that all these studies are small. They are single-center studies or small case series. And there is some suggestive studies which again support the plausibility of the hypothesis about the limb survival I have suggested. So there's a couple of, again, very, very, very limited studies which sort of show very limited case series, or in the case of the second one, only a case report of improved perfusion in the distal limb after the peripheral nerve block. So how we decided to set up the whole process of this catheter service. Now, I've mentioned at the beginning that it's a very surgeon-driven protocol, and that's mainly because of the restrictions we encountered with the staffing. We don't really have a space to offer yet another theater space or a theater session just for popliteal catheters. So the surgeons took lead in this project, and they want to be the operators in this procedure, which poses us in a quite unique situation when we have fairly complex regional skill to someone who doesn't routinely provide regional anesthesia. Now, that obviously requires some training, so that's a very important part of the whole process here. I'm going to have a few words about that, and I'm going to talk you through some of the steps we include in our training. And I appreciate that a lot of you are probably very keen and experienced regionalists, and some of those steps might be feeling a little bit elementary. But I felt it's important to highlight what I think is perceived as an important aspect from our surgical colleagues. And also it might be some important details for people who are coming from different backgrounds. So our training sessions are hybrid training sessions. They consist of some theory lectures. We had to cover the basic principles of ultrasound-guided regional anesthesia to the surgeons who don't normally practice these techniques. We have to introduce the basic safety elements, so especially the anticoagulation. We had to have a consensus. We had to reinforce the safety in regards of the prevention of a nerve injury, train them for the recognition and management of blast, train them in the stop before you block initiative, etc., etc. So all these safety aspects are considered and they are included in the training. Obviously, the second part of the training is practical hands-on ultrasound training. We use the needle trainer, which is an AI-assistive device and enables virtual needling. So we scan each other in the sessions to get more inter-individual variability in the short period of time, and we can be sort of sticking this virtual needle into each other's popliteal fossas. Now, after the training follows a robust preparation of guidance and SOPs, and we have prepared a catheter passport, which is very similar to our refracture passport, with which we have a very good and rich experience. So it was a great base to build on. And the documentation of the protocols of the infusions, etc. We will have to follow the training of the ward staff, again, mainly to consider the risk of blast. Now, initially, the surgeons will be inserting these catheters in the acute vascular theatre list under the direct supervision of a vascular anesthetist. We appreciate that some of the anesthetists might not necessarily be keen regionalists or might not be familiar with catheter techniques, but they all appreciate the safety aspects of regional anesthesia, and they are mainly there to sort of supervise the safety of the procedure rather than the technical aspects. There's a competency assessment tool which we have developed based on a simplified Delphi process and the previous literature, which I'm going to show you in a moment. And eventually, when the vascular surgeons have enough exposure and they build up the competency, then they will transfer this skill completely out of the theaters to the vascular ward when they will set up an intervention room. And and the patients are obviously followed up by our experienced pain team who have extensive experience with other catheters we insert in our hospital. Right. So now, how did we choose? In prone position. or we're showing them the lateral position as well because there's some advantages. The lateral position usually brings the sciatic nerve a little bit more superficialized, a little bit more visible. But the prone position offers the advantage of stability of the operating field because the patient is not moving, and the patients are usually able to put themselves in the prone positions themselves. We are using the Contiplex kit from the B Brown because that's what we have at the moment. It's a specialized continuous peripheral nerve block kit with a catheter. So it's all part of one pack, and we have a volumetric pumps. However, our organization is planning to switch to electronic pumps in hopefully upcoming weeks or months. It's a fully sterile procedure, which I'm hoping is not coming as a surprise to anyone because we are leaving a catheter in, so I would definitely highlight that it needs to be considered a fully sterile procedure. What might be a surprise is that we have chosen to do an out-of-plane technique in the short axis approach. Again, I presume that most of you will be familiar with doing single shot blocks in plane. However, after the discussion with the vascular surgeons, they do a lot of their vascular access under the ultrasound guidance out of plane. So they are familiar with this approach. And there are some benefits which I'm going to show on my next slides as well, coming from this out of plane approach. Yeah, this is just to illustrate how the out of plane approach to popliteal sciatic nerve looks like. Now I'm going to play a very short video, which I'm showing to the vascular surgeons as well. This is how the out-of-plane popliteal sciatic nerve block looks like. So you can see that the needle visibility is obviously compromised from the approach, and we are relying to a certain degree in indirect signs of needle passage. But you can see here on the injection, this beautiful spread of local anesthetic is amazing. How it spreads within that perineural sheath. You can see the whole volume when they are slowly injecting now, staying in the perineural sheath and just separating those two components of the popliteal sciatic nerve, the peroneal nerve and the tibial nerve. Yeah, I'm going to play it shortly again here. So indirect signs of the needle passage. You need, despite not being able to see the whole length of the needle, is to have a very good control of your needle tip. But if you get into the right place, you do single spot injection, and you have a beautiful surrounding of both nerves within the perineural sheath. Obviously, this is not my video. This is a video from Dr. Kalava, which I found on YouTube, but I just found it amazing. Now, some of the evidence for the choice of the technique we have chosen to use in the end. The first one talks about the different approaches of insertion of catheters in the popliteal fossa, and it compares the out-of-plane and in-plane technique. Now, if you imagine how the catheter aims at the nerve when you do an in-plane approach, it aims perpendicular to the length of the nerve. And this study showed that the displacement of the needle tip is high, up to 40%, as compared to only 10% when you insert the catheter parallel to the length of the sciatic nerve from the out-of-plane approach. So the out-of-plane approach has a significantly lower rate of catheter tip displacement. So that obviously means you have significantly less secondary failure of your catheter, and you don't need to bring the patients back in for repeated procedures and expose them to repeated risks. I've also put a beautiful study which showed how to fix the catheters. So we definitely tunnel I'm training the surgeons to tunnel the catheters and use the skin glue. So I think tunneling is amazing, and it reduces the risk of infection, but significantly reduces the risk of dislodgement of the catheter. So if anyone is interested in this technique, please scan the QR code, and you can see this interesting study. Now, I've mentioned that we have developed a competency assessment for our surgeons. So it consists of a checklist of 15 critical steps, which the surgeons should achieve during the procedure. And there are steps which are part of the setup, how sterile, how they maintain the sterile field, how they check the equipment, how they flush the catheter, how they handle the ultrasound. Now, bear in mind that the surgeons in our situation are novices in regards of regional anesthesia, but they are certainly not novices in the ultrasound-guided procedures. So the vascular surgeons do a lot of ultrasound-guided procedures in their own practice. So it's a bit of a different setup than training novice anesthetic trainees because they have a good control of their image and they have good control of their needle. They just need to apply their skills to sticking the needle into different tissues, if you will. There's also a quick list of 6 critical errors they should avoid, which mainly stem from the safety principle to avoid the needle contact of with the nerve tissue, to avoid intraneural injection, to have a good control of your needle tip, even though it's an out-of-plane technique, and we appreciate that you won't be seeing the whole needle path in your patient, and you'll be relying on the indirect signs. And there's a global rating score which sort of sums some of these steps into more holistic groups, like maintenance of safety, maintenance of asepsis, and how smooth is the control of the needle, etc. As I said, it was a sort of simplified Delphi process, but it's mainly based on these, not exclusively, but mainly on these fairly recent articles, which develop competency assessment tools for ultrasound-guided anesthesia and for regional anesthesia with catheter blocks. So if anyone is interested in this methodology, I recommend these for you. And now we obviously decided that we want to take this project further, and we want to quantify our results. So we have suggested this Popeye trial, which we hope is going to end up being a multi-center parallel group randomized controlled trial, where we will be comparing ultrasound-guided insertion of perineal catheter to peripheral nerve compared to the standard care. Our goal is to assess the efficacy and safety in this setting, and we will obviously follow the clinical outcomes of reducing the pain scores and obviously reducing the opioid consumption. We'll be following the reduction in the necessity for general anesthetics as well. As the modern practice recommends, we'll obviously be following a lot of patient-reported outcome measures through various scoring systems. Eventually, I think from the long term, we should be able to look into the limb survival as well if we manage to have a good set of patients involved. And this project will have eventually 2 phases. So currently, we are at the beginning of phase 1, when we are developing the local process and training the surgeons and assessing their competency. And eventually, we will transfer the skill to the board, as I mentioned. And currently, we are applying for the effectiveness implementation feasibility trial, just to see what are the barriers and what are the enhancing factors in implementation of this brand new service to an area where it hasn't been used before. We'll be analyzing it based on the normalization process theory. And we'll be following up some feasibility and implementation outcomes as well. Once this is done, then we will obviously try to apply for a phase 2 multi-center prospective randomized control trial. And I believe I'm using up all my time, so I'll finish here. And I've overrun slightly, but I apologize to Dr. Sanem, and I'll pass the mic to him. I'll be looking forward to your questions at the end of the session.
Thank you, Jacob.
The floor is yours.
Are you able to see the presentation?
Yes, we can.
Yes, sir. I'm Dr. Sanem. I'm a pain consultant and clinical lead for pain at Hull University Teaching Hospitals. Today, I'm going to be talking to you about transitional pain services, bridging the gap. The concept of transitional pain services is not something new. It is well established in Canada, Toronto General Hospital. It is, in fact, well established in some of the centers in the US as well. Coming to the Europe, there are some centers which has got transitional pain services. But in the UK, unfortunately, I think it is still at the very, very early stages. So what exactly is transitional pain services? Transitional pain services is a comprehensive multidisciplinary pain management program for patients who are at risk for post-surgical pain and disability. What the focus here is on the patients who are at risk for post-surgical pain, and it is to improve the quality of care we provide for these patients. Chronic post-surgical pain, is it a big problem? In fact, the incidence of chronic post-surgical pain, if you take, it is significantly high. It is about 10 to 12% of patients suffer with severe chronic post-surgical pain. Of these patients, 2% complaints of severe pain, severe post-surgical pain. To put into perspective, when I was looking at the previous data, there's almost like 2 million intermediate to major procedures are performed in the UK. Of these, if you are saying 2%, that is about 40,000 patients are added to the community with chronic post-surgical pain. And significant proportion of this pain actually is the neuropathic pain. So it is like a tip of the iceberg. There is a very big problem which probably we are not aware of, because most of the times after the patient is discharged from the hospitals, they are managed in the community. Unfortunately, we don't have a contact with them, so we are not particularly aware of this bigger problem. So we know there are some surgeries which contribute to significant severe chronic post-surgical pain, which includes amputation, cesarean deliveries, inguinal herniatomy, mastectomy, and thoracotomy. If you look at most of these surgeries, the neuropathic pain is significant. Actually, if you look at amputation, where there is actually injury to the nerve associated with most of these surgeries, the neuropathic pain is about 80%. Coming to cesarean sections, how many of us actually know that they can have a severe chronic post-surgical pain, and the neuropathic pain in these patients is about 50%. It's quite significant. Likewise, in herniatomy also, neuropathic pain is about 80%, even though the severe chronic post-surgical pain is seen in 2 to 4%, they suffer with neuropathic pain, 80% of them. So the reason why we should know about this is because if the surgeons are consenting these patients, and if we are more explicit in explaining these patients about this, the chronic post-surgical pain and the severity of the pain, probably if the patient is coming for example, inguinal herniatomy, and if you explain that the pain can be very severe, they may change their mind of having a surgery if they're coming only for the pain related to inguinal herniatomy. So likewise, we know some of the surgeries which could be contributing to a severe post-surgical pain, and we have to be explicit with these patients about when we are consenting. So now the issue is, what happens to these patients once they are discharged and when they are suffering with this chronic post-surgical pain? Unfortunately, these patients are managed in the community by GPs, or sometimes these patients are referred back to the surgeons. And we know their experience in dealing with acute pain is not that great. So most of the times what they say is, what we see is these patients are put on strong opioids, okay, to manage their pain, even though they are in fact, they are not managed appropriately. The consequence of this is opioid crisis, which you have seen in USA. So if we look at it, actually, it all started with prescription opioids in 1990s, late 1990s,
where there was an increased push for prescription of stronger opioids in managing. In fact, it started for cancer pain, but it was pushed to manage chronic pain. And that is contributed initially to the increased number of deaths. But later on, these patients who became addicted started taking street drugs. The reason, especially in USA, why the patients started taking street drugs is because most of the prescriptions in USA, they are like available only on payment. Okay, you have to pay for the prescription. So people who cannot afford those prescriptions started taking cheaper drugs, which are available in the streets. That is, most commonly, they were relying on heroin. And afterwards, because the heroin is kind of not available in the pure form, later on, they started using some more pure drugs like a fentanyl, which is available in the market these days. And in fact, it is very pure. They get high with that. And also, it is easy to smuggle, apparently. And that is the reason, if you look at it now, the deaths related to opioids in USA is more to do with fentanyl. So even though it is not the prescription opioids which is contributing to majority of the deaths, it is definitely one of the reasons what is contributing to number of increased deaths in the USA. And if you look at it, approximately 200 patients die, or 200 people die of opioid or fentanyl or opioid-related deaths, what we see in USA these days. And it accounts to about approximately 70,000 deaths in USA every year, though it is decreasing currently. In the last 2 years, there is a decreasing tendency in opioid-related deaths, but it is mainly because of the availability of naloxone freely in the market that reduce the number of deaths. But that doesn't mean the dependence and addiction has reduced. It's only the number of deaths has gone down. If you look at UK data, as some of our colleagues have already mentioned, there is a gradual increase in deaths related to opioids. And it is in 2024, there were about 2,600 odd deaths related to strong opioids compared to previous years. We started with very low. Obviously, it is not as bad as in USA, but it's definitely, there is an increasing trend. So what I would like to say is we have a definitely gap in here, okay, where when the patient is admitted to the hospital, we take care of these patients, and we are managing very well when they are in the hospital. We got acute pain teams taking care of these patients. Once they are discharged, unfortunately, there is a vulnerable period where the patient's pain, which is starting as an acute pain, going through becoming a subacute and then becoming chronic. During this phase, during this vulnerable time, they don't have any support. They mostly rely on GPs or the surgeons to manage their pain, which is, as we know, it is inadequate. And before they become more chronic, and by that time, the changes in the body has happened, like peripheral sensitization, central sensitization, neuroplasticity has happened. And by the time they reach the chronic pain teams, it is well established, and it is very, very difficult to treat at that time. So what with transitional pain services, what we are trying to do is to bridge that gap from acute pain to chronic pain. By transitional pain services, we'd like to modify the way the acute pain changes its course. So the transitional pain is not just for the gap here. They provide, they manage the pain even before the patient is admitted to the hospital. They identify these patients during the time of a pre-assessment, okay? And high-risk patients, once identified, they are referred to the acute pain services or acute pain team or transitional pain services, we can say. And then they have a management plan in place to manage these high-risk patients. And then during intraoperative or during their admission to the hospital, their pain is managed. And then after the discharge, they continue to provide that service until 3 to 6 months. And hopefully by doing so, by providing this transitional pain services, what we are intending to achieve is mainly the aims of this service is to reduce the incidence of chronic post-surgical pain. That is one thing. Optimize opioid management post-surgery and improve coping function and quality of life after surgery. That is the main aim of this transitional pain services. And what is the constitution of these transitional pain services? Obviously, it has to be a multidisciplinary model. There should be pain specialists and anesthetists involved in this, pain specialists, nurses, psychologists, and physiotherapists. So how do we deliver these transitional pain services? As I said, early identification of these patients is a key. During the pre-assessment, you identify these patients, and if they have, these patients on strong opioids, or if they have some psychological vulnerabilities like anxiety and depression, identify these patients and refer these patients to psychological services. And if the patients on strong opioids, have a management plan, perioperative management plan when they come for the surgery. So during the admission, you implement the plan by regional anesthesia and multimodal analgesia. And if they need any psychological support, provide that psychological support, and also continue the support post-discharge. Okay, you're not just leaving these patients after once they are discharged, especially during that vulnerable time where pain is changing from acute to subacute, where they needed you the most. I think we have to continue that service or support these patients after the discharge by following them up. For how long? Probably up to 3 to 6 months we need to follow them up. And if needed, they should be provided psychological support. And sometimes we may have to see the patients and provide some interventions like nerve blocks to help with these patients. Instead of putting them on strong opioids, or instead of leaving these patients to be managed by GPs or the surgeon. That is probably the best kind of possible care we can provide by these transitional pain services. So this is something which is followed in Toronto General Hospital. As I said, when they see the patients preoperatively, they got a pain alert. Okay, they flag those patients up, and then perioperative period, they optimize their pain by multimodal analgesia, and they do provide education for these patients and their families. And if appropriate, they make a referral to clinical psychologists. And then post-discharge, and this is what they follow. Okay, after 3 days after the discharge, they give a phone call to these patients and identify or find out how their pain control is. And then after 2 to 3 weeks, they review these patients in the clinics. And if they are on opioids, they try to manage and reduce those opioids or wean them off, and then follow them up again until the patients are relatively pain-free, and then the functional, the function is back to normal. And if appropriate, despite 3 to 6 months, if they still continue with the pain, they make a referral to chronic pain services. This is a kind of a service they provide at Toronto General Hospital. This is the first hospital actually which instituted transitional pain services in Canada, and it is running very well. So what are the risk factors we should be looking for? Because as I said, key to provide this service is for the high-risk patients. And we know from the literature and the evidence that preoperatively, if the patient is already in pain, or if the patient is on strong opioids or psychological factors like anxiety and depression, these are the patients who are at high risk for chronic post-surgical pain. And intraoperatively, if the surgery is such that, which might involve cutting through nerves, like, okay, thoracotomies or some of the surgeries like amputation, we know they are at high risk for CPSP. And post-operatively, if there is cancer pain patients or patients who is going to receive chemoradiotherapy, obviously the risk of CPSP is high in these patients. So these patients, once identified, we should have an individualized plan for these patients so that they can be managed appropriately, intraoperatively, and also support these patients post-operatively. And it's a similar thing, identification. How do we identify these high-risk patients before surgery, during their admission? How do we manage that? And there are some of the surgeries which we have looked at already, like amputation, thoracotomies, breast surgeries. We know these are high-risk surgeries for chronic post-surgical pain. After the surgery, again, you have to make sure their pain is well controlled. And some of the patients you may come across, we would have seen, like immediately after the surgery, they would be in significant and severe pain. And most of the times the symptoms what they describe maybe sometimes gives you an impression that is a neuropathic pain. So patients who suffer with neuropathic pain immediately after the surgery are more likely to have chronic post-surgical pain. So these are the patients who should be identified. If you have not identified preoperatively, intraoperatively, or perioperative period, you should identify these patients and provide support for these patients so that they are not going on strong opioids or their pain is managed well. And if needed, probably a referral to chronic pain services is needed earlier than later. So there is another risk stratification system which is available. And I'm sure most of you are aware of this ONET classification system. This is to stratify the patients who, based on if they are on strong opioids before the surgery, and also on top of it, if they have got any other modifiers, like, say, for example, if the patient is opioid naive, or we say opioid exposed, are the patients whose morphine equivalent per day, oral morphine equivalent per day is less than 60 milligrams. And we call opioid tolerant, or the patients whose oral morphine usage is more than 60 milligrams per day. So if you have these patients alongside some modifiers, like modifiers are, we know, high-risk surgeries, and also history of substance use or behavioral tendencies like anxiety and depression and pain catastrophization. So these are the modifiers. So we can classify them based on opioid usage and modifiers, and then we can categorize them into low risk, moderate risk, and high risk patients for chronic post-surgical pain. So based on this stratification, we can devise a plan. Like for low risk patients, probably it is just a preoperative education and perioperative multimodal analgesia would be sufficient. And for moderate risk patients, probably a bit more preoperative education, perioperative multimodal analgesia, and preoperative psychological optimization is also required. And for high risk patients, there's not just preoperative psychological optimization, but postoperatively, probably it has to be continued until they are well enough and their pain is well controlled and the quality improves. So this is one of the classification systems which can be used for patients who are admitted to the hospital and managed accordingly. So far, I've given you some information about how we can kind of identify these patients and how it can be delivered. And let us look at, is there any evidence as such available to say that transitional pain services is effective? So this is a publication which is published in 2025. Lead author is Hansi Clark. He's an anesthetist from Toronto General Hospital. He's the first person who has, like, as I said, mentioned, instituted this transitional pain services in Toronto General Hospital. So they looked at 10 years of transitional pain service research and practice. Where are we and where do we go from here? So they identified 270 transitional pain services related publications. Of these, only 3 were RCTs and 3 non-randomized comparisons and 10 observational studies. So their findings were definitely TPS is clinically impactful. The evidence consistently supports improved opioid outcomes, potential improvement in pain and mental health, but what they couldn't definitely show is transitional pain services definitely reduces chronic post-surgical pain. They were not able to identify because most of the studies actually did not have enough number of patients. So that is one of the reasons. So what they suggested is more robust research is needed. This is coming from Canada. And there's a trust study which was done in Netherlands, Amsterdam. So this was published in 2023. This is the effectiveness of transitional pain services in patients undergoing surgery with an increased risk of developing chronic post-surgical pain. So essentially, high-risk patients, when they instituted transitional pain services, did that make any difference? It's a randomized clinical trial. They randomized the patients into 2 groups, high-risk group where they have instituted TPS, and then high-risk group routine care. There were about, I think, 169 patients. So divided into 2 groups. What they found is no improvement in short-term quality of recovery. Immediate 3rd day post-op, they looked at the quality of recovery. There is no significant difference between the 2 groups. Having said that, the numbers are quite small. But what they definitely found is TPS patients experience less persistent pain in surgical area. This is positive, less persistent pain in the surgical area. And substantial opioid reduction in 3 and 6 months. Higher proportion of patients discontinued opioids per 6 months, which is quite significant. And there is lower incidence of new onset disability and improved functional recovery. So this is significant, but what the problem with most of these studies is they don't have enough numbers in these studies. And that is the reason they were not able to show that definitely it is reducing the chronic post-surgical pain. Though the intensity, they were able to show that is reduced, but the incidence, they were not able to show so far. We need a really good randomized control trial to show that it is definitely effective. And that is going to be, I think, is going to be published this year. This is a POET pain study, and I'm sure the results will be published this year. It's a prevention of persistent surgery-related pain through the introduction of perioperative transitional pain services. So this is undertaken in Germany. It is a multi-center randomized control trial with 3 groups: high-risk patients having TPS, high-risk patients with routine care, and low-risk patients with routine care. And they're looking mainly, the primary outcome they are looking at is what is the incidence of chronic post-surgical pain. And there are a number of secondary outcomes they are looking at opioids, reduction, quality of recovery, and functional improvement, and patient satisfaction. So there's lots of numbers. And if you look at, they've recruited more than 1,800 patients. It's closer to 1,860 patients. And they've already recruited, and they collected the data, and they're analyzing the data and hoping that the results are going to be published. So which will make it clear whether it will reduce the incidence of CPSP or not. However, it is definitely clear by now, the transitional pain services definitely reduces the opioid use in some of these patients. So as I said, in the NHS, to implement this kind of a service in the UK, it can be really challenging. One, obviously, it needs funding to have a multidisciplinary team to deliver transitional pain services. At the moment, most of the funding is diverted towards acute care. So there's not much of funding available for these kind of services. Obviously, we need resources, we need psychologists and physiotherapists. So it is resource intense. As I mentioned, there is still limited high quality evidence to suggest it is impactful. Though lots of smaller studies shows that it's clinically impactful. It's not included in core standards of pain management, which I think hopefully will be included in the future. There is no accepted standard protocols for implementation. As I said, there is one model which is Toronto General Hospital, but when I was looking at different studies, there are various ways the post-discharge, how they followed up these patients is not standardized. So that standardized protocol probably is needed if you have to implement in NHS. To conclude, CPSP, chronic post-surgical pain, is a significant problem. Because we don't come across these patients in acute setting, we are not aware of the problem, but in chronic pain setting, we do see these patients and it is a significant problem. And transitional pain services offer structured method in managing patients at risk of CPSP. Of course, it is resource intense and we do need more RCTs to substantiate the effectiveness of TPS. Thank you.
Right. Thank you very much, Dr. Simon. That was an amazing presentation again. Because we are overrunning a bit, I'm going to pass the word straight to Balaji and his update in obstetrics.
Thank you very much, Jacob. Just get it on. Are you all able to see my slides?
Yes, we can see.
Can see it. Okay. Give me a second. I think it went on to the last one. Okay. Yeah. Good afternoon, everyone. I'm Dr. Balaji. I'm one of the consultants from HUD, and I'm one of the co-organizer. I'm just going to draw with my role as an Yashara DRA examiner and Royal College examiner. I'm just going to bring on what is new in obstetrics. It's going to be a slightly interesting one. There are a lot of updates and development in obstetric world, but my focus is going to be more focused on regional anesthesia and related topics. So I am going to focus on the new development that is coming up is the dural puncture epidural for labor analgesia. Focus in obstetrics, focus only on gastric ultrasound. I'm not going to speak about the lung or cardiac or all other components of ultrasound. And also newer blocks like quadratus lumborum blocks and erector spinae blocks for pain relief following C-section. There are a few other developments, but I'm not going to focus on that one, like the epidural boluses, how to give it, or rapid sequence spinal anesthesia. And we discussed a lot about intrathecal and epidural neuroopioids and adjuvants, which I'm not going to touch about that one. Now, just to make it interesting, so if you can spend some 10 seconds and put it in the chat box, whether you have done any dural puncture epidural, yes or no, and whether you have done a focused gastric ultrasound in obstetric population or even in a normal adult population, just put it as yes or no, whether you have done any quadratus lumborum block or ESPN block in obstetric population or even in the normal adult population, yes or no. Just give your answers and let us brainstorm from there. Good. I can see some things that have come across. What I'm going to do is for dural puncture epidural, because it's a newer topic, I'm going to bring some evidences there. But for the next two topics, the gastric ultrasound and quadratus lumborum ESPN block, I'm not going to bring in quite a lot of literature search or anything, but I'm going to say how we normally perform it. Just like as an instructor in ESHRA for gastric ultrasound, that's what I'm going to do. So it may be a good one for all the new trainees and also the consultants who are not exposed to gastric ultrasound and ESPN block, you can visualize how it has to be performed. Okay, now when we do an epidural, this is what we are going to do. We use the epidural needle, the 2E needle, and we go into the epidural space, use the loss of resistance, and you find that one. And what we try to do after that is we thread the catheter through the epidural 2E needle into the epidural space, and we give the pain relief through that one for labor. And the modification that came out was the CSE. It's a combined spinal epidural technique. In that one, what we try to do is, it depends upon what type of needle you have. It's through and through. You can thread the catheter in, and in the second port, you can try to get the spinal needle in, and you go into the dura mater and inject a low volume of spinal anesthetic. So it acts very faster. Or if you have the same needle in, so what we try to do is we try to do the first spinal anesthetic, inject it, take it back, and put the catheter in. And there is a theoretical possibility the catheter can go through the dura that has been breached. But that is a theoretical possibility because the size of the spinal needle is very small. And what is dural puncture epidural? It's almost the same technique, okay, whichever the thing you try to do. But what we try to do is you go into the spinal space, make a hole and come out, and then thread the catheter in. So you're not injecting any drug at all. And that has few advantages, okay. And this one was started early 2018 or so from Canadian group. But I'm not going to look into quite a lot of literature search. I'm just going to focus only one which came out recently in British Journal of Anesthesia. It's a meta-analysis which came out last year. I have to admit I have not done it, but my colleague in our department is very keen on it. And yes, there is an evidence there, and it's something which we can look into it in future as well. Okay, what the evidence shows there, it's a meta-analysis where they have used PRISMA guideline, that is it's an analysis which they use for meta-analysis and a systematic review guidelines, and they looked into 143 literatures, of which they have taken 18 trials, which involves around 2,144 participants, which is a good number there. And what they looked into was the primary outcome, that is a time to onset of analgesia, that is when you do the catheter, and after that, and you inject the drug, and what is the time of analgesia. And the secondary outcomes, what they looked was there any unilateral block? Was there any motor block? Was there any sacral sparring? How adequate was the analgesia? And what is the incidence of cesarean section and forceps delivery? And was there any additional doses that was given? And also the complication, they focused on hypotension. Okay. And what they found, it's quite interesting. They found that the time to onset of analgesia with dural puncture epidural was reduced by 3.5 to 4 minutes, which is very helpful in laboring patient who is struggling a lot, who is having pain, where we need to get the pain relief immediately. So it has reduced by 4 minutes or so when compared to epidural. And few other things, what they found was the unilateral block was very less, and the motor block also was very less, and there was less sacral sparring, and that incidence was more with epidural, and the higher rate of analgesia, and all this was statistically significant. But one other thing which they noticed was there was a substantial heterogeneity, such as with the dosing practice of local anesthetic and the concentration of local anesthetic used. If you look into it, there were 3 or 4 articles. They have used 0.125% bupivacaine for pain relief, and it was 20 ml. And there was one article where they have shown 0.25% bupivacaine, and they used 15 ml. And similarly, there were 7 studies which have used 0.2% bupivacaine, and there were 3 studies where the concentration of ropivacaine varied from 0.08% to 0.2% ropivacaine. And also the spinal needle gauge was slightly different. They were varying from 25 gauge needle to 27 gauge needle. And the opioid dose, yes, there was also variation there. Some used fentanyl up to 2 mics per ml. Some used sufentanil, some have used fentanyl 2.5 microgram per ml. So there was some variation with the dose and the concentration. And also the maintenance technique for analgesia also was diverse. One group, this was an operator dependent one, which was midwife operated top-ups. There were few, they have used bolus only epidural pumps. Some have used programmed intermittent epidural boluses as well. And other one which they have found was the inconsistent timing of the epidural or dural puncture epidural placement during labor. Was it early labor or was it late labor, or what was the cervical dilatation? So there was more inconsistent findings about the timing of the epidural placement. But the most important factor is the spinal needle gauge. That is what is going to determine how the principle of effectiveness of dural puncture epidural is going to work, because the drug is going to sweep through and it goes into the CSF and it causes an additional effect. That's the advantage of dural puncture epidural. That's a theory that has been postulated. And what the authors they did is they did a subgroup analysis, but they were not able to find out any significant difference there. And that is one of the recommendations that came out with meta-analysis. And the size 25 gauge is sufficient enough to make the sweepage and cause a good analgesia for the patient. Another article which I want to emphasize and bring it on is that was published in Anesthesia and Analgesia by Maida et al. In 2023. Yes, they want to know what is the effective dose of bupivacaine, and they compared between dural puncture epidural versus conventional epidural technique. They sampled 100 patients there. And what they did is the dose of bupivacaine for each trial was determined by the response of the previous subject. It is used an established selection allocation method, a biased coin approach, and they did that one. And what they found was the dose of epidural bupivacaine was less with dural puncture epidural when compared to conventional epidural technique, and that was a 35% reduction. If you see, it was 29.3 milligram with DPE, but with the conventional epidural, it was 45 milligram. So that is another one advantage of using dural puncture epidural. So we can reduce the dose of local anesthetic. So to conclude, it's a very good technique. It provides faster onset when compared to conventional epidural, and but when compared to CSC, it doesn't cause significant motor block. That is a real advantage with it. And also the sacral sparing, which is more common with epidural, almost 20%, they tend to have sacral sparing, and it is reduced significantly, as well as the unilateral block. And the analgesic rate effects were very good and side effects were very less. But there are a few things there. There's a theoretical migration of epidural catheter because of the hole that is there. That has to be addressed. And second one, there's an additional cost because we are using a spinal needle, which the trust has to look into that one. And third one, ethically, we are breaching the dura, which we are doing it knowingly, and there are risks involved with the PDPH and infection. So we need to have proper trials in future moving forward. That's what I will put it across for dural puncture epidural. Next one, I want to focus on the gastric ultrasound, the POCUS. Now, ultrasound is a validated tool in third trimester to assess the quantitative and qualitative content of the stomach in pregnant patients. And the challenge is the 6-hour fasting rule may not work out very well for third trimester parent. That is where the challenge is. And ultrasound has revolutionized to know what is the amount of fluid content or stomach content that is there. And I would like to touch about one of the article that came out in 2018. That is a Bible for gastric ultrasound for third trimester in pregnancy, third trimester pregnancy, which has looked into the a model of volume assessment. That is a very good way of bringing it out, and they define what is the cutoff value for the risk of aspiration by measuring the antral cross-sectional area, and they found that the cutoff value is 9.6 centimeter square. Sorry, it's a mistake. That's a centimeter square. It correlates to the volume of 1.5 ml per kilo, which carries a significant risk of pulmonary aspiration. So that is the cutoff point. So that is where the focus is focusing on. And we all know that risk of aspiration, yeah, the patient can go to ITU, that's an additional cost, and the patient stays in the hospital for a long time, risk of pneumonia leading to sepsis and death. So we can prevent it by quickly acting upon using a bedside ultrasound. How to do gastric ultrasound? I'm not going to touch about. There are plenty of articles that is available in the literature, but I'm just going to focus how to do it. So it is very helpful for you guys. What we need to do is two approaches. You keep the patient semi-recumbent position, as well as semi-recumbent in the right lateral position, but that is not advocated in emergency position, emergency procedures like C-section, emergency C-section. And you have to use a curvilinear probe so that you can have a maximum depth. And the approach we use is a sagittal approach. What you need to do is just go underneath the xiphisternum 1 to 2 centimeter to the right side in the epigastric area, and your focus is more on the left lobe and the pancreas at the level of the aorta. So this is semi-recumbent position. You keep it at 30 to 45 degrees. The patient is in this position. And what you do is use the curvilinear probe, and this is what you have to do. And you can see that one, it's 1 or 2 centimeter away from the midline. You just keep it there. And what you're going to look into the picture, the top one is the ultrasound and the bottom one is the what anatomy it correlates to. So you can see on the top of the skin. On this side, L is the liver, that is onto the right side, and A is the antrum, P is the pancreas, and SMA is the superior mesenteric artery.
We can't see the pictures. The presentation is stuck on a focus gastric ultrasound, the previous slide.
Okay, just a moment.
It looks like some people are stuck even on the previous slides of on dural puncture epidural.
Okay, are you able to see now?
No, mine is still stuck on the text.
Okay, let me see. I'll stop sharing that one.
Balaji, are you there? You seem to be frozen completely. Right, it looks like we've lost Balaji. We'll give him a few minutes to come back. It wouldn't be a proper online conference without technical issues, I suppose. Right, I'm hoping Dr. Balaji will be able to join us soon. Right. There's been a question from Nimi for Dr. Vinod in the meantime. Dr. Vinod Sanem. Oh, that's a very good question, actually. Nimi is asking how we can extrapolate the benefits of transitional pain services to our organization. I mean, that's a challenging one, I suppose. What are your visions?
Yeah, see, it's the concept is great. I mean, I'm sure what we know is the patients when they are followed up. One, as experts in managing acute pain, once the patient is discharged, probably will be able to manage their pain better rather than relying for the pain management on GPs or the surgeons. So the concept itself is great, and then how do we extrapolate that to in our institute is one, we got a fantastic acute pain team, and then we got the psychological support from chronic pain services. Whether we can do a small pilot project, which we are thinking going forward, and whether that shows any benefit. I mean, that's what I'm thinking is, and if that shows, then probably we can make it as a big research project. And even though it is in its infancy at the moment, I'm sure transitional pain services is something which is going to be big in the future, in next 5 to 10 years time. Maybe it'll take some time in NHS, but it's going to be a big thing. Because, as I said, the impact of chronic pain, chronic post-surgical pain is very, very high. When to put into perspective, as I said, if we are having 40,000 patients added to this community with severe chronic pain every year, some simple numbers if you are looking at, and usually it's about 4,000 to 5,000 pounds is spent on managing chronic pain per patient. So 40,000 patients added to the community multiplied by 5 is about 200 million every year you'll be spending just managing this patient. So it doesn't make sense. So if we can manage, if we can prevent that happening, obviously it has got a significant economical benefit. So translating it into our own service, it's going to be challenging, yes, but it is something which we need to focus and try and do it. I don't know whether I've answered Nimi's question, but that's where we are at the moment. Yeah.
Certainly sounds like a big challenge, especially in the region where the disease burden of opioid use in the communities is quite high. I think all the patients
quite high.
Have a lot of
risk factors. Unfortunately quite high. It's in Northeast, actually, it is significantly high compared to that of a South of the UK I'm talking about. And in our region, Humber and Yorkshire, it is high. And also, as we go north, it is significantly high. We need to reduce that. And I mean, we did manage to reduce significant opioid loads in the community by making changes to our guidelines, acute pain guidelines, and educating people, educating our staff, and opioid stewardship has made a big difference. But still, it's one of the biggest problems we are facing, yes.
Right. I actually had a question for you as well. So when you, I think everyone's thinking, when you think about chronic post-surgical pain, the first thing everyone thinks about is the limb amputations, because that's something we know for quite a while. But recently I've been thinking about craniotomies. I was actually seeing that in one of your slides, you were saying that the incidence of chronic post-surgical pain after craniotomy is up to 25%.
That's right.
I was wondering whether you have any experience seeing these patients in the clinic from your own clinical practice, because we do a fair amount of neurosurgical interventions in our organization.
That's right, yeah. So more recently, I mean, just a week ago, I saw one of the patients who has had was diagnosed with trigeminal neuralgia, had microvascular decompression, and then the patient now is having more of occipital pain related to the surgery than trigeminal neuralgia pain. Even though the surgery, unfortunately, did not help much with the trigeminal neuralgia, and now she has got this pain on top of it. So how do we go about? Yes, it is there. And I think most of the times, if we are talking about a craniotomy, these patients would have had craniotomy for a really significant reason. So for them, after having a craniotomy, having a pain in that particular area may be like relatively a small thing to deal with than the primary pathology that went for a craniotomy. So you see, there is every patient is different, every patient's perspective is different, and that is the reason maybe we don't see that many patients after craniotomy in the chronic pain clinic, but we do see other patients, yes. But we have to acknowledge that it's a bigger problem in the community, and most of these patients are managed by GPs, which is a challenging group of patients being managed by GPs. And I don't know whether they are being managed appropriately or not. Maybe most of the times they go on strong opioids, which is not an ideal thing.
Are you able to hear me now?
It sounds
yes,
like
we can hear you.
Just rejoined.
Yeah,
Yes, we can hear you. Yeah.
What has happened? It is not allowing my camera. Oh, it's coming on now. Yeah. Sorry. Yeah.
Here you go.
Excellent. I don't know till what level everyone read it. Is it up to the DPE conclusion one?
Sorry, I think I've seen the start of the focus. I think just before the pictures.
Okay, fine. Let me get it on. I don't know what happened to my Teams. It completely froze up immediately. Let me see.
Yeah, it happened to me at the beginning of the session too, as well. I apologize to Babette that we are overrunning a bit, but since this is our last session, I think we can sort of shift a little bit. And I also wanted to highlight that the last round of the course is starting now. So if anyone's interested in that, please join through the QR code in the chat.
I think there's a bit of problem there in sharing that one. Can you share my slides if you don't mind?
Yeah, I can do that.
I don't know what is happening there. I don't know. It went to the older model of Teams for some reason. And it's not accepting anything there.
Yeah, I'm going to share them now. Right, there we go. Which slide were we on?
So I think you go to the area where it is gastric ultrasound.
Yep.
Okay. So yeah, the way we need to do the gastric ultrasound, it's going to be semi-recumbent position as well as semi-recumbent right lateral position. This is a semi-recumbent position which I want to tell you, it'll be 45 degrees up. So what we are going to do is now keep the probe. Can you move to the next slide?
Yep.
So the probe position, what we need to do is keep it 1 centimeter or 2 centimeter away from the midline below the xiphisternum. And you're going to focus on the structures. What you're going to see is you're going to see antrum, liver, and also superior mesenteric artery and aorta in a transactional one because it's vertically you're keeping sagittally the probe. And the ultrasound image, you can see there is a white structure there that is superior mesenteric one. Underneath you can see the aorta that will be pulsatile if it is in real time, and above the superior mesenteric you can see the pancreas, and above that is going to be the antrum. That is what we are going to focus on, and also the liver. Can you go to the next slide? Yeah, so the images, so what it helps you with. Now, if you see the slide, the image A, it shows the arrow mark shows the antrum, that is the empty stomach there. And you can see very clearly the liver, pancreas, and aorta there. Now, if you take the fluid in, and you can see the antrum gets dilated, and the fluid looks more hypoechoic, and you can see the liver onto the right side. Now, if you come to the slide C or the image C, you can see a complete dark one. That is, if you have any injected air or something, some people, they do it when they try to eat it, and you can see it will be completely hypoechoic, and air is not a good transmitter for the ultrasound beam, so you can't see very well. Sometimes you can have a blurred image as well. And if you come to the image 4D, that is the solid contents there, and that is what it looks like, the antrum. Okay, so this is an information which I want to tell. And if you can move to the next slide. This is one which I took from the Nysora website, and you can see very clearly along with the picture on the side. The first one is the empty stomach, and you can see how it looks like with ultrasound. And the second one is the solid where the patient started to eat, and again that is what it will be. And you might have some air at the time, so the picture is not very good. But if you see the onto the right completely down, they have taken the proper solid where the air is taken out, and they come as a gray structure there. That is what the solid food looks like. And onto the side, onto the left side, you can see the fluid one, which is hypoechoic one. And this is what the image you will be having when you do the gastric ultrasound. Can you go to the next slide? So now, what is semi-recurrent in right lateral position? Not left lateral. We need to use right lateral for obstetric patient. So it's like a sim position, but what we are going to do is you are going to make 45 degrees propped up, and this is what we need to do for obstetric patient. And the bottom one, I just took the picture there to show where we are focusing on. I'm not interested in the cardia. I'm not interested on the fundus, but I'm more interested in the pyrolic antrum. That is what it's there, and that's where I'm going to focus with ultrasound. Can you go to the next slide? And in pregnant patient, this is where you're going to keep it. So that is semi-recommend. It'll be around 30 degrees in real time, and you put the patient on right lateral, and you put the probe there. Can you go to the next slide? And the image which I showed initially was for a normal population, but in obstetrics, how it looks like. And you can see onto your left side, you see the uterus. That is what it looks like. Onto the right side, you have the liver, and you can see the liver is pushed more to that side, to the right side, and you can see the antrum. It may be small. And if you have fluid, you can see the picture B shows that one is the dilatation with the fluid there. And picture C shows the food particles there, and it has the food particles which by gray like structure there. And picture D is the air. The air, sometimes it can be completely dark or it may be grayish one. Can we move to the next slide, please? So once you see any fluid or anything, we need to put the caliper on and try to measure that one. And as I mentioned earlier, the antral cross-sectional area is a very important thing. And you put the caliper and measure that one from D1 to D2 and see what is the distance there. And you use the formula and work it out. And ideally, it should be less than 9.6 centimeters square. Can we go to the next slide? So Perlas, after that research, they made the scoring system, and this is a very well-recognized scoring system that is used to identify which patient is low risk or moderate risk and high risk. They gave grade 0 to 3 scoring system. If the patient is having empty stomach, both in the supine and the right lateral position of the semi-recumbent position, they are low risk. So that is a good advantage for us. And gray one, if the stomach looks empty in supine, but you find some clear fluid in the right lateral, that is a little bit advantageous one. But if we think it is less than 1.5 ml per kilo, the risk is low. But if you are able to see clear fluids in both the position and it's more than 1.5 ml per kilo, it's a high risk one. And the grade 3, what they told us, if you see any thick fluid or solids or anything, it's high risk one. So that means this patient is more prone for pulmonary aspiration. Despite we might use 7 rapid sequence and we still use rapid sequence, but this is what we have to think about that one. Can we go to the next slide? So it is a very helpful, validated bedside tool for us to identify who are more risk to develop pulmonary aspiration, particularly for the 3rd trimester who comes for cesarean section or forceps. Okay. Only one thing which I would tell is we need to do both supine and lateral position of semi-recumbent position and correlate with whatever the finding you get for Perlas grading system. And the cutoff value is very clear. It's 9.6. It should be less than that. Otherwise, it gives a value to say that it's more fluids are there. So for a 100-kilo pregnant lady, it will be around 150 or something. So that is where the thing we need to look into that one. So it minimizes the gastric aspiration and further complication that is related to aspiration. Can we go to the next slide? Okay, this is the final part which I'm going to touch about. What are the other roles of ultrasound in obstetrics? Okay, we all know that when most people now use ultrasound for locating the epidural space, and also in some trusts they try to use performing the neuroscope block using ultrasound guidance in difficult cases, and it's not new. Main thing is it helps to locate the midline in obese patients and also measures the depth to the dura from the skin, because the spinal needle length is only 9 centimeter and the introducer hub takes around 1.7 centimeter. That means if I'm going to do a spinal, if the depth is more than 7.3 centimeter or so, I can't use that needle. I may have to go to the next longer needle, which will be 110 millimeter one or 120 millimeter one, whatever the thing that is followed in your hospital. So that is an advantage of obstetrics, but that is not new. It's obsolete. But there are a few other things that came out as the quadratus lumborum block and erector spinae block. Okay, I'm not going to touch about the transverse block because you guys could have done that one. Can we go to the next slide? And this is what I found the evidence from the obstetric anesthesia website. And they clearly told that the posterior tab blocks are found to provide prolonged analgesia. This is after looking into a lot of meta-analysis. And also they told that it provides better analgesia when compared to the lateral approach. And also, because of the abdominal dressing and tissue edema and intra-abdominal layer that is following the surgery, it can obscure your anatomy. So what they are suggesting is lateral approach is not good. We normally don't perform doing tab blocks or anything before the surgery. We always try to do it afterwards, and that is what most of the articles are told, and that is my practice as well. So we do it, but what they are trying to say is the posterior approach or the quadratus lumborum are more beneficial. That is what OAA website is recommending now. But only one caveat is we need to position in the lateral position to perform the posterior approach. And also it needs an operator experience to maximize the effectiveness of the quadratus lumborum block or erector spinae block. Can we go to the next slide? So this is a normal way of doing the tab block, and this is what we do at the triangular petite. And we go for the rib cage, look for the pelvis, look for the external oblique, and we try to get the needle inside. And if I put the ultrasound there, can you go to the next slide? If I put the ultrasound, this is a pregnant patient who had the procedure. And if you put the ultrasound, you move from anterior to posterior, and you see the three muscle structures, external oblique, internal oblique, and transverse abdominis. And you're going to get the needle in between the internal oblique and transverse abdominis. And I tend to go more posterior because that is a place where I try to block both the branches. If you leave it little more into the mid abdomen, it gets divided into anterior and lateral. So I'm trying to block the spinal nerves exactly at that particular point, and I inject some decent volume around 20 ml on each side. But can you go to the next slide? But to maximize that one, it's better to do posterior quadratus lumborum block. So what you do is put the patient on lateral position and look for L2, L3 or L3, L4. I prefer to do it at L2, L3. And you go more posterior, very close to the transverse process. And I'm introducing the needle again from anterior to the posterior. And if you see the ultrasound picture C shows the anatomy. So on this side is the anterior one, and the part of it is going to be your psoas muscle or probably external oblique muscle. And you can see the compartment in between is the quadratus lumborum, and on the top is going to be the erector spinae muscle, and in between is going to be your transverse process of L2 or L3. And I tried to introduce the needle into the quadratus lumborum. Can we go to the next slide? So if you look into the anatomy, this is what it's going to come. So you can see very clearly the three abdominis muscles on the side. And when you move more posteriorly, you will see the psoas muscle. Then you will see the quadratus lumborum underneath the psoas muscle. And adjacent to the psoas muscle is going to be the erector spinae muscle. And most commonly I prefer to do the posterior QL block. It could be QL2. I don't bother about it, but I prefer to do the posterior quadratus lumborum block. So I try to advance it in between the quadratus lumborum and erector spinae muscle. That is what I tend to put it across. But can you move forward? And again, I use the same volume, around 15 to 20 ml of local anesthetic, like 0.25% levobupivacaine on each side. The other one, which is slowly coming up, and there are quite a lot of evidence that is coming across, the erector spinae plane block. Particularly, it's useful for rescue block. If the patient had C-section under general anesthetic, you gave some morphine, patient is in the recovery room, but screaming a lot, they are advising is better to use the erector spinae block. This is coming from OAA website. Okay, can you go on to the next slide? So how you do it? Now you need to see the angle. I'm trying to come from posterior to anterior when compared to the quadratus lumborum one. It's almost the same, but I'm focusing on erector spinae and quadratus lumborum and trying to inject the needle from posterior aspect, going into the erector spinae muscle and inject it there, very close to the transverse process. That's what I need to do. But again, we need to do it on posterior aspect. What is the real advantage with it? There is no real advantage when compared to quadratus lumborum. Only one thing is, when you're going from quadratus lumborum, you're coming from anterior aspect, you're coming through the muscle. Sometimes you may have to come through psoas muscle, and you can get confused between the quadratus lumborum psoas muscle. But if you're coming posteriorly, you know that's only one muscle, is erector spinae muscle, and you need to focus very close to the transverse process. That's the only advantage there. Again, the volume is almost the same. Can we go to the next slide? So to conclude with the third part of the discussion, that is a regional abdominal and ESPM block, they play a crucial role in multimodal analgesia, particularly for part ones who had general anesthesia. Posterior approach, they provide better and prolonged analgesia, and anatomy is very good when compared to the anterior approach, and it can be used as a rescue analgesia following C-section. But only one thing which I want to tell, there is a risk of local anesthetic toxicity, so you need to be careful with volume what you are injecting it, because in pregnancy they tend to have altered pharmacokinetics to local anesthetic, and there'll be some physiological changes as well, which you have to look into it. Can we go to the next slide? So to conclude, the dural puncture epidural for labor analgesia is a promising technique, but it requires more evidences. And I am interested to do it after doing this literature search. Probably I might start doing it from Monday onwards. And other one is focus in obstetrics. I use a lot, and it's definitely making a good tool and helps to prevent any aspiration, because the 6-hour rule is not applicable in obstetrics. And the last one is the use of ultrasound in obstetrics, which is the posterior blocks and erector spinal blocks. They are really a key component for multimodal strategies if the patient had general anesthesia, and it optimizes the recovery. Can we go to the next slide, please? Okay, can you go to the next slide? Can I ask, thank you very much. Thank you very much for listening to my lecture. But can I ask, can we reinvent what I asked, the 3 questions again? Now, after the lecture, would you all be happy to perform dural puncture epidural? Yes or no? Can you put it in the chat blocks? And similarly, would you all be happy to use ultrasound for gastric fluid location, as for gastric location? Would you all be happy with it, gastric fluid location? And also the third one, whether you will be happy to do quadratus lumborum block and erector spinal block in obstetrics or even in non-obstetric population. Just put it in the chat box. That gives me a feedback to know whether you have listened to my lecture or not. Thank you very much.
Thank you very much, Balaji. That was very interesting. And I'm sure we will come back to your talk with some questions in the final section. But now I'm going to hand over to Babette. Babette is our host, our guest from Antwerp, and she's going to give us an update on regional in pediatrics. Babette, please accept my apologies for 20 minutes being behind the schedule, but the floor is yours.
Thank you so much. I'm just trying to get the presenter view. I'm just sharing, but I want to share different.
I think if you, the presenter view, if you go to your presentation, there should be a button present in Teams.
Have a look. I'll just do it without, it's fine.
Okay.
We'll manage. We'll manage.
We'll get there.
Can you see the slides though?
Yes, we can, yeah.
And you can hear me all right as well.
Yes, we can.
Good. Thank you so much for the invitation, everyone. My name is Babette Klink. I'm a Belgian pediatric anesthetist, not from the Netherlands, as it said in the program, a Belgian one. I worked for 5 years in Alderhay Children's Hospital, which is a very regional-minded tertiary pediatric hospital. And now I have moved back to Belgium, and I'm working very hard to introduce more regional anesthesia in children everywhere. So I don't have a conflict of interest, but I am one of the founding members of the In Plane group, which is a collaboration between 5 anesthetic societies. And we're basically trying to make the aim to create a unified international and educational platform on regional anesthesia in children. We have published the Plan A blocks on the RUK website, and we're currently working on the Plan B blocks. We should be finished soon, and we're in the final stages of also creating an app on pediatric regional anesthesia. So that should be there quickly. I'm going to try to make my presentation a little bit short because we're kind of time limited, I think. So bear with me. I'm going to talk about keeping kids comfortable. So I'm quickly going to gloss over pain in children and the importance of a good pain relief, which will take us to regional anesthesia in children. I will talk about safety, a little bit performance, taking consent, and how to manage expectations, which I think is also very important in children. Throughout the talk, you'll see some QR codes. Those link to the articles or the resources that I've used for this talk. So you can look at those if you want. So if we're looking, moving. Yeah. If we're looking at the literature, at studies trying to estimate pain in children, the numbers are shocking. Estimated is that 20 to 35% of all children experience recurrent or chronic pain. The numbers are slightly lower than in the adults, but we also think there's an underestimation of the actual numbers because children don't show their pain or they don't report their pain as readily as adults. And most of the studies will rely on parental reports or healthcare providers' reports who do not always recognize pain, or often the pain is seen as a normal part of development, which obviously is not helpful in reporting or seeking help. So why is this so difficult? Well, there used to be a common misconception that neonates cannot feel pain. However, neurobiology actually suggests they might be more sensitive because all the pain neural pathways are there, like peripheral neuroreceptors, you have the spinal cord connections already, the thalamocortical pathways, they all have formed, but the pain regulators are still immature. The descending inhibitory pathways, they start forming around 32 weeks of gestation, but the maturization of these processes happen after birth and don't don't mature until the child reaches adolescence. So the younger the child, the greater the incapability to modulate pain and to recover from painful experiences. So effective pain management is crucial, also because the pain that they are experiencing is happening in critical periods of growth and neurodevelopment. So the stress response that is triggered by having pain will disrupt sleep, activity, development, all those things. And there's an increased risk of chronic pain and functional impairment in later life. So a child does not just feel pain, a child will remember the pain. And early recognition, effective pain management are essential to prevent lasting trauma and to protect long-term health. So if you're looking at the symptoms of pain, they can be roughly divided into physical signs and behavioral signs. But we are still, as adults, expecting our children to react to pain with predictable, visible signs. But there's a wide variation on pain perception, on manifestation, on tolerance. So it's not so easy to assess pain in children. Sure, it seems relatively straightforward if you have a child or a patient that can verbalize their pain, localize the pain, know what they're feeling, understand it. And there are a number of self-report tools or observer-based scales that can help us assess pain in children from 3 years old. But it can still be a challenge. For instance, a baby in pain can be silent, can cry, can wiggle, can be still. And if the child is crying, it's often difficult to differentiate between different reasons for discomfort. And then you have this very, very dramatic phase where a toddler in pain, they can go from quiet to being very active to being even aggressive. And fear in this age is a very huge component to what they're feeling and what they're displaying. So I think in these two categories, it's very important that you listen to the parents or the carers, because they might tell you things like they're not themselves, or they're not reacting or acting like they usually do. So in older children, self-reporting will become more and more accurate, but also here there might be an underestimation because they might deny pain because they want to go home, or they're afraid of injections, or they don't like doctors. So there's kind of still there sometimes difficulties. So just be wary. And the assessment of pain is not going to become more easy, or it's not going to improve with an anesthesia, which one we give. There will be no behavioral component when you give them an anesthesia. So the physical signs are really all we can rely on, but they're very aspecific. For instance, tachycardia might mean pain, but can also be hypovolemia, sepsis, infection, and those are things you don't really want to miss. So I think the best thing we can do, in my opinion, is try to take pain out of the equation. We've heard a lot about opioids yet, but I think we can all agree that opioids are not the answer to treat pain, especially not in children, because it has been proven that we don't like to give opioids to children because of the respiratory depression, because of the nausea and vomiting, and we don't like to give the doses that they need. So we're actually still with opioids, even though we give them, we might still be under-treating their pain. So that is where the regional anesthesia comes in, which I think is probably the better option. And ideally, you want to do your block after the induction of the general anesthesia, but before incision. And ideally, when the child has had either no opioids or very, very minimal dose of opioids. So that means that throughout the surgery, you can evaluate, assess the effectiveness of your block, and you can titrate the opioids to effect, which will give you a very good idea of the amount of pain relief they'll need in the postoperative period. So I'm guessing my introduction to this whole topic is basically a plea to consider regional anesthesia in children and to consider it very early. So even though the benefits of it in children are well known and accepted, how come blocks in children are still not the standard of care? Most common discussion point is safety. It's in the risks of complications, and then the whole debate about whether we should be performing our regional anesthesia in children when they're still awake or when they're under general anesthesia. So let's take a quick look at the evidence on these topics. So the two largest studies looking at safety in pediatric regional anesthesia are the PRAN and the ADAPTIV studies. Both confirm that blocks are generally safe in children with very low complication rates, no deaths, no permanent neurological injuries. And we can already see that in those, the majority of those blocks in these large database with almost no complications, a lot of them, most of them, were performed while the child was under general anesthesia. Interesting is as well, if you look at the data, is that central blocks have a 6 times higher complication rate than peripheral blocks, and the majority of the central blocks in children are caudals. And if you look at the complications that come with a caudal block, it's usually about either failure, intravascular injections, or intraneural injections. A lot of those things can be solved if you actually were to use the ultrasound while performing a caudal anesthesia. So I'm going to come back to that. Another complication of regional anesthesia that we dread and where we have to be mindful of is LAST, so local anesthetic systemic toxicity. again, the incidence is very, very low, confirming yet again that a regional block is safe in children. But if you look at the study on the left, it will show you that the blocks that are commonly associated with LAST in children were penile blocks and caudal blocks. And a lot of the cases where LAST occurred were blocks where the ultrasound was not used, but you could use the ultrasound to do a penile block or a caudal block. So I'm just going to quickly talk you through how to do a ultrasound-guided caudal block. So if you look at the picture on the left, top left, where you have the sacrum, you can see the superior posterior iliac spines, and then the triangle with the cornu, which we feel for if we're going to do the blind technique. What you want to do is grab the large linear probe, large footprint linear probe, and put it transverse on the posterior iliac spine, superior posterior iliac spines. You want to search for the midline first, and then you want to slide your probe down to where you can see the cornu. They appear as two round structures, and this is what commonly described as the frog face. So once you've got this view, you want to turn your probe 90 degrees for an in-plane needle insertion point. The structures you're going to be looking for is you want to have sacral bones on either side, and you'll see there's mostly paired. So you'll have one on the top, one on the bottom, until the very last one on the right side. You'll see there is one on the bottom, but none on the top. This is where your sacrocaudal ligament can be found. Between the sacral bones, you have your caudal space, and then you can also see the dural sac, which is obviously the structure that we don't want to hit when we're performing a caudal block. I'm going to quickly show you how it looks, because it's actually for this spread that I really want to show you the video. So easy to see the spread and to follow it up towards the head of the patient. So once again, you're looking for the caudal bones on either side. You can see the dural sac on the left. And in this video, the needle is already in place. So you'll see it move before they gonna give you start giving the local anesthetic. So you'll see it on the left. It's gone through the sacrocaudal ligament. And then you see how the local pushes the dural sac down. And if you go up with your probe, you can actually follow it up and just stop injecting once you've reached the level you actually need for your surgery. So the arguments of using ultrasound in children is basically because the volumes of local anesthetic you need to do any block are less, because you can see the spread and you can stop when it's enough. You see real-time visualization of your needle and of the local spread, and it just makes it more safe. So I'm going to quickly go over the awake versus the asleep things. So basically, the anesthetist people, the reason why we don't like is because we don't like the idea of not having feedback from our patients when we are actually performing the block. And then there's a concern that a general anesthesia might mask an intraneural injection or might mask LAST. But if you look at the evidence for this, you'll back again the big, large database studies. The first one is the one we've already said about very low complication rate, and over 90% of these blocks in that database was actually performed under general anesthesia. And even within that database, if they look specifically at the asleep versus awake, they could not find any difference in the complication rate. And then if you take into account that an awake child might not even give reliable feedback, they might interpret anxiety as pain, they might move during the procedure, which all risks injury, and the whole experience might be very traumatic, which is the reason why we are going to do the block anyway, to try to not have that traumatic experience. So based on the evidence we have seen, regional anesthesia in children is safe. And the guidelines actually support performing regional anesthesia in children under general anesthesia. And I think this is the best way anyway, because if the child is having a general anesthesia anyway, just do it when they're asleep. It will make everything so much easier. So just to reiterate, regional anesthesia in children is safe as long as you stick to the rules, which means that you have to use the ultrasound to do a block. You have to calculate the dose you're going to give. This dose is weight-based, and just ensure that you never have more local anesthetic in your syringe than that is safe for that particular patient. If you need more volume, then you can dilute a little bit, but still, again, not more local in your syringe than you're actually going to give that patient. and then a little bit of experience from the operator. That's actually quite nice as well. So if you have then a child that is eligible to have a block, you need to come up with a plan. There's some nice articles explaining about pediatric plan A blocks, things like that. Very good article from Steve Roberts and Annabelle Pearson. But I would also argue that the plan A block for you should be a block that you have done multiple times, that you're very familiar with. And it's also nice to have behind your plan A block, also have a plan B or a plan C, what you're going to do when it's not possible to do that block in that child, or what you're going to do when it doesn't work. We have discussed timing of the block. When you're performing your block, just ensure that your child stays warm. That's actually quite important and not always very easily done. If you're going to do a catheter, make sure that the post-op ward is happy to accept children with catheters. Make sure you document which kind of catheter it is. Is it an epidural? Is it a paravertebral catheter? Because the ward needs to know whether they need to do bromide scoring or not. If you're going to put a catheter, I would suggest always tunnel it. There's some very nice videos on tunneling catheter, and we'll have a very nice section about this in our app as well. And we would argue that it's safe to keep catheters in for 3 days. After that, the risk of infection becomes a little bit more increased. It's not a hard rule or anything, but just if you're going to put it in longer, have a good reason and just make sure that there's daily reviews, including reviewing the insertion point. Once you've done your thinking and you have your plan A, plan B, you actually do need to go and consent for the block as well. There's also going to be a nice section on the app. But this is very important because what you need to do is give information to the parent without scaring the child, and then give information to the child in an age-appropriate manner. So you kind of want to use words maybe like, we're going to let you sleep for the operation, but then when you're awake, your arm might still be asleep. That's because we don't want you to feel any pain from it, so we'll let your arm sleep for a little bit longer. Explain the pins and needles. Sometimes if they have the cast on, the whole thing about not being able to move a limb is often not really important to them anyway, because they won't move it anyway. But then if you also talk to the patients, try to manage their expectations. I always tell my patients, I'm going to do this block with your child when the child is asleep, so they're not going to feel anything from the block. But you might see that little puncture mark or a little bruising, and when they wake up, they might have an arm that's numb. They might not be able to move it. There might be a feeling of pins and needles, which is actually quite important, especially when you have a patient with autism or something, because the parents might tell you, actually, the feeling of pins and needles might be worse than pain. So in that case, I might not do a block. I also explain to the parents that when the child will wake up after the anesthetic, they will be upset. There might be a million reasons for them to be upset. If I have a working block during my theater, it's very unlikely they're upset because of pain. So just to explain to the parents that it's sometimes a search to see what's actually bothering the child. Often they need food and they need parents, and they will settle down. If you think it's pain, just treat it with some nice opioids, titrate to effect, and it will work nicely. Also important that the parents know about the multimodal effect of the block, so they still need to give paracetamol, still need to give NSAIDs to keep on top of the pain, especially when the block wears off. And then for us as well, when you're going to do multimodal, it's not just a regional block that you're doing in theater, but especially if there's risk of neuropathic pain with that particular case, remember magnesium, remember all of your other drugs to help with that. And then once you've done all that, don't forget to document it. There's a very nice article from Ezra as well on how to document your block with all the things that should be included. And in the post-op care, have a think about what that patient needs, apart from the paracetamol, ibuprofen. If you have blocked a limb, they might need a sling, or if you've blocked a leg, they might need to be carried by the parents. So think about all those things. And then I would also say, if there was a risk of compartment syndrome, we all know it's not a contraindication to do a block anymore, but you might have to remind your surgeon that they need to ensure there's some compartment syndrome monitoring for post-op. So in conclusion, I hope I didn't make it too long. I tried to shorten it a little bit, but I would say regional anesthesia is safe and effective in children if you follow all the rules, use the ultrasound, and just think that you're working with children, so they basically need that whole picture to actually make it safe and make it effective. So thank you so much. Just a small plug as well. The Alder Hey organizes an ultrasound for pediatric anesthesia course twice a year, which I think is very excellent. And then also keep an eye out for our in-plane app, I would say. Thank you so much.
Thank you, Robert, for an excellent summary, especially for an occasional practitioner like myself. That was an amazing update. Before we move to Q&A, let me just apologize to all the Belgians out there for assigning them to Netherlands. Rather than being an ignorant of geography, I was misinformed and initially thought that you moved to Netherlands after Alder Hey, and when I learned about Antwerp, I didn't update it properly.
No worries.
So my apologies. Right, Q&A, it was a large block, so we have already addressed some of the questions for transitional pain services. Anyone wants to ask anything before I start reading the questions from the chat? Right, there was a question for Dr. Balaji from Dr. Raina again. I have to find it.
There are quite a lot of questions. I think I went through that one.
Yes.
I think,
yes.
Anju, first and foremost, I would like to apologize to all the delegates, and this is one of the problem with the online one. Okay, and I really liked one of the comments they told that because I'm moving off track of the regional one, Jacob sabotaged, and he might have sabotaged. I don't know. I'm just joking. Okay,
you'll never know.
But the whole idea today is we need to focus where we can help out with it. I know even though we moved out of regional anesthesia, but it is a perioperative care, and the focus and other things are important. So that's what I want to put it across. And Anju, the first question she asked was ropivacaine. Ropivacaine, whether we can use it intrathecally, that is still a debatable one. The reason why we are not keen to do ropivacaine intrathecally is because of the differential blockade, and also what is the effect it can provide. But I was surprised when I did the literature search. All the 18 articles, there were 10 articles they have used ropivacaine, and they have all told that it works very well. So I think even if the hole is there and the seepage is happening, and the block is caused by a seepage of ropivacaine through that one, it works. So that is one thing which I thought I will highlight to that one. And then next one, I was really overwhelmed with the response to say that everyone are going to use duropuncture epidural, which is a very good thing from pre to post. And also quite a few people thought about ultrasound for gastric fluid measurement. Now, but there are many who asked, were very much concerned, what is the purpose of it? Now, there are many cases like they might be a grade 2 or some sort of C-section where the patient could have had something to eat, and the surgeon might be saying, oh, we need to carry on doing it or something. So in those cases where if you think there's a time, the ultrasound might be a tool for you to look whether there is gastric emptying, which has worked very well, and there's no fluid, no solid material there. Okay, I'm more than happy to carry on with it. I know it's 6 hours fasting, and we all know that there is a delayed gastric emptying and obstetrics, but not necessarily it has to work like that. The patient might be having a proper gastric emptying as well. And just because they had some apple juice or something and delaying 6 hours will not help. At least you can use that tool and see and do it. It's not going to be a very helpful in emergency situation, which I agree on it, but Gadas, he asked that one. And it's not going to change our practice, but at least if you know there's a full amount, you can document that one. And at least if the patient aspirated, you can say that the patient stomach was full, you have documented that one, and it works out. So it takes only 2 or 3 minutes, and if you have time to do it, even in real emergency, if you can scan it, okay, and document that the patient had full stomach, you do the rapid sequence, because rapid sequence is not a full proof for you to say that the patient cannot aspirate or not. At least you documented that one, and you can say, I did rapid sequence, the patient aspirated, I can't do anything. So at least you have that evidence there, and you can say that's a grade 1 section, I did it. So that in that way, for medical legal aspect as well, it will be very helpful. And there was no question about the tab block or quadratus lumborum or rectus spinal block, I think. Is there anything there?
There's one in my head. So with the data coming on the superiority of the QL block, do you think that should be our first line block we should be teaching to the trainees then? Because it's not a plan A block and it's certainly more technically difficult.
I would say that we need to advocate quadratus lumborum because that is working very well when compared to tab block. Because when you try to come for anterior and lateral, because the spinal nerve, they start to divide into anterior and lateral and you have a potential to miss it. And quadratus lumborum, they work very well. It's a pain that we need to put the patient on a lateral position to do it, but at least the patient will get a good benefit after following that. And yeah, definitely I will agree that we need to start teaching the trainees the QL block because it's been mentioned in the OAA website itself that rather than lateral approach, they are advising for posterior approach now. And that is what we need to be heading for.
Yeah, and the posterior approach is just a few centimeters away from the QL anyways, isn't it?
Yeah.
Very much the same block. It's a continuum of
same thing,
space.
Yeah. So I think it's an era now where we need to think about QL blocks and ESPN blocks and work it out. Yeah, and I use for all spine surgery the ESPN block. It does a very good trick there, definitely.
Yes, and there was a praise trial recently, which unfortunately was cancelled, so we won't see the results of that. But it was promising to use ESP block for spines.
It might be because it's going very close to the paravertebral area, but I don't know. ESPN block does good trick there.
Yeah, that's one of the suggested mechanisms of action, I believe. Mustafa has asked a couple of questions from Babette. Just to introduce Mustafa, Mustafa is one of our pediatric anesthetists in Hull. And he was asking about the practice in interestingly, he's asking about the practice in Netherlands, but I think if you can tell us about the practice in Belgium, Babette, that would be great. If there are any different pediatric blocks which compared to UK.
Well, I actually think that especially Older Hay was actually farther along in pediatric regional anesthesia than in Belgium. I quite need to advocate a little bit in Belgium for my colleagues to do it more. But if you're looking at the common blocks in children, I'm going to say we have kind of tried to go away from central blocks as much as we can. I do appreciate caudal and epidurals will still have their use, but you've seen quite an interesting shift in the hospital that go from we do a lot of lateral QLs in our day case patients, a lot of anterior QLs now, especially for unilateral hip surgery, proximal femur surgery. They all get anterior QL blocks now. And I would say on thoracic level or upper abdominal, we tend to do a lot of paravertebrals now. All our cardiac patients also get paravertebrals. But yeah, I think we do a lot of different blocks. Everything we can block, we will block.
Sounds very good. And Mustafa has followed with a second question. He was asking about your experience how to handle regional anesthesia consent in pediatrics. But do you find it more challenging than with adults?
I actually find it easier. I find it easier because I feel when you go to adults and trying to sell regional blocks, often is the discussion, do you want to be awake for this surgery and have it on the regional, or do you want to sleep? And then often it's not regional in adults. I find in children, what you're offering is besides the general anesthesia, you can still tell them like your child will not feel anything, the operation, I'll be with them, like the whole kind of trying to comfort them, like the parents and the children, like you'll have general anesthesia. But on top of that, you can actually offer them something that will help them in the post-operative period. They'll wake up nicer. So I actually find that taking consent for regional blocks in children is very easy because the parents really want what's best for your child. And if you come there with the idea that what I can offer this regional anesthesia is going to be of huge benefit for that child, you won't have a lot of parents trying to dissuade you of doing that. So I actually find it easier.
That's very encouraging. Thank you. And I also particularly liked your mention of tunneling. I can't highlight enough tunneling even for the adults because as opposed to what you normally said, some adults are just bigger children and they will pull on anything you put into them. So unless you tunnel it, it's going to come out. Any other questions here for either Babette or Dr. Sanem or Balaji or myself. Right. I had one more question for Dr. Balaji, actually. He showed you showed the meta-analysis comparing DPE versus epidural. There was a crucial piece of information which I was missing, and it was the incidence of PDPH in those two groups. Is it something the meta-analysis looked into?
Unfortunately, they didn't look into that data. They clearly mentioned that one. That was one of the drawback or limitation of the trial. So they didn't look into the timing of epidural. They found that was a limitation. They didn't look into other complication because not many trials have shown that one. So they have to take it out. And the secondary outcome, they focus only on hypotension because that was present in all the 18 trials or whatever may be there. So that was that. So they just looked into the data. That's all. So they didn't look into the PDPH. They didn't look into the risk of infection. So these are all something for in future to look into it. But this is the first meta-analysis that came out on a very good number of patch ones. That's the advantage with it.
Right. And so do you think we should start using dural puncture epidural more routinely now?
It looks like the evidence is coming out. If you could have asked me in 2020, I could have been worried about that one. I could have been skeptical about that one. This topic, for example, was started by my colleague, Sarah Price. She was very keen on it because this is coming up quite frequently. And definitely now all evidence are showing that it's very helpful. I think it's a time to look into it because the unilateral block and the sacral sparring is a real concern with epidural. And because I can't do CSE, still we can do CSE. It's not that, but we are going to have a profound motor block. But in this one, it's not going to be a profound motor block. But you can still get away the sacral sparring and the unilateral block. Yes, there is a theoretic that we are breaching the dura just like that. But still, if I do CSE, I'm still going to breach the dura. That's what I will flip the coin and put it across.
Yeah. So before rolling it out routinely and teaching all the trainees to do DPEs, would you want to wait for more data about PDPH first?
No, I think 2,144 is a good number. I think with the needle what we use 25 or 27, the risk is going to be very, very minimal because we do a lot of spinals left, right, and center. And if you see the incidence is probably 0.01% to 0.1%. So I think it's not going to increase it significantly more. That's what my understanding. Yeah.
Dr. Salam has a question.
Sorry, it's not a question. I thought I'll talk a little bit about a pilot project which we are planning.
Yeah, go ahead.
At our hospital, in our trust. Essentially, when I'm talking about transitional pain services here, you did ask, like, okay, how are you going to translate the information what we have into practice? So we are planning a pilot project, mainly looking at hip and knee arthroplasty, since we are like doing ERAS and also day care procedures. We are kind of planning to implement a transitional pain services by involving our clinical psychologists, acute pain team, and probably enthusiastic trainees, and then start screening some of the patients. I mean, we can look at the retrospective data on what is a chronic post-surgical pain currently from the previous hip and knee replacements we have. And going forward, we are planning to kind of implement what we call it as an explain pain program through psychologists delivered by acute pain nurses and psychologists to the high-risk patients, and then follow them up post-discharge, probably enthusiastic. We are planning to have trainees involved in it and see if we can find any difference between this group, the interventional group, that is TPS group, to that of a retrospective data available already. So this is something which we are going to plan this year, in next 6 months, actually. So I thought I'll let you know. We are doing something about it.
That sounds very exciting, and I'm looking forward to seeing it on the floor.
Thank you.
Right. Any other questions before we conclude this session? And it looks like we have exhausted ourselves. So that brings us to the end of the whole webinar. Before we finish, let me please thank you to all the presenters and to Ezra for putting up this amazing networking and sharing platform for us. Ezra is really reaching beyond Europe and is becoming a very welcoming and global society. And I'm very grateful that it prepares these opportunities where we can meet and share our experience. Thank you to all the presenters that they found free time to present on Saturday, which here has been one of the first sunny Saturdays in this year. And yet we are still meeting here over an online webinar discussing work. That's, I think, very showing a great dedication to regional anesthesia and pain medicine. And thank you all the delegates who dedicated your time in attending this session. I have put up a QR code here. If you can give us your feedback, we will take it seriously, I promise. And we will try to bring this forward in upcoming years. So thank you very much again for joining us. And
Jacob, can I add something? Yeah.
Yes.
As a co-organizer, thank you very much, everyone, and also the delegates and the speakers, and taking your time on a weekend to do this one. I'm pretty sure this is live and it's been recorded in the YouTube, and it will be a fantastic thing which if people wants to have it, you can look into that one. Just click it and you can have a look. And all other meeting also is recorded. You can see how it's been done in other places, and you can compare and see and take the valuable points from each and every meeting that has happened in other parts of the world, but particularly today. It's all compared into the YouTube. And I would like to thank Jacob as well, who has done a great job in getting this one organized. Thank you very much, Jacob. And thank you very much, everyone, and enjoy the weekend.
Thank you, Balaji. I've posted a link to the YouTube channel, and on Ezra channel, you can find the streams from all over the world as well, if you want to spend your Sunday with regional anesthesia as well. Thank you.